Hello guys, can you hear me? Good morning guys. Good morning everyone. Good morning. So have you revised cardiovascular physiology? Yesterday's class we have completed gastrointestinal, we have completed the cardiovascular system, and we have started with the respiratory, right? Now have you revised cardiovascular system? S1, S2, S3 heart sounds, jugular venous pressures, okay, abnormal waves. Have you discussed about the left ventricular pressure volume loops, concepts of preload and afterload, okay? And the antiarrhythmic drug classes, Vaughan-Williams classification. So all these things you have to revise again and again. The central venous pressures, the clotting factors like the clotting cascade, the hemodynamics, the Poiseuille-Higgins formula, fixed principle, Frank-Starling's law, cardiac reflexes like brain bridge reflex, okay, Cushing's reflex, Bezold-Janisch reflex. Okay, these are the important topics which you need to revise again and again and again till the time of your exam. Okay, for every 1 week you have to revise physiology once, otherwise you will forget. But don't worry, physiology is a very easy subject. Like, the most of the time, the questions that will be coming 80% of the time, 80% of the questions will be easy questions only. Okay. Don't worry about that. So having said that, shall we start? Share the screen. 3, 2, 1. Okay. So now in this first half of today, we have to do the respiratory physiology. We have to complete the respiratory physiology. And in the next half, in the afternoon session, like the 2 to 7 o'clock, 2 to 3, 3 to 4, 4 to 5, 5 to 6, 6 to 7, those 5 hours, we have to do the renal. We have to do the renal. So today we have to complete the respiratory and we have to do the renal. That's the target for today. So now in the beginning itself, I'm telling you the respiratory, we are left with 10 topics. Okay, we are left with 10 small topics. Okay, so we have to do those 10 topics in the respiratory system. Are they big topics? Or no, they're all concepts, small concepts. So in the morning half, we have to complete the respiratory. Okay, and these 10 topics, are they important? Yes. For example, in one session, for example, like the last FMG exam, the 20 days back, whatever the FMG exam happened, question came from these 10 topics only. Do you know what is that question which was asked? The spirometry curves. Okay, that's the question which was asked. And the last FMG exam, the June attempt, question also came from these 10 topics. The question was oxygen hemoglobin association dissociation curve. Okay, so something like that. Without any further late, okay, let's start the class. So in yesterday's class, we have discussed till where? We have discussed till the compliance curves. Okay, we have discussed till these curves, right? Now, after this, the next topic here. Just wait one second. Let me add one more thing. What? It's not coming. Just give me 1 minute, guys. Okay, okay, done. So let's begin today's class. Now the topic which I am going to start, the first topic, okay, today that I am going to discuss, the first topic that I am going to discuss here is the lung volumes and capacities. Okay, lung volumes and capacities, and you already know it. Most of you guys have gone through this lung volumes and capacities even in your class 7th and 12th. So first, what is this volume? Tidal volume. So what is this tidal volume, sir? Tidal volume means the normal amount of air that will go in and out. Okay, see how much you inspire with one breath. With one breath, how much you inspire, and with one breath, how much you expire is called as the tidal volume. What is the one single value which you have to know? 500 ml. Okay, 500 ml. The explanation was anyway given over here. You can go through that later. Array, what exactly is tidal volume? How much you take in and how much you exhale out. Okay, how much you take in and how much you exhale out with one breath of 500 ml air. Okay, you will take 500 ml of air into your lungs and you will take 500 ml of air out of your lungs. That's the tidal volume. Now, what is the inspiratory reserve volume? Inspiratory reserve volume means, see, normally how much you can take? 500, you can take 500 ml. But if I ask you, you can take extra air into your lungs. Okay, you can take extra air into your lungs. So that extra air is called as inspiratory reserve volume. How much is that value? 3000. Remember, 3000. That is the extra. That extra. This is extra. Okay, this is the tidal volume. But this is extra what you can take. Your ability to take extra. For example, look, imagine you are going to take a dive into the river. Okay, you are going to take a dive into the river. Now, before taking a dive into the river, you have to take some extra air. You have to take some extra air. That extra air is called as the inspiratory reserve volume. And how much is that value? 3000. And what is the tidal volume? 500. You might think that, so these are all silly things. We already know it. But this is what the question which was asked in the recent FMG exam. 20 days back, this is what exam question which was asked. Okay, I will tell you what is the question, but just wait. Next, sir, what is expiratory reserve volume? Expiratory reserve volume means, see, normally how much you will take out? Sir, 500 ml of air you will take out during expiration. How much air will come out? 500 ml. But if I ask you, you can take some extra air out of your lungs. Okay, you can take extra air out of your lungs. For example, when you are inflating the balloons. Okay, you are inflating the balloons. What you will do? You will take extra air out of your lungs. Or when you are playing flute or trumpets. Okay, trumpet players. What they will do? They will take extra air out of their lungs. So that extra air, how much you can take extra? 1200 ml. You can take 1200 ml extra air out of your lungs. That is called as expiratory reserve volume. Okay, so expiratory reserve volume value is how much? 1200. Inspiratory reserve volume 3000. Okay. Now, whatever you do, okay, how much ever you try, you can't take this air out of your lung. Okay, what is that air? Residual volume. You do whatever you want, you can't take residual volume out of your lungs. And how much is that value? 1300 ml. Okay. So, for example, I'm asking you. See, for example, who is the student active today? Let me see the student. So Satish Kumar, for example, Satish is there. I'm asking Satish, Satish, will you please do something to take the residual volume out of my lungs? What you will do? See, if you want to remove the residual volume out of my lungs, what do you have to do? Yeah, Abra, good morning. If you want to remove the residual volume out of my lungs, what do you have to do? You can't remove it. You have to kill me. You have to kill me and you have to take my lungs out. You have to squeeze my lungs out. Okay, then only it will come. So residual volume is the air that will never come out of my lungs. It will never come out of my lungs. So how much is that? 1300 ml is always there. So values is important. Tidal volume 500, inspiratory reserve volume 3000, expiratory reserve volume 1200, and the residual volume is 1300 ml. Okay, these are the points. Now, if you add these volumes, okay, if you add volumes, that will give you capacities. Now, look at here. These are the lung capacities. Lung capacities. What are capacities? Capacities are sum of volumes. Okay, sum means add up. Okay, summing means adding, right? So if you add 2 or more volumes, you will get capacities. So what are these capacities, sir? For example, I am asking you, what is your inspiratory capacity? Okay, what is your inspiratory capacity? So what is inspiratory capacity means? Inspiratory capacity means your capacity of inspiration. How much air you can take in? How much air you can take in? That is, you can take first tidal volume, 500 ml. You can take 500 ml. Along with that, you can also take inspiratory reserve volume. That is 500 ml plus 3000. How much it will be? 3500 ml. So your capacity of inspiration, how much you can take maximum, air from rest. See, from rest you can take first tidal volume, along with that inspiratory reserve volume. The value is 3500. Important, remember it. Okay, they will ask the values also. Direct values can also be asked in the exam, tested in the exam. Okay, next, what is functional residual volume? Okay, what is functional residual volume? It is the sum of residual volume. Okay, residual volume always there inside your lungs. How much is that? 1300 ml plus expiratory reserve volume. If you try, it will come out. How much is that? 1200 ml. How much is that? 2500. Okay. So this is a functional residual capacity. Functional residual capacity means, look at me, guys. Look at me. Functional residual capacity means simple. When you are at rest, say I'm at rest right now. I'm not inspiring, I'm not expiring. Simple. I'm not inspiring, I'm not expiring. I'm like this. See, how much air is there inside my lungs? Residual volume is there, and expiratory reserve volume is also there. See, I'm at rest like this. But if you ask me, I can take air out of my lungs. Look at me. Inspiration, expiration, completed. Now I'm at rest. How much air is there inside my lungs? Expiratory reserve volume is there. See, I can take out. Expiratory reserve volume is there, and also residual volume is there. So that is functional residual capacity, means the amount of air that is present inside your lungs at rest. Okay, the amount of air that is present in your lungs after normal expiration. See, after normal expiration, how much air is there inside your lungs? That is the functional residual capacity. Okay, so let me write here. Right, you also write this. Amount of air present in lungs after, this is a question which was asked, air present in lungs after normal, not forceful, after normal expiration. Okay, so how much is there? 2500 ml of air is there. Functional residual capacity 2500. Right, next. So what is vital capacity? Okay, what is vital capacity? Okay, this is a small mistake, typing mistake over here, but I will correct it later. So what is vital capacity, sir? Vital capacity is, okay, see, after taking deep inspiration, see, okay, after taking deep inspiration, first what you have to do, look at me, you take deep inspiration, as much amount of air as possible. Okay, look at me, what I'm doing. First, what I'm taking, tidal volume, inspiratory reserve volume. Okay, now I have taken tidal volume and inspiratory reserve volume. After having the deep inspiration, how much air you can take out of your lungs? How much air you can take out of your lungs? Okay, how much air you can take out of your lungs? Look at me. Tidal volume, inspiratory reserve volume. Now I have to exhale. See, I'm taking out inspiratory reserve volume. I'm taking out tidal volume. I can take out even expiratory reserve volume. You understand? Okay, let me draw it and show you. Sir, what is vital capacity? Vital capacity may, first you have to do the deep inspiration. Do deep inspiration. Deep inspiration. When you are doing deep inspiration, what you will take first? Tidal volume plus you will take inspiratory reserve volume. Inspiratory reserve volume. Okay. Now, when you are exhaling, when you are trying, now you have to exhale. When you are exhaling, first what will come out? First inspiratory reserve volume, that will come out. Later, you will remove the tidal volume. And if you try, you can also remove the expiratory reserve volume. Okay. So inspiratory reserve volume, you can take out first. That 3000, it will coming out. Later on, that 500 ml tidal volume will come out. And expiratory reserve volume, even this 1200 ml will come out. If you add this, that will be 4700 ml. Okay. Your vital capacity means the amount, the total amount of air that will come out. That amount of air you can take out of your lungs. After taking maximum inspiration, how much air you can take out of your lungs? 4700. It is a sum of what? It is a sum of inspiratory reserve volume, tidal volume, and expiratory reserve volume. So right here, it is the sum of inspiratory reserve volume plus tidal volume plus expiratory reserve volume. So this is your vital capacity. How much is that? It is approximately 5 liters. For understanding purpose, easy understanding purpose, let's remember it's somewhere around 5 liters. 4000 ml It's near to 5 liters, right? Done, simple. Simple. Okay, it's approximately 5 liters. Next, so what is the total lung capacity? So total lung capacity is the sum of all volumes. Okay, total lung capacity is the sum of all volumes. Add all 4 volumes: inspiratory reserve volume, tidal volume, and expiratory reserve volume along with residual volume. If you add all volumes, it will be 5,900 or approximately 6 liters. Means this much amount of air can be there inside your lungs. 6 liters of air can be present inside your lungs. Out of that 6 liters, if you try, how much you can take out? Almost near to 5 liters. Okay, so this is what I want you to know. Array, in your lungs, you can store how much amount of air? 6 liters. If you try, how much you can come out? 5 liters can come out. Okay, so that's it. So lung volumes and capacities completed. Lung volumes and capacities completed. Now, what is, see, this is a previous year question. Actually, this is, I think, this is the question which was asked in 2020. One, I think. Just let me show you. This is the question which was asked in the 2021. Okay. Okay, this is the question which was asked in the 2021. Now, what was the question is, they have asked this, what is this area? They have asked something like this. They gave this spirometry graph. Okay, they gave this spirometry graph and they have asked this. What is this area? Okay, what I am showing here. Let me tell you how to understand this spirometry graph. It's very simple. Now you are taking 500 ml of air into your lungs, taking out 500 ml. So this is the tidal volume. Okay, 500 ml you take in, 500 ml you take out. 500 ml you are taking in, 500 ml you are taking out. So this is what tidal volume. These curves which I am showing here. These are the what? These are the tidal volumes. See, again you are taking 500 ml in. This is the tidal volume. But if I ask you, you can take some extra air into your lungs. You can take extra air into your lungs. So this curve which I am showing to the top. Okay, what is this one? This is inspiratory reserve volume. This is the inspiratory reserve volume. Okay, and inspiratory reserve volume can come out again. Okay, this is the inspiratory reserve volume, the top. How much is this inspiratory reserve volume? 3000 ml. Okay, you know it. And again, tidal volume is coming out. This is the tidal volume. Okay, let me take the black color again. So again, this is the tidal volume. You are removing the tidal volume. But if I ask you, you can take some extra air out of your lungs. See, you can take some extra air out of your lungs. So what is this curve which I am showing in the bottom? So this is the expiratory reserve volume. Expiratory reserve volume means till here to here. This is expiratory reserve volume. ERV. That red color thing is the ERV, expiratory reserve volume. Okay. Now, whatever you do, certain amount of air is always present in the lungs. Okay, what is that? This down thing is the residual volume. Okay, the down thing is the residual volume. Okay, 1300 ml is always present inside your lungs. It will never come out. Okay, 1300 ml. And what is the expiratory reserve volume? Expiratory reserve volume I have given 1200 ml. Okay, 1200 ml. So now, what is this marked area? I have given this black color. What is this marked area? Total. This marked area mein expiratory reserve volume is there plus residual volume is there. So what is this? If you add expiratory reserve volume plus residual volume, expiratory reserve volume and residual volume, what it will give you? Okay. So this down thing, this total area is functional residual capacity. Functional residual capacity. Okay, functional residual capacity. Now, one more thing, one more capacity I'm talking here. See, if I'm starting from here, okay, starting from the top and till here, what is this capacity? Anyone can tell me what is this green color thing? Anyone can tell me what is this green color area from here? For example, from here, starting from here till to here. Which means tidal volume plus inspiratory reserve volume. If you sum up, that will give you, if you add this to it, will give you inspiratory capacity. Okay, inspiratory capacity. Okay. Now, one more capacity I'm talking here. One more capacity is starting from here. Okay. And I'm extending till here. What is this? Okay, let me take some other color. It is confusing. Okay, let me take pink. Okay, starting from here. Okay, let me see who can answer. Abra, Satish, or some other. Student, so now you tell me what is this pink color thing, which includes inspiratory reserve volume, also including the tidal volume and expiratory reserve volume. What is this area which I'm highlighting here? That's the vital capacity. Excellent, guys. Roshni, Iqbal, Maria, Vishnu, yeah, you're all true. Subhatra, Krishna, yes. Abra, yeah, Satish, you're all true. Vishnu, yeah. So a lot of good students are there. Okay, Pranati, yeah. It is vital capacity. Okay, so such kind of questions can show up in your exam. So the identify the marked area and the spirometry graph, you know it. Now it is X area, it's functional residual capacity. Done. Okay, so this is the same question. Okay, let me show you what was the recent. I just forgot what was the recent question which was asked. Okay, let me show you directly. I have saved everything in my mobile. Just yeah, let me show you. I hope you can see me. So they have given in the recent FMG exam. In the recent FMG exam, okay, what this the graph is called as a spirometry graph. In the recent FMG exam, this is the question which was asked. They gave the same spirometry graph and they have asked about the point F. See, point F, you know about the point F. You tell me what is the point F, the topmost point, point F. Point F. So point F, okay, it's necessary. Like, you can't see. The recent FMG exam, what they have asked is the vital capacity. Okay, they have asked this one, the pink color one. So they have marked from here till here. Okay, and they have asked what is this? It's the vital capacity in the recent FMG exam 20 days back. Okay. Now, okay, let me check. Who can answer this? Who can answer this? This is a spirometry graph. Okay, this is a spirometry graph. These are the tidal volumes. Now, you tell me what is this area which I'm highlighting? From here till here. For example, say, now I'm asking, what is this area that I have highlighted? What is this area that I have highlighted? The blue color thing. So the blue color thing, it is including tidal volume, you know it, tidal volume, inspiration, expiration. Say inspiration, expiration, tidal volume. Plus, if you try, you can take some extra air out of your lungs. So this is expiratory reserve volume. Okay. So this blue color thing, it includes tidal volume plus expiratory reserve volume. So what is this? This is expiratory reserve volume. Expiratory reserve volume, 1200 ml. Okay. So such kind of questions can be asked in your tested in your exam. Okay, done. Okay, done. Now, some direct single liner questions which I want you to know. These are single liners. Volumes and capacities that cannot be measured via spirometry. Okay, spirometry is a test. Okay, it's a test. Spirometry is a test, and you will get the graph, spirometry graphs. See, which volume cannot be measured? Residual volume cannot be measured because it will never come out of your lungs. Okay, spirometry, if you are doing spirometry test, first of all, residual volume will never come out of your lungs. So you can't measure residual volume via the study. Via spirometry, you can't measure this. If you can't measure residual volume, automatically functional residual capacity cannot be measured. Why? Because functional residual capacity is the sum of expiratory reserve volume plus residual volume. Without knowing residual volume, how can you calculate functional residual capacity? Right? So that's the answer. Next, total lung capacity. Total lung capacity, it's the sum of inspiratory reserve volume, tidal volume plus expiratory reserve volume plus residual volume. If you don't know residual volume, you cannot calculate the total lung capacity via spirometry. So this residual volume, FRC, functional residual capacity, and total lung capacity, they are not measured via spirometry. If they are not measured via spirometry, then how to measure them? They are measured with other studies. What are the methods to measure FRC, functional residual capacity? Okay, this was the recent question which was asked. There is a best study called as body plethysmography. Okay, this is a body you know plethysmograph, right? You just search what is plethysmograph, you will get the monitor kind of thing. that the body plethysmography is the study which is used to measure FRC. And nitrogen washout, okay, nitrogen washout technique and helium dilution technique. Helium dilution technique or helium dilution method, nitrogen washout and body plethysmography, these are the studies which are used by the, like, the physiologists. They don't have any work, okay? So they will be doing all these studies to calculate the functional residual capacity, okay? Not only for functional residual capacity, for also the other things, okay? Residual volume also, okay? So that's the thing. Body plethysmography is the best MCQ which was tested. Done. The topic is completed. Topic is completed. Next. So flow volume loops. Okay. Flow volume, not capacities, flow volume loops. Here is the heading, flow volume loop. Guys, this topic is very, very important. For what? For understanding the medicine. In medicine, you will be discussing, in medicine and pathology, you will be taught there are two types of respiratory diseases, like obstructive lung diseases and restrictive lung diseases, OLDs and RLDs. So how to understand these OLDs and RLDs, obstructive lung diseases and restrictive lung diseases? How to understand? For understanding that OLDs and RLDs, this flow volume loop is the basic thing. Basic thing. It's very easy. Don't think too much about it. Don't think too much about it. It's very easy. Please be attentive. Okay. So first, let me check myself. Is everything clear or not? Let me get the clarity. Everything clear, right? Okay, it's clear. Done. Chalo. Now, look. On x-axis. This is the x-axis. First, always check the x-axis. On x-axis, what I'm talking about? I'm talking about some volumes. Which volume? How much volume of air is there in the lungs? Okay, how much amount of volume of air is there in the lungs? 0 liter, 1 liter, 2 liter, 3 liter, 4 liter, 5 liters, and maximum how much? Total lung capacity, 6 liters. Total lung capacity, 6 liters. Okay, on x-axis, I'm talking about the volumes. On y-axis, what I'm talking about? I'm talking about the flow. Flow means with how much speed air enters into the lungs, and with how much speed means how much velocity air exits out of the lung. Okay. So 1 liter per second, 2 liters per second, 3 liters per second, 6 liters per second, 8 liters per second means velocity, the velocity by which air comes in and air goes out. Okay. Here also same thing, 2 liters per second, 4 liters per second, something like that. So x-axis, y-axis, I have explained you. Now, see, I'm taking a person. I'm taking a person, healthy person. He's a healthy person. I'm taking a healthy person. Okay. Now, I have asked him to take air as much as possible and as fast as possible. First thing, I'm asking him to do inspiration. Inspiration. Breathing mein inspiration hai and expiration hai, right? Two things are there, inspiration, expiration. First thing, I'm asking him to take air as much as possible and as fast as possible. So what he's doing, he's starting the inspiration, Now he have started the inspiration here. Okay. Now he's starting the inspiration here, not at zero. Why? Why? Because you already know there is some air already there inside the lungs. Residual volume is always there inside the lungs. So that's why he's starting his inspiration at 1.3 liters, 1.3 liters, because almost 1.3 liters residual volume is there inside the lungs. So he's starting the inspiration. See, now, see, okay, let me ask you one thing. Imagine you are having a bike, for example, Ninja bike, okay, Kawasaki bike. Do you think that bike will take the velocity directly to 100? If you raise the speed, do you think it will go directly to the 100? No, it have to start from zero. And it will go 0, 10, 50, 100, right? In the same way, inspiration also with zero velocity. This is zero. Here, zero means it has started from zero. And see, the velocity by which the air enters into the lung is increasing. So air is coming into the lungs And how much air you have taken maximum? You have taken 6 liters of air. Now in your lungs, how much air is there? 6 liters of air is there. Okay. So this is the peak velocity. No one will ask you about that value. Okay. Inspiration ho gaya. Okay. So you are taking air. Okay. So initially the speed is increasing. Initially the speed is increasing. Look, you are doing the inspiration. When you are doing the inspiration, initially the speed is increasing. Okay. Look at me. Look at my face. Look at my face, sir. Look at me. See. Initially speed is increasing, but look at the end of my inspiration. At the end, air is not going in. Means at the end, the velocity by which the air enters into the lung decreases. So initially increases, later decreases. So at the end, how much you take? Total lung capacity 6 liters. Where you have begun at 1.3 liters. Okay. So here in the downside, I'm talking about the inspiration. Okay, this is called the inspiratory loop. And this is also the question which was asked in the recent FMG exam in medicine. Medicine में एक question आया sir. Okay, if there is any repeater, they can confirm this. This is the question which was asked. Okay. Next. After that, I'm asking this person to do the expiration fastly, as fast as possible. So see, he is doing the expiration. He has started the expiration. Now let me show it in the red color. He has started the expiration, means very fastly he's trying to do the exhalation with 8 liters per second. Values are not needed. And he's exhaling. And again, he's coming back to 1.3 liters. Again, he have done the expiration completely. He have taken the air as much as possible, as forceful as possible. He have removed the air. And again, he's coming back to residual volume. Starting residual volume, ending also residual volume. Okay. So on the top, I am talking about the expiration. In the below, I am discussing about the inspiration. This is the basic thing I want you to know. Starting point is the residual volume. Ending point is the total lung capacity. Total lung capacity is 6 liters. Residual volume is 1.3 liters. Okay. Done, sir. Now, if you understand this, now I will tell you a basic thing about OLDs, obstructive lung diseases, and restrictive lung diseases, or LDs. Obstructive lung diseases ka best example is emphysema. Apart from emphysema, you can also write bronchitis. Okay. Bronchitis, chronic bronchitis, asthma. Okay, something like that. These are all the obstructive lung diseases. Okay. Emphysema, bronchitis, asthma. What is the main problem in obstructive lung disease? Are emphysema ka main problem kya hai? Sir, emphysema, I have already told you in yesterday's class. Emphysema mein what happens is the elastin fibers in your lungs are damaged. In yesterday's class, I have told you in emphysema patients, elastin fibers are damaged. So if elastin fibers are damaged, means elastic recoil. Okay, so the elasticity decreases, elastic recoil. Lungs are not collapsing, lungs are not undergoing recoil. So elastic recoil kam ho gaya. Look at me, sir. Normally during inspiration, what should happen? During inspiration, lungs should stretch, and during expiration, lungs should recoil. So now lungs are not collapsing, lungs are not undergoing recoil. So expiration will happen. Do you think air will come out easily? No, because lungs are not collapsing. The lungs have to collapse and push the air out. Lungs have to push the air out. Now lungs are not collapsing easily. Now the elastic recoil kam ho gaya. So it's an expiratory problem. So emphysema is expiratory problem. Remember, emphysema, elastic recoil decrease. So expiratory problem. So all E. So emphysema mein elastic recoil kam ho gaya. So the problem is with the expiration. So air is not coming out. Okay. The air is not coming out. So where the air is getting accumulated? Air is accumulating inside the lungs. So there is air trapping inside the lungs. Okay. Air easily not coming out of the lungs. Air is trapping. So now tell me, if the air is trapping inside the lungs, you will have big lungs or small lungs? So you are going to have big lungs. Okay, bada lungs, big lungs. So because the patient is having big lungs, okay, big lungs, is having very big lungs. So what about his chest? If you look at his chest is going to be also big. So that chest is called as, because of the big lungs, the patient is going to have which kind of chest? Anyone? Emphysema patients, they will be having barrel shaped chest. Okay. So barrel shaped chest, the patient with the emphysema, with obstructive lung diseases are going to have big lungs, and they are going to have barrel shaped chest, like a barrel. Okay, big drum, barrel shaped chest. You know the oil barrels, right? The drums which we have the oil containers, the crude oil containers. There's the barrel shaped chest. Okay. Now tell me, sir, if you are having so much amount of air in the lungs, if I try to do the examination by percussion, if I try to do the percussion, look at this. If I try to do the percussion, I feel like I'm beating on the drums because more air is there. So more sound will come. Okay. In the drum, if you beat, more sound will come. Now also your lungs are not lungs but drums. There is more air is there. So whenever you try to do the percussion, there will be hyper resonance. Exactly, Subhatra, there will be hyper resonance. The patient with emphysema is going to have hyper resonance. Hyper resonance is going to be seen. And the last keyword about the obstructive lung disease is, sir, there is so much air in the lungs. So what happened to volumes and capacities? What happened to volumes and capacities? Lungs are big lungs. There is extra air that is accumulating inside the lungs. So what happened to lung volumes and capacities? So right, lung volumes and capacities increases. So lung volumes and capacities are going to be more than normal person. When compared to the normal person, the lung volumes and capacities are going to be more. Okay, so that's why now let me show you the flow volume loop. Look, now I'm showing you obstructive lung disease. What is example? Emphysema. In emphysema, you know, all lung volumes and capacities are increased. So that's why in emphysema patient, look, if I draw the flow volume loop, see what happens. He's starting his inspiration here. Now this fellow, look, he's starting his inspiration from where? From 2.5 liters. Instead of starting at 1.3 liters, he's starting at 2.5 liters, which means what happened to his residual volume? Increased. Yes, in obstructive lung diseases, residual volume increases. And what happened to his total lung capacity? His total lung capacity is increased, maybe 8 liters. Okay. Now because of the air trapping, his total lung capacity is now 8 liters. Okay. So now where the graph is shifting? Okay, where the graph is shifting? The graph is shifting towards left side. This is left side, right? Okay, so the graph is shifting towards left side. Okay, the flow volume loop is shifting towards the left side. Simple. Always look for these two things. Residual volume is going to be more. Total lung capacity is also going to be more. And the graph is shifting towards left. Okay, in obstructive lung diseases, the graph shift to left. Okay, the graph shift to left. Okay, and in your pathology, you will know, sir, the patients, like, no, here there will be like a coving, they're scooping. Okay, in expiratory limb, there is something called as coving pattern. Okay, for example, imagine if you are taking a scoop out of ice cream. Okay, there is ice cream cup. Okay, here is ice cream, and if you take a scoop, how it will look? Okay, just let me show you. So now you have taken with a spoon, you have taken a scoop. Now there is a cove, right? Coving. Okay, so same pattern will be seen, and you will study that in your patho, why there is that coving pattern. Okay, so there is coving pattern. Okay, this is normal. Okay, look at normal. Look, in the normal, there is no such thing as coving. That coving pattern is seen in obstructive lung diseases, and there will be left shift. Done. So what are the important points? Repeat after me. Obstructive lung diseases example is emphysema. Main problem is with the expiratory problem, air trapping, bigger lungs, barrel shaped chest, hyper resonance, lung volumes and capacities increases, more residual volume, more total lung capacity, left side shift, coving pattern. Done. Done. Okay. Now, next is restrictive lung disease. Okay. Next is what? It's a restrictive lung disease, RLD. So, a restrictive lung disease, the main example is pulmonary fibrosis. Lungs are getting fibrotic. Lungs are getting, and the alveolus, for example, say this is the alveolus. What is happening to the alveolus? Let me draw the alveolus in a better way. So, how actually the alveolus looks like is like this. Okay, like a bunch of grapes. Now, this alveolus is getting fibrotic, total collagen deposition, idiopathic pulmonary fibrosis, silicosis, vicinosis, berylliosis, all these conditions may, what happens? There is fibrosis of the alveoli. Okay, sarcoidosis, the alveoli are getting fibrotic. Now, when the alveoli are getting fibrotic, what is the main problem? Now, fibrotic alveoli cannot stretch. Okay. Now, look at here. So, the main problem here is non-compliant alveoli, means alveoli are not stretching. If the alveoli are not expanding, the main problem is inspiration. Alveoli are not filling. There is a decreased filling. Okay, there is a decreased filling. So it's an inspiratory problem. Okay. Restrictive lung disease may inspiratory problem means air is not going in. So if enough amount of air is not going in, so what will happen to the lungs? They are small lungs. Okay, air is not going in, lungs are not expanding. So these lungs are smaller lungs. Okay, chota lungs. If there are chota lungs, what happens? Volumes and capacities decreases. Okay, volumes and capacities, what happens? Decreases. So residual volume will be less, total lung capacity will be less. True. So let me show you in the graph. Okay, Sir, this is my restrictive lung disease patient. Okay, see, the main problem is inspiration. See, air cannot get in. Okay, cannot get air in. Inspiratory problem. Okay, inspiratory problem. Now, I have told you how to identify this patient is having restrictive lung disease. Look, sir, here the patient is starting his inspiration at maybe 0.8, which means the residual volume is decreased. Okay, residual volume come ho gaya. And what about his total lung capacity? Total lung capacity was still 6, up to 6. It was supposed to be till 6. Now the patient is having a total lung capacity of maybe 4.8 liters, which means his total lung capacity decreased. His residual volume decreased. Okay. So now the curve is shifting towards right. Okay, the curve is shifting towards right because everything is getting lesser. Okay, everything is getting lesser. See, the curve was supposed to be till here, but the curve is shifting towards the right. Okay, so simply remember restrictive for right shift. Okay, so restrictive lung disease is right shift, obstructive lung disease is left shift. Okay, done. So in restrictive, volumes and capacities are decreased. In obstructive, volumes and capacities are increased. Okay, volumes and capacities are increased. So these are the points which I want you to know. Now look at this. This is normal, sir. Normal. Okay, normal flow volume loop. Inspiration here, down, inspiration, expiration, inspiratory limb, expiratory limb. Okay. Now total lung capacity is 6 liters and residual volume starting at 1.3 liters. Okay. But see, in obstructive lung disease, what is happening? Obstructive lung disease, this green color, obstructive lung disease. Okay, what is happening to the obstructive lung disease? There is left shift. Look, there is left shift and there is coving also. There is coving and left shift. Okay, the total lung capacity increased, residual volume increased. And in restrictive lung diseases, the curve is shifting towards the right side. Okay, loop shift to right. Okay, the dotted line is normal. This dotted line is normal, sir. Okay, so this is what I want you to know. So clarity here, nahi hai. Just tell me. So can you identify or not? When when they give such graphs in your exam? So tell me. Okay, let me ask you. Forget about everything. Let me ask you, sir. Here I am showing you flow volume loop. Look at this flow volume loop. This is normal flow volume loop. Imagine this is the normal flow volume loop. Okay, this is the normal. Sorry. This is the normal flow volume loop. Okay. Now my patient is having a flow volume loop something like this. My patient is having a flow volume loop something like this. Now tell me, this green color thing is the patient. Patient's flow volume loop. He is suffering with obstructive lung disease or restrictive lung disease. You tell me. Is he suffering with obstructive lung disease or restrictive lung disease? The green color patient. It's obstructive. Excellent guess. It's all obstructive. He's having emphysema, obstructive lung disease. Emphysema. Okay. We understood. Now, after this, let me teach you a few more things. Okay, this was supposed to be taught in physiology only, and it will also come in medicine again. Medicine, it will again come. If you understand it here in medicine, it will be easy. Now, let me write here 3 things. What is forced vital capacity? You don't write anything. Just listen. Forced vital capacity. Okay. What is FEV1? This is FVC. FVC. What is FEV1? FEV1 means forced expiratory volume in 1 second. Okay, in 1 second. Forced expiratory volume in 1 second. And later you have to know FEV1 by FVC ratio. Okay, FEV1 by FVC ratio. So you have to know these things. What is forced vital capacity? What is FEV1? And what is FEV1 by FVC ratio? Okay. Now, let me tell you one by one. Okay, let me tell you one by one. Now I'm taking graph. First of all, I'm taking a graph. First, let me tell you what is normal. This is x-axis. This is y-axis. Look, in x-axis, I'm talking about the time. What I'm talking about? I'm talking about the time. That is 0 second, 1 second, 2, 3, 4, 5, 6 seconds time. Okay. On y-axis, I'm talking about the volume. Volume. Okay, let me write here volume. Which volume? The lung volume, like how much air is going in and how much air is coming out. Okay, how much air is coming out, that volume. 1 liter, 2 liters, 3, 4, 5, 6 liters. 6 liters. Okay. Now, I'm taking a person, normal person. He's a normal, healthy individual. Okay, look at me. Imagine I'm the person. I'm a healthy individual. PEFR is peak expiratory flow rate. PEFR is peak expiratory flow rate, means the highest speed with which the air comes in and comes out. That's not needed. Forget about it. Okay, not needed. Look at me. I'm a healthy person. Okay. Now, what you are asking me to do is, sir, please take as much air as possible. Okay. I have taken maximum inspiration. Okay. I have taken maximum inspiration. Okay. Now you have to ask me, sir, do expiration as fast as possible. So you're asking me, sir, do expiration as fast as possible. So look, I have taken in. Now I'm doing expiration. See, I'm doing the expiration. For how much time I have done the expiration? Look, I'm doing expiration for almost 6-7 seconds. I'm trying to exhale. Same thing I'm showing it in the graph. Okay, same thing I'm showing it in the graph. So now I'm doing the expiration. After maximum inspiration, I'm taking the air out of my lungs. So with the time 1 second, 2 second, 3 second, 4 second, 5 seconds. See, now I am taking air out of my lungs. Okay, something like this. I have done the expression like this. Okay, so how much air I have taken out? You know, sir, vital capacity. How much is the vital capacity? How much air you can take out of your lungs? If you try after maximum inspiration, look at here. After maximum inspiration, how much air you can take out of your lungs? Vital capacity 5 liters, almost 5 liters you can take out. So even a healthy individual, now look here, healthy individuals, how much they can take out? 5 liters. That's why, see, 5 liters. The person can take 5 liters out of their lungs. Okay, so 5 liters. For how much time I have done the inspiration? Maybe like 5 seconds or 6 seconds, something like that. Okay, but important, this is called as forced vital capacity. Forced vital capacity, which means how much air you can take out of your lungs. Means 5 liters of air you can take out of your lungs, maybe in 5 seconds or 6 seconds. But look, in 1 second, how much air you have taken out? Look at this, concentrate this. In 1 second, how much air you have taken out? Almost 4 liters. Okay, almost 4 liters. Means just within 1 second, a healthy individual, just within 1 second, he can take almost 4. Out of 5 liters, he can take 4 liters in just 1 second. In just 1 second. Okay, so this is called as FEV1, means forced expiratory volume in 1 second. Okay, now tell me what is here in this condition, in this normal healthy individual, what is FVC? FVC is 5 liters, sir. You can take out 5 liters. What is FEV1? Forced expiratory volume in 1 second. 4 liters. Means out of 5 liters, you can take 4 liters. That is FEV1 by FVC ratio. That is 4 liters of air can be taken out of 5 liters in 1 second. FEV1 by FVC. That is ratio is how much? 80% or 0.8. 80% or 0.8. And what is the meaning? What is the meaning? The meaning of this is a healthy individual can take 80% of the air out within 1 second. Okka second low. In 1 second, you can take 80. Okay, in 1 second, 80% of the air can come out. Okay, a healthy individual, see, how much air I can take out? 5 liters of air. 5 liters of air I can take out in 5 seconds or 6 seconds. But in 1 second, in the first second itself, 80% of the air will come out. Okay, now look at me, what I'm doing. I'm taking the air out, but initial first second, in the first second itself, 80% of the air will come out. That is called as forced expiratory volume, FEV1. Okay, now you understood? So that is FEV1 by FVC ratio, 80%. So understood or not? If you want me to repeat it again, okay, I will repeat. The person is breathing for, like, doing expiration for, listen. The person is doing expiration for 5 seconds. But in first second itself, how much air came out in the first second? In the first second itself, he is removing how much air out of his lungs? He is removing almost 4 liters of air out of his lungs. In the first second itself, 4 liters of air will come out. That is 80%. 80% of the air is coming out in a healthy individual. If the person is healthy, he will remove most of the air, 80% of the air in the first second itself. That is FEV1 by FVC ratio. Okay, 4 out of 5. Okay, so now after this, let me discuss about obstructive lung disease. Okay, obstructive lung disease. Now, the patient is having obstructive lung disease. Do you know how the curve is going to be? Do you know how this a graph is going to be FeV1 by FVC ratio graph, like this curves. The curve, let me take the pink color, emphysema patient. Okay, emphysema patient. The graph is going to be something like this. Okay. Something like this. The graph is going to be something like this. So this is obstructive lung disease. Example is emphysema. Emphysema. Now, look, the main problem with the emphysema patients. Listen carefully. The main problem, imagine I am the emphysema patient. I am the emphysema patient. Now, if I am the emphysema patient, what is the main problem? Air is not coming out. Air is not coming out easily. Okay, air is not coming out easily. But see, if the air is not coming out, definitely the person will die. This or not. It's hard to take the air out of the lungs. Okay, it's hard to take the air out of the lungs. It's hard to take the air out of the lungs. Imagine I am the emphysema patient. Okay, I am the emphysema patient. Now, what is the problem? Elastic recoil decreased. Elastic recoil decreased. Air is not coming out. Now, as a doctor, you are asking me, sir, do expiration. Do expiration. So what I will be doing, I am trying to take the air out of my lungs. Like, I'm expiring like this. Look at me. Look at me. Means I'm trying to squeeze my lungs as hard as possible to take the air out of my lungs. It's difficult for me to take the air out of my lungs. Emphysema patients, expiratory problem. So I'm squeezing my lungs. Okay, like by creating the positive pressure here, I'm trying to take the air out of my lungs. I'm trying to do pursed lip breathing. I'm trying to take the air out of my lungs. So even emphysema patients, if they try, they can take the air out of their lungs. So that's why, look, even these patients, how much they can take the air out of their lungs? See, again, even they can take 5 liters of air. See, this is FVC. How much FVC? Again, 5 liters. So the point which I want you to know is, in emphysema patients, the FVC is normal. Okay. So let me write here. In emphysema patients, FVC is normal, 5 liters. Even they can take the 5 liters out. If they try, if they do the pursed lip breathing, they are called as the pink puffers. They will breathe like a puffer fish. If they try, they can take 5 liters of air out of their lungs. But what is the problem? Look at FEV1. This patient, he is not normal person. He is a patient. But look, what is FEV1? What happened to FEV1, sir, here? Normal FEV1 should be 4 liters. Normal person FEV1 should be 4 liters. But here, what happened? The FEV1 decreased. Okay, FEV1 decreased. Now it's only 2 liters. Out of 5 liters, how much is coming in the first second? He is taking only 2 liters of air in the first second. So FEV1 decreased. Maybe 2 liters decreased. Okay. So what happened to FEV1 by FVC ratio? FEV1 by FVC ratio. FVC. That is FEV1 by FVC ratio is 2 divided by 5. 2 divided by 5. So what is normal? 80%. Now 2 divided by 5, definitely it is less than 80%, right? Definitely that is less than 80% or less than 0.8. So now tell me, in emphysema patients, okay, listen Abra carefully. In emphysema patients, the FVC is normal. If they try, they can take the air out of their lungs. Okay, with so much effort, they can take the air out of their lungs. But what is decreasing? FEV1 in the initial first second, 80% of the air is not coming out. Only less air is coming out. So FEV1 by FVC ratio is decreased in emphysema. Okay, FEV1 by FVC ratio is decreased in emphysema. Okay, understood? Sir, please tell me, is it clear or not? But okay, before asking you a question, let me conclude finally. Let me draw here 3 things. What is the normal? What is obstructive lung disease, emphysema, and restrictive lung disease, pulmonary fibrosis? What is the difference? Normal, FVC. Okay, forced vital capacity. How much air you can take out? 5 liters. In obstructive lung disease also, If they try, how much they can take out? 5 liters they can take out. Okay, with pursed lip breathing, with pursed lip, like pursed fish, like, sorry, the puffer fish. You know how the puffer fish look like? Okay, with the pursed lip breathing, even they can take out 5 liters. But what is FEV1? In 5 liters, a healthy individual will take 4 liters in 1 second. In 1 second, he will take 4 liters. But what happened here? FEV1 is only taking out 2 liters, maybe, or 3 liters. So decreased. FEV1 decreased. What happened to FEV1 by FVC ratio? FEV1 by FVC ratio, that is 4 divided by 5. Normal is 80% or 0.8. But in obstructive lung disease, FEV1 by FVC, it is 2 divided by 5. Definitely it is less than 80% or less than 0.8. So, do you have clarity till here? Do you have clarity till here? I'm asking you. Abra, is that clear? So that's the recent question which was asked. That I'm giving so much time here. Okay, I'm giving so much time here because this is the recent exam question which was asked. One question will be definitely there regarding obstructive lung disease and restrictive lung disease. They will try to test you regarding this FEV1 and FECs. Okay. Now, chalo, let's discuss about the restrictive lung disease. Okay, let's talk about the restrictive lung disease. So let's take which color? Let's take yellow color or orange color. Let's take orange color. Okay. Now, how this FEV1 and FEC are changed in how they are changed in restrictive lung disease. Now look here, how they are changed means in restrictive lung disease. Remember, restrictive lung disease, chota lungs, small volumes and small capacities. Don't forget about it. This is how the graph is going to be. Okay, this is how the graph is going to be. So, restrictive lung disease, small lungs. Example is pulmonary fibrosis. Okay, pulmonary fibrosis. Restrictive lung disease, pulmonary fibrosis. Now, listen carefully. What happened to his chota lungs? No, so they are having small lungs. So they can't take the air in and they can't take the air out. Okay, if they can't take the air in, see, first of all, restrictive lung disease, remember, small lungs means they are taking less air into the lungs. So automatically less air will come out of the lungs. So that's why less air is coming out. So that's why what happened to their functional, forced vital capacity? Forced vital capacity, because of the small lungs, there are also expiring less air. So normal person, forced vital capacity is 5 liters, normal person. Now here in this person, what happened to the forced vital capacity? Maybe 2.5 liters. Okay, the forced vital capacity is decreased. From here, it is decreased. Okay, so let me write here. In restrictive lung disease, the forced vital capacity, because they are having small lungs, so less air will go in, automatically less air will come out. So forced vital capacity, they are not taking out 5 liters because that much amount of air, first of all, is not there in the lungs. So forced vital capacity decreased. Maybe here 2.5. Normal is 5 liters. But here it is decreased. So let me write here, restrictive lung disease, forced vital capacity is 2.5 liters. That means decreased. That number is not important. 2.5 is not important. Decreased is important. Forced vital capacity is decreased. Okay. Now what about the FEV1? Okay, what about the FEV1? Look at this FEV1. Now, FEV1, orange color, right? See, orange color. Let's see FEV1. Normal FEV1 should be 4 liters. Normal healthy individual FEV1 should be 4 liters. Here, what happened to FEV1? In 1 second, they are removing how much? Maybe the total lung capacity is 2.5. In FEV1, what happened to FEV1? Maybe it is 2 liters. Let's take round figure. Maybe it is just 2 liters. Okay, maybe it is 2 liters. Okay, let me just make a small, for easy understanding purpose. Let me take FEV1 here. Yeah, in 1 second. How much air they are taking out in 1 second? near to 2 liters. Their forced vital capacity is maybe 2.5 liters. Easy understanding purpose. So FEV1 also decrease. No, normal FEV1 should be 4 liters. Normal FEV1 should be 4 liters. But here in this person, what happened to FEV1? 2 liters. So right, FEV1, it is 2 liters. 2 liters. So this is also decreased. It should be 4 liters, but here it is just 2 liters. So decreased. Okay. Now look. What happened to FEV1 by FVC ratio? What happened to FEV1 by FVC ratio? That is 2 divided by 2.5. 2 divided by 2.5. 2 divided by 2.5, how much? Okay, we are not very good with the math, but anyway, 2 divided by 2.5 is almost nearing to 80%. It's almost nearing to 80%. Am I right or not? Just wait. Yeah. So 2 divided by 2.5, how much? Exactly 2 divided by 2.5. Exactly, I have just calculated. It is 0.8. Okay, 0.8 or 80%. So which means it is normal. It is normal. Okay. So what I'm trying to put into your mind, sir, look carefully, listen carefully. Here FEC is decreasing, FEV1 is also decreasing, but both are decreasing in the same proportion. Okay, both are decreasing in the same proportion. As they are decreasing in the same proportion, ratio will be normal, 80%. 80%. Now some students will have confusion. Sir, normal person may 80%. But why RLD may 80%? Because see, numerator and denominator both are decreasing in same proportion. So that's why here also FE1 by FEC is 80%. Okay, look at this. Tell me 5 divided by 10, how much? 5 divided by 10, how much? Sir, 50% or 0.5 ratio. 2.5 divided by 5, how much? Sir, that's also 50% or 0.5. See, if you decrease the denominator and numerator in a same proportion, ratio will be constant, sir. Ratio will be same. Okay, here are 50%, this is also 50%. So in restrictive lung disease, what I want you to know is FEC is decreasing, FEV1 is also decreasing when compared to normal. But both are decreasing in same proportion. So FEV1 by FEC is 80%. It is normal. Okay, now you understand? I hope you understand this thing. Even if it takes some time, not an issue. Important topic. That is 0.8%. No, 2 divided by 2.5. Just calculate it. You're asking, sir, some books mention 0.7, some books mention 0.8. You can take anything. Both are true. Okay, some books mention 0.7, some books mention 0.8. Both the values are correct. Like someone will say, like, FE1 by FEC is like, normal, in a normal individual, it is 70%. In some books mention 80%. That's a range. 70 to 80% is normal. Okay, 70 to 80% is normal. Okay. So I will ask you some questions. You just try to answer them. Tell me, in restrictive lung disease, what happens to the FEC? Tell me, in restrictive lung disease, what happened to FEC? In restrictive lung disease, what happened to FEC? Reduce. What happened to FEV1? Reduce. What happened to FEV1 by FEC ratio? Normal. In restrictive lung disease, FEV1 by FEC ratio is normal. Okay, tell me. In obstructive lung disease, pursed lip breathing, like a pufferfish, obstructive lung disease, emphysema. What happened to forced vital capacity, FVC? What happened to forced vital capacity? Normal. They can take 5 liters of air. If they try, they can take 5 liters of air. Okay. But what about the FEV1? In 1 second, it is reduced. FEV1 is reduced. So what happened to FEV1 by FEC ratio? Subhadra, yes, it's reduced. Okay, Vishnu, Priya, yeah, Rasul, yeah, it's all reduced. Yeah, Salva, it's all reduced. Okay, so done. So if you understand this, try to answer these questions. I am going to show you certain questions. You just try to answer them. Okay, you just try to answer them. Maybe the here I have given green. Maybe they are wrong. Maybe they are wrong. Don't simply go look at this. You just try to answer the question. First question: a 60-year-old male. Okay, 60 years old male presented with the complaints of dyspnea. Okay, he's having respiratory difficulty, dyspnea. Previous medical history suggests he's having emphysema. That's it. Emphysema means obstructive lung disease. You know the thing. What changes in the pulmonary function test is expected? So what kind of changes you expect in the pulmonary function test? FVC, FEV1, FEV1 by FVC ratio. In obstructive lung disease, tell me, in obstructive lung disease, FEV1 by FVC is increased. No, it is not increased. There is no change in FEV1 by FVC. No, this is also wrong. In obstructive lung disease, you know it. Sir, FEV1 by FVC ratio decreases. It is less than 0.8. True. True. This is true. Okay. This is also wrong, right? In obstructive lung diseases, what happened to the FVC? It's not increased. It is normal. This is also false. Okay. Now you tell me this question is correct or not. See, air remaining in lung after normal expiration. After normal expiration. Normal, not forced. After normal expiration. How much air is there inside your lungs? Residual volume is there. Plus expiratory reserve volume is also there. After normal expiration. So residual volume plus expiratory reserve volume is FRC, functional residual capacity. Students will think it is RV. No. Now I'm talking about normal expiration. After normal expiration, you have functional residual capacity. Okay. And how much is that functional residual capacity? Don't forget, 1300 ml plus 1200 ml. It is 2500 ml functional residual capacity. Next question. Regarding the pulmonary function test, all are true except total lung capacity increases in emphysema. True. Emphysema, obstructive lung disease. Obstructive lung disease, bigger lungs. Residual volume increases. Total lung capacity increases. The graph is going to shift to left. True. Total lung capacity increases. True. This is a true. But here I'm asking about except. Okay. Residual volume increases. True. Okay. What is this? FEV1 is forced expiratory rate in 1 minute. No, not in 1 minute, in 1 second. In 1 second. So this is wrong answer. So accept this. This is wrong. This is wrong. In restrictive lung diseases, FEV1 by FVC is normal. Just now we have discussed both numerator and denominator decreases in the same proportion. So FEV1 by FVC is normal. Normal. True. Okay. So this is accept. Wrong answer. Okay. Now the last question. Look at this. A 35-year-old. Okay. A 35-year-old woman present with the complaints of difficulty in the inspiration. So dyspnea is there. Inspiratory problem means you know it already. Restrictive lung disease. So the doctor suspects sarcoidosis. Now you know it. Sarcoidosis. Now I am telling you. See, silicosis, berylliosis, byssinosis, stenosis. All are restrictive lung diseases. Pulmonary fibrosis. They all are restrictive lung diseases. Sarcoidosis. So what happened to FEV1 by FVC? You know, in restrictive lung diseases, FEV1 by FVC is normal. Normal means how much? 0.8, near to 0.8. So what is the answer? 0.85, near to 0.8 or 80%. Okay. So that's it. These are the questions which can come up in your exams. Okay, these are the type of questions that can come up in your exam. So this is also done. Okay. So obstructive lung diseases, restrictive lung diseases, even though it takes some time, worth knowing. So shall I go forward, guys? Shall I go forward? Chalo. So again, I'm telling you, if you are listening to a live class, that is different. You might think I can watch the video later. Okay. But live classes are always effective. Okay. When you are when we are listening to one to one, that is different. recorded classes, of course, they will helpful, no doubt in that. But one-to-one classes are always different. Okay, you can ask doubts or like you will be more attentive. Okay, chalo. The next topic is alveolar ventilation and pulmonary circulation. Alveolar ventilation and pulmonary circulation. Okay. So what is this concept of alveolar ventilation, pulmonary circulation? So for the next half an hour, we have to discuss this alveolar ventilation, pulmonary circulation. Okay. So what is this concept of alveolar ventilation, pulmonary circulation? Simple. Alveolar ventilation means how much air you are taking into your lungs. Ventilation. Okay. Alveolar ventilation means what? Okay. Ventilation. Representing with the letter V. Representing with the letter V. Which means how much air going into the lungs for exchange purpose. మీరు ఎంత ఎయిర్ తీసుకుంటున్నారు 1 minute కి? ఓకే, హౌ మచ్ ఎయిర్ యు ఆర్ టేకింగ్ ఇంటూ ద లంగ్స్ ఎవ్రీ మినిట్, ఎవ్రీ డామ్ మినిట్, హౌ మచ్ ఎయిర్ ఈస్ గోయింగ్ ఇంటూ ద లంగ్స్. ఐ విల్ ఎక్స్ప్లెయిన్ యూ. ఓకే, డోంట్ వరీ. సో దట్ ఈస్ alveolar ventilation. We have to calculate it first. So this is our first topic, alveolar ventilation. Next, what we will see, what is the pulmonary circulation? Means how much blood you are sending into the lungs. It's represented with the letter Q, right? Q. Okay. So how much blood is going to the lungs for the purpose of oxygenation? Okay. So how to represent this in the image form? How much air is going in? Air is going in. How much air is going in? And how much blood is coming? Okay. How much blood is coming for oxygenation ke liye? Okay. అర్థమైందా? ఎంత ఎయిర్ తీసుకుంటున్నారు, హౌ మచ్ ఎయిర్ యు ఆర్ టేకింగ్ ఇన్, అండ్ హౌ మచ్ బ్లడ్ యు ఆర్ సెండింగ్. సో దట్ ఈస్ వి, వెంటిలేషన్ అండ్ పర్ఫ్యూజన్, వి అండ్ క్యూ. సో ఫస్ట్ టాపిక్ ఈజ్ వెంటిలేషన్. లెట్స్ స్టార్ట్ విత్ ద వెంటిలేషన్. ఓకే, నౌ ఇన్ వెంటిలేషన్ లెట్స్ గో ఫ్రమ్ ద బేసిక్స్. ఎన్విరాన్మెంట్ లో, ఓకే, ఇన్ ద ఎన్విరాన్మెంట్ వాట్ ఈస్ ద ప్రెషర్? The pressure in the environment is 760 mmHg. You consider it as 0. Okay. Environmental pressure is how much? 760 mmHg. Okay. In the environment, oxygen is there, carbon dioxide is there, nitrogen is there, helium is there. So many things are there. All these gases, all gases accounts for how much pressure? 760 mmHg. Okay. So this is the atmospheric pressure. So the environment is showing pressure on your body, but you can't feel it. Okay. 760 mmHg. Now, in the environment, what is there? What are there in the environment? You know it. Sir, in our environment, the major gas is not oxygen. The major gas is nitrogen. Okay. So most of the student doesn't know. They will think that there is maximum oxygen. No. In our environment, who is more, sir? Nitrogen, 79%. Oxygen, 21%. Okay, 21%. So this 21% can be converted into 0.1 fraction. Percentage is 21. Fraction wise, 0.21. So this is called as fractional concentration of oxygen. Remember this word. This is important. Fractional concentration of oxygen in the environment. How much? 0.21 or 21%. Okay. Carbon dioxide. How much carbon dioxide is there? When compared to the other gases, carbon dioxide is not even accounting for 1%. Okay, it's very, very, very less. It's 0% or nil. You can consider it as 0% or nil. Okay, nitrogen 79%, oxygen 21%, and carbon dioxide is 0. See, all this together they account for 760 mmHg. Okay, all these three together account for 760 mmHg. Now I want to know what is partial pressure. Partial pressure ante enti? What is partial pressure? Partial pressure means pressure exerted by an individual gas. For example, what is the pressure exerted only because of oxygen? All together is 760. How much is contributed by oxygen? Only oxygen partial pressure anta, only oxygen pressure anta. How much is contributed only by the oxygen? That is individual gas. Okay, so how to calculate it? See, now I'm trying to calculate partial pressure of, partial pressure of only oxygen is out of 760. How much is oxygen? 0.21. That is 160 mmHg. So the partial pressure of oxygen is 160 mmHg. Means out of that 760, how much is oxygen? 160 is oxygen. Oxygen is contributing how much? 160. So now you understand what is the partial pressure? Partial pressure is the pressure exerted by the individual gas. Now important MCQ, what is the partial pressure of oxygen? 160 mmHg. Done, sir. Okay. So in the environment, in your environment, look at your surrounding, look at your surrounding. In the environment, the oxygen pressure is 160 mmHg. Okay, done. Now after this, let's go further. Okay, let's go further. Look, in the environment, listen carefully here, it's a little confusing. In the environmental air, okay, the partial pressure of oxygen is how much? Okay, 160 mmHg. Outside it is 160 mmHg. Okay. Now, you will take the air in, right? You are going to take the air in. Means, for example, imagine these are the lungs. Okay, here is the person. For example, let me show the lungs something like this. Here are the lungs, both the lungs. Okay, now you are going to take the air in. Now this oxygen, look first where the oxygen will go. Oxygen will go into the paranasal sinuses. First, directly oxygen won't enter into the respiratory tract. No, it won't enter into the respiratory tract. First, oxygen will go into the paranasal sinuses. The air will go into the paranasal sinuses. In the paranasal sinuses, do you know what will happen? The air is getting humidified. The air is getting humidified. Water vapor will be there. Water vapor will be there. The air is getting humidified. The air temperature will come down. Okay. So what happens is, look, in the environmental air, the partial pressure of oxygen is 160. But when that air enters into our body, due to the process of humidification will occur because of the water vapor. Look what is happening. Now the partial pressure of oxygen in the inspired air, it is coming to 150 mmHg. Means from 160, it is reducing to 150. 160 నుంచి 150 కి decrease అయిపోయింది. Okay, the partial pressure is decreasing from 160 to 150. You will get it out. Why, sir? Why it is decreasing? Because let me tell you something. See, fishes are living in the lake. Fishes are living inside the lake. Fishes, turtles, like, all the things are living in the lakes. How they are getting the oxygen? Oxygen ko property undi. Oxygen have a property. Do you know what is the property of oxygen? Wherever there is water, oxygen dissolves in the water. Okay, oxygen, some amount of oxygen will dissolve in the water. In the same way, even in the paranasal sinuses, water vapor is there. See, water vapor is there. So some oxygen is dissolved over there in the paranasal sinuses. Some oxygen is dissolved. Because of that, we lose some oxygen. We lost some oxygen. So because of that, the partial pressure of oxygen in the inspired air, it is decreased from 160 to 150 because of the water vapor. Done? So if you say, sir, I understood this. Okay, environmental air mein partial pressure of oxygen is 160. In the inspired air, after entering into your paranasal sinuses, the inspired air mein the partial pressure of oxygen, that is PiO2. Okay, partial pressure of oxygen in the inspired air is 150 mmHg because of the humidification process. So in your exam, you know the direct value 150. PiO2 value is 150. But what they will ask you is sometimes, okay, once this question was asked, that's why I'm including it here. They will ask you to calculate. You know the value, PiO2 value. See, final value is 150, you know it. But how to find out PiO2? The formula is FiO2. You know the FiO2 value, fractional concentration of oxygen, that is 0.21. FiO2 into atmospheric pressure minus water vapor pressure. Water vapor pressure I have given here, 47 mmHg. That's constant. That's a constant. Atmospheric pressure is 760. Water vapor pressure is 47. Okay. So 0.21 into 713. 760 minus 47. That is 713. So how much? 150. See, this is the formula to calculate the PiO2. So PiO2 is equal to FiO2 into atmospheric pressure minus water vapor pressure. So 0.21 into 760 minus 47. So final answer 150. Okay, now you know how to calculate PiO2. Am I clear? Am I clear? Okay, so just close your eyes, and repeat for me. What is the formula to calculate partial pressure of oxygen in the inspired air? The partial pressure of oxygen in the inspired air is FiO2 into atmospheric pressure minus water vapor pressure. That is 0.21 into 760 minus, okay, 47. The direct value of PiO2 is 150 mmHg. So the partial pressure of oxygen is decreasing from 160 to 150 due to the process of humidification in the paranasal sinuses. See, there is maxillary sinus, ethmoid sinus. Okay, you know the sinuses, right? Paranasal sinuses. There will be frontal sinus, ethmoid sinus. All these sinuses will be there. Okay. Now, after that, where the air is going? Air is going into trachea, bronchi, bronchioles. Now, as the air is going through the trachea, bronchi, bronchioles, so some amount of oxygen, some amount of oxygen is getting dissolved in the mucus. Some amount of oxygen is losing. We are losing some amount of oxygen because oxygen is getting dissolved in the mucus. Mucus is there in the respiratory tract. Some amount of mucus is dissolved in the respiratory tract. Okay. So in the respiratory tract, what do you have? Here all mucus lining will be there. So as the air is moving, oxygen is going to be dissolved. Oxygen dissolved, oxygen dissolved, oxygen dissolved. So because of this, here it is 150 mmHg. The partial pressure of oxygen in the inspired air is 150. But when it reaches the level of alveolus, as we are dissolving the oxygen in the way, oxygen is getting dissolved. Konta oxygen dissolve avutu vastundi. Okay, oxygen is getting dissolved. So here in the alveolus, the partial pressure will fall to 104 mmHg. So this is the final value. Okay, this is the final value. So the partial pressure of oxygen in the alveolus, that is P capital A, means partial pressure of oxygen in the alveolus is 104 mmHg. Okay, so that is P capital A about 2. Okay, P capital A about 2. Okay, so how to calculate this P capital A about 2? You know the value. Okay, sir, partial pressure of oxygen in the alveolar A, you know the value 104 mmHg. But how to calculate it to make the life difficult for us? They have gave a equation formula. No need to remember this formula for FMG exam. No need to remember. If you want to remember, you remember it. Okay, that formula to calculate the alveolar partial pressure, oxygen partial pressure in the alveolar air. The formula is alveolar gas equation. See, it is calculating partial pressure of oxygen in the alveolus. Capital A means alveolus. So there is here the formula. Here is the formula. No need to remember. Just leave it. Okay. So three values, sir. Environment में partial pressure is 160. Inspired air, the partial pressure of oxygen is 150. In the alveolus, the partial pressure of oxygen is 104. But what I want you to know is how to calculate PiO2. PiO2 is equal to FiO2 into atmospheric pressure minus water vapor pressure. Done. So after this, okay, now let's discuss more about the ventilation. Now we are discussing more about the ventilation. Question which was asked in the recent exam. Okay, let me first show you the question. After that, I will discuss you the topic. First, let me show you how the question was asked. Let me show you. That's a respiratory may. So in respiratory low. In respiratory, this is the first question which I have kept. Okay, sorry. Just wait. Not the first question. Where is that question? Where is that question? Just give me a second. Okay, that question was not there. Okay, anyway, I will give you the question. I will write the question here. No worry. So, okay, after this topic, I will give you the question. I will give you the question. You have to calculate it. Okay. So now the topic which I am starting is the minute ventilation. Okay, minute ventilation. Yeah. So what is minute ventilation, sir? Every minute, how much air is going into your lungs? Every minute, how much air you are taking in? How much air you are taking in? So look here, the formula to calculate the minute ventilation is, sir, tidal volume into respiratory rate. Sir, every breath, with every breath, how much air you are taking in? 500 ml. Okay, with every breath you are taking 500 ml. And how many times you are breathing, sir? 12 to 16 times. 12 to 16 times you are breathing. So 500 into 12. Okay, 500 into 12. Minimum, I am taking the minimum. So you are breathing 500 ml of air with every inspiration. And how many times you are breathing every minute? 12. So 500 into 12, 6 liters. Okay, 6 liters. Which means, sir, every minute, how much air you take in? 6 liters of air. 6 liters of air. This is the minute ventilation. Direct value completed. Minute ventilation value is 6 liters. Okay. Okay. But what we want is not the minute ventilation. We don't want a minute ventilation. What is our topic? Our topic is alveolar ventilation, not the minute ventilation. We have to calculate what is the alveolar ventilation. I will tell you what is that alveolar ventilation. Look, guys, look at this tidal volume once. Sir, every minute, with every breath, how much air you are taking in? Tidal volume. How much is that? 500 ml. With every breath, you are taking how much? 500 ml. See, do you think all this 500 ml will go into your alveolus? 500 ml of air will go into the alveolus with every breath? No, sir. No. See, out of this 500 ml, look, 150 ml is going to stay in your conducting zone. The 150 ml conducting zone lo agipotundi. The 150 ml is going to stay in the conducting zone. Or you can say 150 ml is going to stay in your dead space where there is no exchange of gases. So 150 ml of air is lost. I'm not talking about oxygen. I'm talking about the air. So 150 ml of air is lost. It is not involved in exchange. So it is useless. Okay. So every time how much is lost? 150 ml is lost. So with every breath, how much is lost? 150 ml is lost. So how many times you are breathing? 12 times. So 150 into 12, which is 1800 ml. So 1800 ml is waste. So that is called as dead space ventilation. So in this 6 liters, okay, that is 6 liters means 6000 ml. Is 6000 ml low? In this 6000 ml, 1800 is lost. That is dead space ventilation. Then what is exactly going into the alveolus? How much is exactly going into the alveolus? You tell me. Sir, if you remove this 150, how much is exactly going into the alveolus? Out of this 500, 350 is going into alveolus. Or you can say 350 is going to respiratory zone. Okay, respiratory zone or alveolus. So how much is going? 350 is going. How many times you are breathing? 12 times you are breathing. So 350 into 12, how much? 4200. 4200. Approximately, you can say 4 liters. 4 liters. So how much is really going? How much is really going, sir? 4 liters is going into your alveolus. So this is your alveolar ventilation. Okay, so topic done. Now you have calculated alveolar ventilation. Our topic, alveolar ventilation. మీరు ఎంత air alveolus పంపిస్తున్నారు? How much air you are sending into the alveolus? See, I'm telling in I'm repeating it again in Hindi, English, and Telugu for easy understanding purpose. So how much air you are sending into the alveolus? 4 liters. 4 liters. So tell me the 3 values. So please tell me the 3 values, sir. Minute ventilation is 6 liters, but in that 6 liters, 1800 ml is the dead space ventilation. 4200 ml is alveolar ventilation. So please add this to, sir, 4200 plus 1800 is how much? 6 liters. Ardhamainda? Understood? Okay, so these 3 values I want you to know. Look at me. So Imagine I'm breathing for 1 minute. Imagine I'm breathing for 1 minute. So from environment, how much air I have taken in? I have taken in 6 liters. 6 liters. Out of that 6 liters, 1800 ml is lost in the conducting zone. 1800 ml is not involved in exchange. 1800 ml is lost in the dead space. How much is actually going into the alveolus? 4200 or 4 liter is going into the exchange purpose. 4 liters is involved in the exchange purpose. Okay. Hope you understand. Now, you tell me the calculation I have said, right? Question is there. Try to calculate this. Calculate this. Sir, there is a patient. His tidal volume is 500 ml. Write this. This was the question which was asked. Patient with a tidal volume of 500 ml. His dead space, sorry, first his respiratory rate is 12 per minute. His dead space or the conducting zone. Okay, how much ml? Here he is having 200 ml. His dead space volume is the 200 ml. Okay, so now what is his alveolar ventilation? Calculate alveolar ventilation. Calculate alveolar ventilation. Tell me. Let me see who can answer. So for those students who are not good in mathematics, now I'm telling you. See, so he is taking 500 ml. Out of this 500 ml, now how much is lost every time? Dead space may 200 ml is lost. How much is actually going into the alveolus now? Sir, how much is actually going? 300 ml is going into the alveolus. With every breath, 300 ml is going. And how many times he is breathing? 300 into 12. Okay, 300 into 12. So how much is 300 into 12? Can you tell me? 12 3s are 36. So 3600 ml is his alveolar ventilation. Okay, normal person alveolar ventilation is 4200. But here it is decreased because there is more dead space. Is that okay? 3600. You have calculated. Excellent. You have all calculated. 3600 ml is the alveolar ventilation. Okay. So that's how you have to calculate. Now, after this topic is done. After this, there are few questions on dead space. Okay, few questions on dead space. Let's see what are they. You know, the dead space volume is how much? A dead space also called as conducting zone. The first 16 generations, you know it. How much is the anatomical dead space? Yenta sir, how much is the anatomical dead space? Kitna hai? 150 ml, you know it. 150 ml. Anatomically, that area is dead. No exchange. Now, I'm asking you a new dead space that is called as alveolar dead space. Alveolus mein gases will be exchanged. So there is no such thing as alveolar dead space. Okay, normal healthy individual. In normal alveolus, gases will exchange. So there is no alveolar dead space. So always a pathological. Alveolar dead space is absent in healthy individual. So alveolar dead space is 0. Okay. Now, what is physiological dead space? Physiological dead space. The formula for physiological dead space is anatomical dead space plus alveolar dead space. We are calculating. We are doing the sum. You know, anatomical dead space 150. Alveolar dead space in healthy individual 0. So 150 plus 0 is 150 only. So done, sir. So physiological dead space is 150 only. Okay, physiological dead space is 150 only. That's it. Okay. So can I say something like this? In a healthy individual, normal individual, look at this. In a normal individual, anatomical dead space is 150 and physiological dead space is also 150. Both are equal. So note. So in healthy individual, physiological dead space and anatomical dead space are equal. Okay, that's a true statement. They can give you such kind of questions also. Assertion reason cases. Assertion reason kind of cases are mainly asked in the NEET PG and INACT exams. Okay, but know this one thing. There is anatomical dead space, alveolar dead space, and physiological dead space. Anatomical dead space and physiological dead space are 150, 150, same. But alveolar dead space is 0 in a healthy individual. Okay. For example, if the patient is having pulmonary edema, then alveolar dead space is going to increase. So it increases in the pathological conditions. Done. Now, two single liner questions. Okay, two single liner questions. What are the single liner questions, sir? Okay, let me tell you. Anatomical dead space, how to measure it? Okay, anatomical dead space, how to measure it? Physiological dead space, how to measure it? Sir, these single error questions are little boring, sir. We have to by heart. Yes, you have to by heart. Anatomical dead space, how we will measure it? There is a method called as single breath nitrogen method. It is also called as AKA, also known as Fowler's method. Anatomical dead space is measured with Fowler's method. Do you know how I used to remember when I was a student? I made this own mnemonic when I was a student. Anatomy. When you are going for the anatomy labs, okay, when you are going for the anatomy labs, the professor is going to like ask you to do the dissection. They will take you to the cadavers. So how the cadavers, anatomy labs, foul smelling, foul anatomy is a foul subjects, all bad smelling. Okay, so anatomical dead space is calculated by Fowler's method. I used to remember. Okay, anatomical dead space, Fowler's method. Foul. Okay, anatomical dead space, foul. And physiological dead space, physiological dead space, it's a 150. But how to calculate it? What is the equation? There is a special equation to calculate it. That equation is called as Bohr's equation. No need to remember. Equation is not important, but this like Bohr's equation is used to. They will ask you. Bohr's equation is used to calculate physiological dead space. How I used to remember when I was a student, I feel physiology is a boring subject. Boring subject. Physiology. Okay, so physiology is a boring subject. Okay, so physiological dead space is calculated by Bohr's equation, and anatomical dead space is calculated by Fowler's method. Anatomy foul, physiology Bohr. Okay, so is that helpful? I hope this is helpful to remember at least. Is that okay, guys? So ventilation part ho gaya. So tell me anatomical dead space. When you hear the word anatomy, anatomical dead space calculated by Fowler's method, single breath nitrogen method, and physiological dead space is calculated by Bohr's equation. Physiology, Bohr, anatomy, Fowler. Okay. Done. Next. So ventilation done. Next, I have to discuss about perfusion. So in the ventilation perfusion topic, okay, some students will be like, confused. So one thing I have completed, guys, so far. Ventilation గురించి అయిపోయింది. The ventilation के बारे में we have completed all minute ventilation, dead space ventilation, alveolar ventilation. Okay, all these points completed. Fractional concentration of oxygen in the environment, partial pressure of oxygen in the environment, partial pressure of oxygen in the alveolus. We have completed. Now what we have to discuss? Pulmonary circulation. What is the alveolar ventilation value? You know it. 4,200 ml, 4 liters. You know it. Okay, 4,200 ml. You know it. Alveolar ventilation. Now let's calculate pulmonary circulation or perfusion to the lungs. Simple values are one single value. Every minute, how much blood is going to the lungs? Oxygenation purpose ke liye, every minute, how much blood is going to the lungs? Simple, you know it. 5 liters. Alveolar ventilation is 4 liters. Alveolar ventilation is 4 liters. But what is the pulmonary circulation? Enta blood veltundi? How much blood is going to the lungs? 5 liters. 5 liters is going. So direct single value, 5 liters of blood is going. That is the pulmonary circulation. Okay. So the pulmonary circulation is highly compliant circulation, low pressure circulation. That's not needed for FMG students. Simply remember one point. Pulmonary circulation and the pulmonary circulation, how much? 5 liters. So Q, pulmonary circulation, how much? 5 liters. Ventilation is 4 liters. Perfusion is 5 liters. Okay, done. Done. Now, if you understand this, let me tell you a little important points. Sir, important, listen carefully. This is your lung. This is your cute little lung. Now, I am dividing the lung into 3 parts. Apex, middle lobes, and base. Okay, apex, middle lobe, and the base. Now, look at the diagram carefully. Okay, look at the diagram carefully, sir. Where do you think more blood flow is there? Tell me, where do you think more blood flow is there? Sir, look, the base and in the apex. Where do you think more blood flow is there? Base may the nature have designed our lungs in such a way. Nature, the God, okay, have designed the lungs in such a way. Base may zyada blood flow hai. Okay, Q is going to be more. And when you are going towards the apex, see, the blood vessels are getting compressed. So the blood flow is going to be less. Q means perfusion. Q means blood flow. The flow is going to be less. Okay. So look here, blood flow in the apex, middle lobes, and the base. Okay. Now in the apex, what I have told you, apex may blood flow is going to be less blood flow. You might ask me the reason why. Why, sir? Because in the apex, in this apical region, the alveolar pressure, the pressure within the alveolus, later I will discuss what is this pressure. In apex low, in the apex, alveolar pressure is more. So alveolus will compress the blood vessels. So less blood flow. So there are certain pressure changes. Pressures are going to be different. Alveolar pressure, see, P capital A. P capital A means alveolar pressure. Alveolar pressure is greater than arterial pressure. These are the arteries. Arterial pressure kante alveolar pressure equa. When compared to the arterial pressure, alveolar pressure is more. So they are compressing the blood vessels. So blood flow decreases. Okay. So now tell me, in the apex, alveolar pressure is greater than the arterial pressure, and arterial pressure is greater than the venous pressure. Because of this pressure changes, pressure differences, apex में blood flow कम है, and this is normal. But base में देखो, base में arterial pressure is more, more pressure, so more blood flow will be there. Okay, arterial pressure is more, even venous pressure, pulmonary venous pressure is more than the alveolar pressure. Pressures ila undadam valla, as the pressures are like this, base में blood flow zyada hai, and middle में average blood flow. Okay, middle में intermittent means 50-50% blood flow. Okay, so in the middle lobes, look, arterial pressure is greater than, see, arterial pressure means more blood flow can be there. Okay, blood flow can be happening. Arterial pressure is greater than alveolar pressure, but alveolar pressure is greater than venous pressure. So this pressure differences are a topic for NEET PG. These are the topic for NEET PG. But FMG में what is important? At least for FMG, what is important? Sir, apex में less blood flow, base में ज़्यादा blood flow, continuous blood flow, middle lobes में intermittent blood flow means 50-50%. Okay, that's called as a waterfall effect, means 50-50%. Like, blood flow will be there. So how to understand this? Let me tell you how the question can come. In which of the question is something like this. In apex of the lungs, there is less blood flow. Okay, due to options 1, 2, 3. Due to, in apex, alveolar blood pressure is greater than arterial blood pressure, greater than venous blood pressure, or arterial blood pressure is greater than alveolar blood pressure, greater than venous blood pressure, or in the apex, arterial blood pressure greater than venous blood pressure, greater than alveolar blood pressure. Tell me what is true in the apex. What is true in the apex? Yes, in the apex, the blood flow is going to be less. Why the blood flow is going to be less? Option 1, 2, or 3. Tell me. Option 1, 2, or 3. Sir, in the apex, alveolar pressure is more. Okay, this is the answer. So such kind of question was tested 2 times in the NEET PG exam. What is asked in the FMG exam? Apex में less blood flow is there. Okay, apex में less blood flow is there. Okay, so know this. Okay, done. Okay, sir. That blood flow perfusion topic is also completed. Perfusion का topic भी हो गया. Ventilation हो गया 4 liters. Perfusion भी हो गया. Ventilation and perfusion are completed. The topic is completed. So take deep breath. Take a 1 minute break, sir. Take a 1 minute break. 1-2 minutes. Take break. Okay. Okay. Like what is the time? 10:55. Okay. Let's take 5 minutes break. As you are asking 5 minutes. Okay. Take 5 minutes break. Go and have tea and come. It's exactly started at 11 o'clock. Now exactly time is 10:55. Take a break of 5 minutes. Next, we are going to discuss about ventilation perfusion ratios. Simple topic. If you understand, it's simple topic. Okay, 5 minutes break. If you have any doubts, please post here. Okay, guys, I have given a little extra time because I know it's respiratory. So respiratory is going to take a lot of energy. Respiratory is going to make you crazy. So that's why I gave a little extra time so that you can have like, a cup of extra tea. So, guys, can you hear me? Am I visible? I hope I'm visible. Shall we start? Shall we start? Okay, done. Guys, give me the confirmation. Like, how many students are there? 50 students are there. Okay. I'm asking you. Almost 2.5 days completed. Okay, 2.5 days completed. So, are you getting things right? Like, at least respiratory. Okay, respiratory is clear, right? Whatever I'm teaching, you can understand and it makes sense. At the end of the day, it's the student who should be happy. Arise policy is one. At the end of the day, student should be happy. At the end of the day, student should be benefited. Okay, if you want me to go slow, yes, I will go slow. Okay, so don't worry about the syllabus. I will make sure that I will complete. Yeah, tomorrow we are going to complete. Tomorrow we have to extend the time. Tomorrow we may extend till 9 o'clock in the night, maybe. So tomorrow we have to complete. Okay, so for example, see, with me, I'm a flexible teacher. For example, if I can't complete tomorrow, so there is one topic left over. For example, like a topic like acid-base balance topic is left over, sir. Or for example, cell membrane topic is left over, sir. So I'm not going to leave that thing. Day after tomorrow, Monday is holiday. So I will take extra 1 hour on Monday. I will complete that. Okay. So there is no topic that's going to be left. I will be doing. How much time will renal take? Today we have to complete the renal. At any cost, today we have to complete at least not at least 70% of the renal we have to complete today. Renal is one of the big chapter. We have to complete the renal. Okay. So I'm not going to waste my time. I'm going to start immediately. So chalo. Ventilation perfusion ratios. Sir, already we have discussed. Ventilation perfusion ratios 4 divided by 5. You know that the ventilation is 4 liters. Okay, the ventilation is 4 liters and perfusion is 5 liters. The ventilation is 4 liters and perfusion is 5 liters. So ventilation perfusion ratio. How much is the ventilation perfusion ratio? Ventilation by perfusion, V by Q. So 4 divided by 5. So 0.8. That's it. Okay, ventilation perfusion ratio is 4 divided by 5. So 0.8. This is something normal. Okay. So ventilation ke liye, how much air you are sending into the lungs? 4,200, you know it. Let's take approximate value, 4 liters. Okay. How much blood is you are sending into the lungs? How much blood you are sending into the lungs? 5 liters. So ventilation perfusion ratio is how much? 0.8. That's it. That's a normal value. Okay. Next. See, let's divide the lung again into 3 parts, apex, base, and middle lobes. Look at the anatomy of the lung. Okay, look at the microanatomy of the lung. See, these boxes which I am showing you here, these are all the alveolus. Okay, these are all the alveolus. This is not a honeycomb, this is a alveolus. Now tell me, sir, where do you think alveolus are? Okay, where do you think alveolus are bigger in size? So, dekho here, alveolus are bigger in size here. Big alveoli. Okay, big alveoli. And in the base of the lung, see, there are chota alveoli, small alveoli are there. Okay. So what I want you to know is, in the apex of the lung, there are larger alveoli. God have made our lungs in such a way. God have designed our lungs in such a way that in the apex, already alveoli are very big. Okay, they are widely opened alveoli. And these alveoli are less compliant. They are already big. They do not stretch further. Okay. In the apex I am talking about. See, now I am talking about the apex of the lung. In the apex of the lung, look, the alveoli are bigger. That's the FMG question. Alveoli are bigger. And how these alveoli already they are bigger, sir? They do not further stretch. If they do not further stretch, the less air is going into them. Already they are big. So they are not stretching further. So less air will go there. So they are having less ventilation. Less ventilation. Okay. So ventilation is less in the apex. Now tell me, in the apex, ventilation is less. Just wait till here. 3 points complete. Larger alveoli, less compliant alveoli, and less ventilation. Because less compliant, less ventilation. More compliant means more ventilation. Simple. Now look at the perfusion part. Perfusion means blood flow. Ventilation means V, airflow, and perfusion means blood flow. Look at the perfusion. I have already told you in the apex. In the apex, P capital A is greater than P small a is greater than, sorry, P capital A is greater than P small a is greater than PV. So what I have said you in the apex, because of such arrangement, because of such pressures in the apex, there is higher resistance. So there is less blood flow or less perfusion. You can say less blood flow or less perfusion. Less blood flow or less perfusion. So perfusion is less. Done, sir. So now tell me, now tell me, in the apex, okay, in the apex, ventilation is less. Here I have written ventilation is less, as well as perfusion is less. Both are less. Ventilation and perfusion are both are less in the apex. True. Both V and Q, ventilation, perfusion, both are less. But the most important point I want you to know, keep like 5-star marks. Most important point. Rendu kuda takkuve. Both are less. Dono bhi kam hai. But perfusion is less than ventilation. Okay. So perfusion, it is less than ventilation. Or you can say, ventilation is greater than perfusion. Both are true. So both are true. It's the same thing. It's the same thing I'm telling you in 2 different ways. Okay. So let's stick to one thing. So in the apex, I'm telling you, ventilation is greater than perfusion. Both are less, but head-to-head comparison, I'm comparing one to one. Okay. Both are less, but when compared to perfusion, little bit more ventilation is there. Ventilation is more when compared to perfusion. So now tell me, which means more air is there, but less blood is there. Less blood. Okay, perfusion is less. So less blood, but more air is available. Means blood is not coming in the apex. Listen carefully. In the apex, blood is not going. Very less blood is going. So if very less blood is going, so what happened to the oxygen exchange? At least little oxygen is there. Ventilation is greater. So more oxygen is there. But blood is not going. Perfusion is very, very less. So because of this, there is less gaseous exchange. Why gaseous exchange is less? Because very less perfusion. Blood is not going. So oxygen is not getting exchanged. Carbon dioxide is not getting exchanged. So less gas exchange. Okay. Because very less blood flow is going. So now tell me, oxygen, is it getting exchanged in the apex? Oxygen is not getting exchanged. So here, oxygen is freely available because oxygen is not getting exchanged. So in the apex of the lung, you have so much free oxygen available. In the apex of the lung, there is so much free oxygen available because the perfusion to the apex of the lung is very much less. So that's why in the apex you have high oxygen. Okay, just remove this. In the apex you have high oxygen. Okay. So now tell me, in which lobes of the lung the partial pressure of oxygen is more, or more oxygen availability is seen? Apex. So that's why in your microbiology, when you are studying about TB, you will be taught that TB is a aerobic organism. TB anedi aerobic organism. Okay, TB requires oxygen. TB is an aerobic organism. So Mycobacterium TB, it will grow in the apex of the lung because in the apex more oxygen is available. So TB will affect apex due to the higher oxygen partial pressure. TB or aerobic organism affects apex. Okay, I hope you have already heard about that in your microbiology. So done, sir. So sorry, repeat for me. So repeat for me. Like, no, I'm going to ask you the questions. You just try to answer them. Okay, you just try to answer this question, sir. Now tell me, in the apex of the lung, more perfusion or more ventilation? Tell me. In the apex of the lung, okay, just wait. Let me frame it in a different way. In the apex of the lung, what about the ventilation? In the apex of the lung, what about the ventilation? Is it more or less? First tell me. In the apex of the lung, ventilation, is it more or less? Apex of the lung. Guys, you are confusing. In the apex of the lung, ventilation is less. Just now I have discussed, no. Ventilation is less. Ventilation anedi takkuva. Ventilation is less. Perfusion kuda less. Perfusion is also less. So ventilation is less. Perfusion is less. Both are less. But when you compare them, head to head compare jeste, when you compare each other, ventilation is greater than perfusion. Than perfusion, ventilation is greater. But you have to say, tell me again, in the apex of the lung, ventilation is less, perfusion is less. Apex of the lung, alveoli are larger, less compliant, less ventilation, less exchange, more oxygen availability. More oxygen availability in the apex of the lung. Okay, more oxygen availability in the apex of the lung. So aerobic infections like TB affects the apex of the lung. Okay, so ventilation and perfusion, they are little different in the apex. Little different. Ventilation is greater than the perfusion. Okay, done. Now let's discuss about the base. Okay, look at the base, sir. Look at the base. Now in the base, okay, in the base, look at this. In the base, alveoli are smaller. Chota alveoli, smaller alveoli. Now God have made these alveoli in such a way they are more compliant. They are more compliant. Means they are more stretchable. They are more stretchable. They will stretch more. They will stretch more. They will take more air. So they have more ventilation. More ventilation. So one thing is clear. So in the base, ventilation more. Okay. You already know that in the base, perfusion. How the perfusion is? P small a is greater than P small b is greater than P capital A. So base low, in the base, there is low resistance for the blood flow. So there is more blood flow. In the last slide, I have explained you, in the base, there is more blood flow. Look at this diagram. I have discussed, in the base, there is more blood flow. Okay. So ventilation zyada hai, perfusion bhi zyada hai. So Q. So ventilation is more, perfusion is also more. Both are more. Ventilation, perfusion are more. So one thing which I want you to know here, both are more, no doubt. Both are more. Rendu kuda ekve. Both are more in the base. Both are more. But now compare them. I am comparing one to one. Okay. In the base, perfusion is greater than ventilation. Means more blood flow. Perfusion is greater than ventilation, which means more blood is going. More blood is going. Okay. When compared to the amount of air. Okay, when compared to the amount of air that is present, there is more blood flow. As there is more blood, more and more blood is going to the base, so more exchange will occur. More exchange will occur. As more blood is going, the blood can take more oxygen. So there is more gaseous exchange. Gaseous exchange is going to be more in the base. In the apex, less gaseous exchange. Okay, so done. So now I'll be asking you questions. You have to tell me. The first question. You tell me, when I'm moving from apex to base. Okay, mano apex nunchi base ki move aite, which means when we move from apex to base. Okay, tell me, what happened to ventilation, perfusion? Think logically and tell me. When you are going from apex to base, what happened to ventilation? Ventilation increases or decreases? And what happened to perfusion? Perfusion increases or decreases? Look, in the base, always ventilation and perfusion are more. Okay, in the base, ventilation, perfusion are more. In the apex, ventilation, perfusion are less. So I can say one thing here. It was given. Look at the statement. As we move from apex to base, both ventilation and perfusion increases, progressively increases. Okay. Now question time. Let me check. Sir, in which lobes of the lung there are small alveoli? In which lobes of the lung? Keep the answers in short form. Short, simple. Base BA is enough. Okay. And the question which was asked in the FMG exam is which lobes of the lung alveolar are larger? Apex, you know it. Okay. In which lobes of the lung both ventilation and perfusion are less? Both ventilation and perfusion are less. Apex. Okay. Apex. In which lobes of the lung there is greater ventilation? Greater ventilation. Only I'm talking about ventilation. See, I'm talking only about the ventilation. In which lobes of the lung ventilation is more? Base. Base. That's it. Ventilation is more in base. That's it. Perfusion is more in base. But if I ask you something like this, sir, in which lobes of the lung ventilation is greater than perfusion? Sir, ventilation is greater than perfusion in apex. In apex. Okay, in apex. Okay, tell me something like this. Sir, in which lobes of the lung both ventilation and perfusion are less? Both ventilation and perfusion, both are less where? Apex. Apex. Okay. So in which lobes of the lung highest oxygen availability is there, or high partial pressure of oxygen availability is there? Excellent. Excellent, guys. Apex, apex, apex. Okay. Apex. Next, in which lobes of the lung perfusion, that is blood flow, perfusion is greater than ventilation? More blood flow is going. Base. Base. So that's it. So apex and base में थोड़ा difference है. Okay, ventilation and perfusion के बीच में there is little difference. Apex में it's little different, that ventilation is greater than perfusion. Base में perfusion is greater than ventilation. So there is a difference. So that's why because of this reason, normal ventilation perfusion ratio is how much? Normal it is 0.8. Where in the middle lobes में, ventilation perfusion ratio is 0.8. But apex में थोड़ा difference है, base में थोड़ा difference है because of the size of the alveoli. Okay, so that's why now I'm writing here. Look, in the apex, if you see the ventilation perfusion ratio, it is a 3.2, not 0.8. It is 3.2. Okay. Now you know all the points about the apex. Large alveoli, less compliant alveoli. Ventilation is greater than perfusion in the apex. Mycobacterium TB affects upper lobes. You know it. Base में, because of the changes in the ventilation and perfusion, the ventilation perfusion ratio is 0.6. 0.6. So normal is 0.8. Apex में 3.2. Base में 0.6. So these three values I want you to remember. Okay. Important. So in one of the FMG exam, the question which was asked is the ventilation perfusion ratio is least in base, maximum in apex. Okay. The next topic, same topic, but the next concept which I want you to know is VQ mismatch. VQ mismatch. Sir, any questions asked in FMG exam? Yes, of course asked. I will show you the previous questions also. VQ mismatch. Sir, what is this VQ mismatch? Now, let me take a new slide and let me discuss about that VQ mismatch. Ventilation, perfusion, mismatch. So what is the normal ventilation? Tell me. 4. What is the normal perfusion? 5. Normal ratio is 0.8. Okay, done, sir. Now, let me take a condition. Number 1. That is foreign body obstruction. Okay, foreign body obstruction. Foreign body, for example, like a boy who is like, playing with a small toy. The toy got lodged in the respiratory tract, or the boy, he have unfortunately, accidentally, he have swallowed a 1 rupee coin. That coin is getting lodged in the respiratory tract. Okay, so a patient is having a foreign body obstruction. Now let me show how the foreign body obstruction looks like. Look at here. So this is your lungs. This is your trachea. Here is your lung. And I'm showing the alveolus here. Let me show. This is the alveolus. Okay. And what is this one? Let me show. This is the blood vessel. Okay, pulmonary capillary. Now, because of the foreign body obstruction, here is the 1 rupee coin. It got lodged here. Okay, 1 rupee coin or some small toy lodged over here. Now tell me, who is affected? Now the blood, now the air is coming like this. Now the air is not able to go to the alveolus. Okay, now the air is not going to be able to go to the alveolus. So who is affected? Ventilation is affected. Now ventilation 2 into this lung, it becomes 0. Okay, into this lung, it becomes 0. But if there is any problem with the perfusion, so blood is going, so there is no problem with the perfusion. So perfusion is good. Perfusion is good. Now normal perfusion, let's take the normal perfusion value. What is the normal perfusion? 5. Okay. So how much is 0 divided by 5? So in a condition called as foreign body obstruction, what happened to the ventilation perfusion ratio? 0 divided by 5. How much is 0 divided by 5? 0 divided by 5, 0 only. Okay, 0 divided by 5, 0 only. So in foreign body obstruction, right? In foreign body obstruction, the ventilation perfusion ratio becomes 0. Okay, ventilation perfusion ratio 0 becomes 0. Done, sir. Now, let me tell you the same thing. Let me give you one more example. For example, tumor, lung, the patient is having lung tumor or some cancer, lung cancer, compressing respiratory tract. Okay, tumor compressing the respiratory tract. So for example, this is your respiratory tract. Okay, here is the lung. Now what happened is the patient is having a cancer in the apex of the lung. Maybe the patient is having a cancer, pan-post tumor is there, which occurs in the apex of the lung. Now because the cancer is growing, what it will do? It will start to compress the respiratory tract. It will start to compress the tract. So now the tract is getting compressed. Okay, now as the tract is getting compressed, who is getting affected? Tell me, who is getting affected? Ventilation is getting affected or perfusion is getting affected? Ventilation, again, the air is not able to go. Okay, but perfusion is normal. The blood is going there. Okay, so now ventilation becomes 0. Perfusion is normal. So again, it is 0. 0 divided by 5, how much? 0 only. So in which conditions ventilation perfusion ratio is 0? In which conditions ventilation perfusion ratio will become 0? In 2 conditions. One is foreign body obstruction and tumor compressing the respiratory tract. And if you want to know one more condition, that is called as atelectasis. Okay, I'm not going to details. Simply remember these 3 conditions. Sir, foreign body obstruction, look here. It was already given in your book. In which condition? Look this. Ventilation perfusion ratio becomes 0. Look here, 0. 3 conditions. One is foreign body obstruction, atelectasis, and airway compression. Okay, airway compression. So these 3 cases, sir. Okay. In these 3 cases, ventilation perfusion ratio is 0. Now, next. This is now what I'm going to teach you. That is the exact question which was asked in the FMG exam. FMG exam mein ek question aaya, sir. Next, look at this. In which conditions ventilation perfusion ratio? Okay, just let me take the example first. So the patient is having example pulmonary embolism. Pulmonary embolism. So what exactly is pulmonary embolism? This is your respiratory tract. Here is your beautiful lung. What is this? This is your alveolus, and this is your pulmonary capillary. Okay, pulmonary blood vessels. Now the patient is having what? He's having pulmonary embolism. Now into the pulmonary artery embolism, maybe directly into the artery. Now the thrombus got lodged. Okay. Now what is this? This is P, pulmonary embolism. Now whenever there is pulmonary embolism, who is affected? So there is no problem with the ventilation. Ventilation is okay. But who is affected? The blood is not coming. The blood is not going. So there is no blood. So I can say ventilation by perfusion. Ventilation is okay. 4 divided by what happened to the perfusion? Perfusion becomes 0. Perfusion becomes 0. So 4 divided by 0. If you divide any number with 0, becomes infinity. It becomes infinity. So ventilation perfusion ratio is infinity in which condition? Pulmonary embolism. That's it. In pulmonary embolism, the patient is going to have a VQ ratio of infinity. Okay. And the second example which I want to give you is anatomical dead space. Anatomical dead space. Okay, anatomical dead space. So what exactly is happening in the anatomical dead space? Let me write. What happens in the anatomical dead space? You know, in anatomical dead space, sir, air is there. Air is there, which means ventilation is normal. Okay, ventilation is happening. But who is not there? The blood is not going to the dead space for exchange purpose. The blood is not going. So perfusion is affected.
Not affected, that is normal physiological only. But this is the question which was asked. In anatomical dead space, ventilation is there, air is going, sir, air is there, but the blood supply is not there, the blood is not going. Okay, because there are no alveolus, the blood is not going, so there is no exchange, there is no exchange, there is no exchange. That's the point which I want to draw. So now ventilation, let's take the normal number, let's put the normal number 4, but what happened to the perfusion? It's again 0, so it becomes infinity. So this is the question which was asked. In anatomical dead space, in your anatomical dead space, if we are talking about anatomical dead space, what about the ventilation perfusion ratio? It is infinity. Infinity का meaning क्या है? No exchange, no exchange, no exchange. Here also say the blood is not going, blood is not going. When the blood is not going, there is no exchange. Okay, exchange is not happening. So just give me a second. Now, let me. Yeah, this is the question which was asked. This is the question which was asked. V by Q is infinity. Holds true in which of the following condition? In which conditions the infinity, V by Q ratio is going to hold true? This is the exact question which was asked in the FMG exam. And right now I have said you, V by Q infinity means it is seen in the dead space or conducting zone. Okay. Foreign body obstruction. What it will cause? Foreign body obstruction may ventilation perfusion ratio is going to be 0. Okay, 0. Okay, so that's it. That's the question. I'm just copying it. Copy and let me keep it in our PDF. So done. So the topic is completed. Ventilation perfusion ratios, ventilation perfusion mismatch, all that stuff is completed. Next, diffusion and transport of gases. Okay, diffusion and transport of gases. So shall I continue? Any doubts? Let me check if they are having any doubts. If you are having any doubts, let me check. So okay, let me try to ask you some question. Okay, just wait. Let me give you one question. Let me see whether you can answer it or not from the previous year questions. Based on yesterday's thing, let me see whether you can answer it or not. So you know this one, respiratory distress syndrome is due to deficiency of surfactant. Okay, the surfactant is produced by type 2 cells. This is okay, but this is also in yesterday's class we have discussed. Maximum smooth muscle thickness is there in terminal bronchioles. Terminal bronchioles have maximum smooth muscle thickness. I have discussed with you. Which blood vessels have maximum smooth muscles? Arterioles have maximum smooth muscles. In yesterday's class we have discussed. So okay, the question which I want you to know is, yeah, this one. Okay, so try to answer this question. Check once. This is what was asked in the 2021 FMG exam. 2021 FMG exam. Try to answer this. A 30-year-old patient with a respiratory volume of 500 ml. That is the tidal volume. He is taking how much? 500 ml. The intrapleural pressure before inspiration is -4 and -8 at the end of inspiration. Inspiration before it is -4, after at the end it is -8. Okay. The pulmonary compliance of this patient is, what is the pulmonary compliance? So students will scratch their head. Oh my God, what is this, sir? We don't know how to calculate. Are you know what they're asking? They're asking to calculate compliance. What is the formula of compliance? Compliance formula is delta V by delta P. How much is the volume change? How much air is going into the lungs? How much air is going into the lungs? Or how much volume the lungs are expanding? 500 ml. Okay. 500 ml air is going to the lungs. And how much pressure change is happening? Okay, how much pressure difference you are giving? -4 to -8 means the pressure is moving from, intrapleural pressure is going from -4 to -8. Means how much difference? Delta P, 4. So 4 divided by 500, how much? 125. So this is the compliance of the lung. in this patient. So 125 ml. Okay, for every 1 centimeter of water pressure, for every 1 centimeter of water pressure, lungs are expanding by 125 ml. This is the complaint. This much complaint the lungs are. Okay, so this is also a recent question. That's why. Copy. Okay, let me just copy it. Let me paste it here. Let me paste it in the topic of compliance. So concepts of compliance and elastance, paste. Okay, paste it. So the next topic which I want you to know is diffusion and transport of gases. So here we are discussing about diffusion. First, we are going to discuss about diffusion. Later, we'll be discussing about transport of gases. How the gases are transported, how the carbon dioxide and oxygen are transported. Diffusion, transport. Okay. In the diffusion transport of gases, the first law that I want you to know is Fick's law. Okay, Fick's law. Okay, Fick's law. So what is this Fick's law, sir? Fick's law ante enti asalu? What is it telling us? Fick's law. Fick's law tells us it's a diffusion is the dependent on diffusion of gases. Is dependent on what? Diffusion అనేది దేని మీద డిపెండ్ అయి ఉంటుంది? Diffusion is dependent on which parameters? Okay, so diffusion is dependent on which parameters? Diffusion is directly proportional to concentration gradient. Okay, diffusion is also directly proportional to the surface area, but diffusion is inversely proportional to thickness. There are three parameters. Diffusion is directly proportional to concentration gradient, directly proportional to surface area, and inversely proportional to thickness. Sir, what does it mean by? What does it mean by? Let's write one by one. See, first, diffusion is directly proportional to pressure difference. Look, here I am drawing two alveoli. Alveoli number A, alveoli number B. Okay, let me draw how exactly alveoli look like. So this is how alveoli look like. A alveoli, B alveoli. Okay, alveoli A and B. So here are the blood vessels. Okay, this is the blood vessel, pulmonary, capillaries. Okay, these are the blood vessels. Now, here the partial pressure of oxygen, for example, see here I'm talking about the partial pressure of oxygen in the alveolus. Here, for example, it is 100. Okay, here it is 100. Now, the partial pressure of oxygen in the artery, P small a, partial pressure of oxygen in the artery. Artery means small a, or the blood vessel. Okay, so how much is here? Here it is 1 mmHg. Same yesterday's principle. Here, the partial pressure of oxygen here is again 100. 100 mmHg. Here, the partial pressure of oxygen in the blood vessel is 99 mmHg. Where do you think the oxygen will diffuse? Where do you think the oxygen will diffuse? In A or in B? Where do you think the oxygen will diffuse? From the alveoli into the blood vessel. Where do you think it will diffuse? Both. Excellent. In both. But where do you think more gases exchange will occur? More diffusion will occur? Sir, it's in the A. Because here, what is the delta P in A? Delta P, here it is 100, here it is 1. What is the difference? Delta P, what is the pressure difference? 99 mmHg pressure difference. Here, what is the delta P? Here, the pressure difference is only 1 mmHg pressure difference. So, in both the cases, diffusion will happen. But here, more diffusion will happen because more difference is there. So, that's the Fick's law. So, diffusion is directly proportional to concentration gradient. More gradient, more diffusion. So, second example is, look, this is the healthy alveoli. This is how the healthy alveoli looks like a bunch of grapes. Okay, A. Now, if you see a patient who is having emphysema, in emphysema, the alveoli look like this, flat alveoli. Okay, flat alveoli, something like this. So, this is a patient having emphysema. Okay, this is normal. Now, see, here there is more surface area. Okay. Here there is more surface area, but here there is less surface area. Okay. So in emphysema patients, these septa are damaged because of the excessive activity of the proteases. Okay. In emphysema patients, these alveolar septa, which was supposed to be there, they are damaged. Damage ho gaya. Now you are having single large alveolus. Single large alveolus is there. So, mainly what happened here? Surface area reduced. If surface area is reduced, automatically area is less. So, automatically diffusion will also be less. So, here more surface area is there. So, more diffusion will happen. More the surface area, more diffusion. Here, the less the surface area, less diffusion. That's it. So, that's the second thing. So, diffusion is directly proportional to surface area. Okay. So, that's why, look, here I have written, in a patient who is having emphysema, emphysema is seen in whom? Emphysema, it is seen in people who are smokers. Okay, emphysema, it is seen in smokers. Okay, smoking people will have it. But not only smokers, people can have emphysema by birth also. By birth also, people can have emphysema. Why? If a baby is having alpha-1 antitrypsin deficiency, okay, by birth. Okay, so people can have emphysema because of two reasons. One can be congenital. Because of the alpha-1 antitrypsin deficiency, people can develop emphysema. Or even smokers can develop emphysema. In both the conditions, the alveolar basement membrane, alveolar septa is damaged. So surface area decreases. So diffusion decreases. Okay, diffusion is going to be less in emphysema. Emphysema low, diffusion less. Emphysema may diffusion less. Next, third example is, you have to tell me what is this condition. So this is the alveoli. Here I am showing you the alveoli. Okay, let me draw, otherwise you will confuse. So this is the alveoli. Now here is the blood vessel. Now what happened is, the patient is having excessive deposition of collagen material here. Okay, so the patient is having maybe silicosis or anthracosis. So excessive deposition of collagen material is happening because of the coal particles which are getting deposited. That will lead to inflammation. That inflammation can lead to the scar formation, fibrosis. So here is all the collagen. Okay, excessive scar formation is happening. Now tell me, so what is this condition? The patient is having pulmonary fibrosis. The patient ki pulmonary fibrosis undi. The patient is having pulmonary fibrosis because of the thickness. See, now the thickness of this area is increasing because there is excessive deposition of the collagen material. Now do you think diffusion can happen easily? No. So diffusion of gases decreases. So that's why in pulmonary fibrosis, okay, in pulmonary fibrosis, there is increase in the thickness of the alveolar basement membrane because of the collagen deposition. Thickness increases. When thickness increases, what happened to the diffusion? Diffusion decreases. That's it. When thickness increases, diffusion decreases. Okay, next. Sir, how to measure this diffusion? How to measure this diffusion? So physiologists, they don't have any work. Okay, so they are measuring how diffusion occurs, that this. So they, for calculating the diffusion, there is a study. Okay, that study is called as DLCO. Okay, diffusion, it is measured by a study called as DLCO. What is the DLCO, sir? Diffusion in the lung. Okay, diffusion in the lung. DLCO means diffusion lung used by carbon monoxide. Diffusion is studying in the lung using which gas? Carbon monoxide, because carbon monoxide is a better gas. It has better solubility. It has better solubility. It have more binding capacity with the hemoglobin. Okay, so the carbon monoxide, not dioxide, you strike it out, it's a typing mistake. So carbon monoxide has more affinity for hemoglobin. It's a better soluble gas. It's a better it's going to be better to study the diffusion. Okay, so remember, diffusion, it is measured with the help of a study called as DLCO. Diffusion in the lung using carbon monoxide. Okay, diffusion capacity in the lung using carbon monoxide. Now you think logically, sir. Simple, small, like 10th class topic. Sir, DLCO increased means what? DLCO increased means diffusion increased. Means the diffusion of gases is increasing. Means the diffusion of that carbon monoxide is increasing. More carbon monoxide is getting diffused. DLCO decreased means diffusion decreased. In which conditions? Which conditions? So in which conditions diffusion increased. Polycythemia. What is polycythemia? It's a type of cancer, sir. More RBC. Okay, polycythemia vera. There is more number of RBCs. Lots and lots of RBCs are there in polycythemia vera. More RBCs means what? More hemoglobin. More hemoglobin means, hemoglobin will uptake the carbon monoxide very easily. So more buses are coming. Bus is nothing but RBC. More blood flow is there. Polycythemia mein more RBC are going, more hemoglobin is there. When more hemoglobin is there, it will readily uptake the carbon monoxide very quickly. Carbon monoxide is being uptaken. So diffusion is going to be more. Simple. So more RBC, more diffusion. Polycythemia, more diffusion. Exactly opposite thing. Anemia. Anemia mein less RBC. Less RBC means less hemoglobin. Less hemoglobin is going to the lungs. Less hemoglobin means less uptake. So diffusion decreases. So DLCO is going to be less. Try to remember like that. Okay. Now, diffusion is going to be more in which conditions? Diffusion of gases is going to be more. More diffusion, more DLCO in which conditions? Exercise. Okay. So when you do exercise, what happens? Heart rate increases. What happened to the stroke volume? Stroke volume increases. What happened to the cardiac output? Cardiac output increases. So more blood flow to lungs. More blood is going to the lungs. When more blood is going to the lungs, more RBCs are going to the lungs, more hemoglobin is going to the lungs. So more blood flow means more exchange. More blood is going means more exchange. So diffusion increases in exercise. And DLCO is going to be more during exercise. And we have already studied, just now we have discussed, diffusion is decreased in emphysema. Emphysema mein, surface area is less. Okay, let me write full form here. Surface area is less. When surface area is less, diffusion is going to be less. So less DLCO. Pulmonary fibrosis, it. So thickness increases. When thickness increases, the diffusion decreases. Done. So, done, sir. This is also a question which was asked in the exam, so we have included. So DLCO increase in which conditions? DLCO decrease in which conditions? Oh yeah, done. Next, transport of gases. So take a deep breath, sir. Take a deep breath. I want you to take a deep breath. Now diffusion of gases completed. Now the transport of gases. In the transport of gases, let me tell you one thing. If you want to study one thing in respiratory system, in the respiratory physiology, in the respiratory physiology, if you want to study one topic in respiratory physiology, you study something called as oxygen hemoglobin association dissociation curve. Okay, oxygen hemoglobin association dissociation curve. After that, study about volumes and capacities, spirometry graph. Okay, spirometry graph. After that, study about those curves, like obstructive lung diseases, restrictive lung diseases, FEC, FEV1. Okay, so first to give highest importance to oxygen hemoglobin association dissociation curve that I'm going to discuss now. Now I will discuss that in next 10 minutes. Okay, first important area is oxygen hemoglobin association dissociation curve, right shift, left shift. Second thing, spirometry, tidal volume, inspiratory reservoir volume, expiratory reservoir volume, nothing. Third, FEV1 by FEC ratios, obstructive lung diseases, restrictive lung diseases. Okay. Next, surfactant, very important surfactant, respiratory distress syndrome, type 2 pneumocytes. Surfactant decreases surface tension, that area. Okay, that area. Okay. So tomorrow holiday, why holiday? Tomorrow is Sunday, no? There is no such thing as holiday. In your, no holiday tomorrow, no holiday. Sundays are not holidays in our eyes, not in our eyes, any coaching institute. Sundays are not holidays. And if management asks me to take holiday, I will take holiday. Like, it's all on the management. Who? Okay, chalo. Look at this. Listen carefully. Based on the topic which I'm going to discuss now, you have to answer certain, you have to calculate certain things. Okay? Sir, how many gases do we have? Two major gases. Oxygen. We have to take the oxygen. Okay, we have to take the oxygen. By using that oxygen, we will produce the ATP. In the electron transport chain, oxygen is help. Okay, we'll take the oxygen for the production of ATP. Glucose and oxygen we will take and we'll convert it into ATP, right? So oxygen, we require the oxygen. Okay, and your tissues during the electron transport chain, your tissues will produce what? Carbon dioxide. Your tissues are producing the carbon dioxide. So okay, how many gases do you have? Oxygen gas is there, carbon dioxide gas is there. Okay, now oxygen from lungs. See, from lungs you have to transport it to the tissues. Okay, from lungs you have to transport it to the tissues. Okay, so how you are transporting? The oxygen will be transported along with hemoglobin. Okay, so most of the oxygen, how much percent oxygen? 97% of the oxygen. 97% of the oxygen is transported in the form of oxyhemoglobin. Oxygen and hemoglobin. Okay, they are marrying each other. They are like girlfriend and boyfriend. So hemoglobin is going to bind with the hemoglobin is going to hug the oxygen. 97% of the oxygen is traveling in that form, but only 3% of the oxygen, 3% of the oxygen is going to be dissolved in the plasma. Okay, 3% of the oxygen is not binding with the hemoglobin. It is simply dissolved in plasma. But the most important MCQ, if I am the examiner, I will give you this question. This dissolved oxygen is responsible for partial pressure. Dissolved oxygen is responsible for the partial pressure of oxygen, PaO2. Partial pressure of oxygen in the blood vessel is due to what? Is not because of the oxyhemoglobin, it is because of the dissolved oxygen. Some students will have it out, sir. I couldn't understand what you are saying, sir. But don't worry, in 5 minutes I will explain you. Just know this one point. Partial pressure of oxygen, partial pressure of oxygen is because of dissolved oxygen. Okay, the dissolved oxygen is responsible for the partial pressure. Okay, now carbon dioxide. So carbon dioxide, we have to transport it from tissues. We have to transport it from the tissues to lungs, back to the lungs, tissues to the lungs. We have to transport the carbon dioxide. How carbon dioxide is transported? Majorly in the form of bicarbonates. Okay, that's the question. Majority of the bicarbonates are transported in the form of HCO3 minus. That's the bicarbonates. That's a major transport. And other in the form of carboxyhemoglobin. Okay, other in the form of carboxyhemoglobin. Major transport is bicarbonates. Okay, now see some basics. Take a deep breath. Now, sir, 1 gram of hemoglobin, you are having hemoglobin no, in your RBC. You are having hemoglobin in your RBC. Okay, sir. 1 gram of hemoglobin can carry, see, hemoglobin, I said, it carries oxygen. Okay. 1 gram of hemoglobin can carry how much oxygen? 1 gram of hemoglobin can carry 1.34 ml of oxygen, sir. Okay. 1 gram can carry 1.34 ml. But in a healthy individual, have you ever done your hemoglobin test, HB? So if an adult male, so if I go and check, okay, my HB, it will be somewhere around 15. So what is that 15 value? See, in a healthy person, 15 grams of hemoglobin is there per deciliter. Deciliter means how much? 100 ml. Deciliter means 100 ml. Okay. In my 100 ml of blood, in my 100 ml of arterial blood, if you take, see, I'm giving you, okay, for the sake of array students, I am giving 100 ml of my blood. In this 100 ml of blood, how much hemoglobin is there in the RBC? 15 grams of hemoglobin is there. Okay. So how much oxygen is there? Now tell me. Sir, 1 gram can carry 1.34 ml. So 15 grams can carry. So 15 into 1.34. So how much is that? 15 into 1.34. How much oxygen is there? Approximately 20 ml. Okay, approximately 20 ml is there. Okay. So how much oxygen do you have in your blood? 20 ml of oxygen is present in 100 ml of your arterial blood. Is that okay? Now, you can ask me, sir, why is that important, sir? If you ask me, yes, of course, I will say it's important. Because, let me show you why it is important. Just give me a sec. Look, this is a question which was asked in FMG exam. This is a question which was asked in FMG exam. So, see, the respiratory recent exam this is a question which was asked. Okay. So, What is that question? Look. What is the oxygen carrying capacity of an 18-year-old boy with a hemoglobin of 14 grams per deciliter? FMG question. Okay. So you know oxygen carrying capacity. Okay. 18-year-old boy. Hemoglobin is 14. So 14 into 1.34. That's it. That is oxygen carrying capacity, right? How much oxygen is having in the 100 ml of blood? So 14 into 1.34. How much? 18. So how much oxygen he's carrying? 18 ml of oxygen in 100 ml of blood. Okay. So 18 ml of oxygen. So this is how the questions will come. Okay. So let me take this copy. Let me give it here. Paste. Now, let me discuss things a little bit more detail. Sir, with your beautiful hands, try to draw this. Okay, try to draw this with your beautiful hands. I will be going little slowly because if you miss one point, the total concept will be collapsed. Okay, total concept will be collapsed. Please be attentive. First, ये क्या है? This is your alveolus. Okay, this is your alveolus at the level of lungs. Now here I am showing you the tissues. EBM tissues. These are your tissues. What do they require? Oxygen. Tissues require oxygen. Where is the oxygen present? Oxygen is present here. What is the partial pressure of oxygen in your alveolus? The partial pressure of oxygen in your alveolus. P capital A O2, you know it. 104 mmHg. 104 mmHg. For easy understanding purpose, let's make it 100. Round figure. 100 mmHg. Okay, sir. Oxygen is there in the alveolus. Now, draw this. This side, I am showing the red color. Here I am showing which color? Red color. Red color means what? Arteries. So these things are your arteries. Okay. This side arterial blood. On the other side, here, look at this. This is your venous side, which means your venous blood. Okay. Now let's start. First, let me draw here one hemoglobin molecule. So here in the venous blood, I'm talking, see, in the venous blood, I'm showing you what? One hemoglobin molecule. In the venous blood, one hemoglobin molecule. Now, what I want you to know is one hemoglobin molecule. Let me write here. One hemoglobin molecule can carry how many oxygen molecules? Not 1 gram of hemoglobin. I'm not talking about 1 gram. One hemoglobin molecule can bind with 4 oxygen molecules. 4 molecules of oxygen. This is a hemoglobin molecule. One hemoglobin molecule, not 1 gram. One hemoglobin molecule can bind with 4 oxygen. But in the venous blood, look, in the venous blood, it is having 1 oxygen, 2 oxygen, 3 oxygen molecules, which means hemoglobin is carrying how many oxygen molecules? Only 3. Only 3. One is empty. One place is empty. Okay. Venous blood means what? From now you should say venous blood mein hemoglobin is how much percent saturated? HB saturation how much? Only 3 pockets are occupied. Only 3 places are occupied. So hemoglobin saturation is 75%. If 4 molecules are occupied means 100%. But one place is empty. So hemoglobin is 75% saturated. And how much hemoglobin is there? Sir, doesn't matter whether it is arterial blood or venous blood. Doesn't matter. How much hemoglobin is there? Hemoglobin is same 15 grams. Same 15 grams of hemoglobin is there. How much saturated? 75% saturated. Now, for now, just remember this one point. What is the partial pressure of oxygen here? What is the partial pressure of oxygen in the venous blood? Sir, remember it is 40 mmHg. Why it is 40? I will tell you. 40 mmHg. Okay. And how much oxygen is there in the venous blood, not arterial blood? Venous blood. Arterial blood, you know it. 20 ml of oxygen in the arterial blood. Here I have calculated 20 ml of oxygen is there in the arterial blood. In the arterial blood. Now this is venous blood. How much oxygen is there? You know, 15 ml oxygen. Because one oxygen is not there here. Don't forget about it. Okay. So only 15 ml oxygen is there. Okay. These are the parameters which I want you to know. So look at the same parameters in this diagram which was already given in your book. Sir, my book look at this in your book. Sir, in the venous blood, this blue color thing, venous blood, only 3 oxygen molecules are there. So hemoglobin molecule is how much percent saturated? 75% saturated. Hemoglobin, 15 grams is there. Partial pressure of oxygen, 40 mmHg. How much oxygen is there? 15 ml oxygen is there. Okay. Now, what happens? Now what happens is, look carefully. Sir, just look carefully. Now, this hemoglobin molecule is coming to the lungs. Now it's at the level of the lungs. Now it came to the lungs. Now you tell me, sir, first what happens? What is the partial pressure here? Tell me. Sir, here the venous blood is coming. No, the same venous blood is coming. As the venous blood is coming, what is the partial pressure here? The partial pressure of oxygen here is 40. First thing, 40. How much is the partial pressure of oxygen here? 100. Now tell me, according to the fixed principle, the gases will move from high partial pressure to low partial pressure. So immediately the gases are coming. Who came immediately? Oxygen came. 100 molecules, for example, 100 molecules of oxygen came. Okay. So now oxygen came here. Now what happens is, first to see 3% out of this 100% of oxygen, whatever have came, out of the 100 molecules of oxygen, whatever have came, first thing, 3% of the oxygen is dissolving in the plasma. First thing that happens, 3% of the oxygen is dissolved in plasma. As 3% of the oxygen is dissolved in the plasma, look, as the 3% of the oxygen is dissolved in the plasma, now the partial pressure, which was 40, it is going to, let me write in the red color, because now blood became oxygenated. So the partial pressure of oxygen becomes 100 mmHg. Okay, now you understand. See, it's the dissolved oxygen. Now it's the dissolved oxygen which determines the partial pressure. 3%, due to the dissolving of the 3% of the oxygen in the plasma, the partial pressure is raised. Okay, partial pressure is raised. Okay, now whenever partial pressure is raised, now the partial pressure is raised. Now what happens, you know? Now the remaining 97% of the oxygen. Okay, now remaining 97% of the oxygen, whatever have came into the blood, now that 97% is going to be binding with the hemoglobin. Now hemoglobin accepts the oxygen. Now this last part, which is free. Now now what happens? Look, now the hemoglobin will accept. When the partial pressure increases, now hemoglobin will accept that new oxygen molecule. Kotta oxygen molecule accept chestun. Now the hemoglobin is accepting the oxygen molecule. But what is the first event that should happen? First thing jaragali. What is the first event that should happen? First 3% of the oxygen should be dissolved in the plasma, because of which the partial pressure increases. When the partial pressure increases, only then hemoglobin binds with the oxygen. Hemoglobin accepts the oxygen. So can I say something like this? Okay. It's the partial pressure. Let me write. Partial pressure determines. Okay. So what it determines? Partial pressure determines the binding of. Okay. The partial pressure determines the binding of oxygen to hemoglobin. Okay. So you understood? So when the hemoglobin is going to bind with oxygen, whenever the partial pressure increases. Why the partial pressure increases? The partial pressure increases because of the dissolved oxygen. How much oxygen is going to be dissolved? 3% of the oxygen is going to be dissolved. So that partial pressure becomes 100 mmHg. Now, say here it is 100, here it is 100. Equilibrated. Okay, understood? Okay, understood. So now tell me. Okay, for some students who doesn't understand, imagine all the boys who were there. Okay, I'm asking their question to the girls. what determines, like, these doctors, all our students are doctors. Now these doctors, like, how they will be first, whenever it's a time to marriage. Okay, what determines the marriage? What determines the marriage? Dowry. Give you more dowry, I will marry. No dowry, no marriage. In the same way, dowry is first step. If the bride's father, okay, if the girl's father, if they say we will be giving dowry, the boy is going to accept. No dowry, no acceptance. Simple, right? In the same way, hemoglobin. If partial pressure increases, I will accept. If partial pressure is less, I won't accept. That's the concept. Okay. So now let's write the parameters one by one. Now you know how much hemoglobin is there in the arterial blood. Now the blood become arterial. Now it is oxygenated blood. Now it is arterial blood. Now tell me one by one, how much hemoglobin is there? Same hemoglobins are 15 grams. What is the hemoglobin saturation? Hemoglobin saturation is how much? Please tell me, hemoglobin saturation is how much? 4 molecules are occupied. So 100% saturated. Okay, 100% saturated. Hemoglobin saturation, 100% saturation. Okay, 100%. Now, what is the partial pressure of oxygen in the arterial blood? What is the partial pressure of oxygen now? Here in the arterial blood. The partial pressure of oxygen here is how much? 100. Now it become 100 because of the 3%. Okay, it become 100. Okay, mmHg, 100 mmHg. Okay, now in the arterial blood, now more oxygen is there. So how much oxygen is there? Now you already know it. 20 ml oxygen is there. Okay, 20 ml oxygen is there per deciliter in 100 ml. In 100 ml. Okay, 15 grams of hemoglobin is there per 100 ml. Okay, so the same thing which I have given in your book also. The same thing which I have given in your book also. Okay, don't worry, I will come here. Don't worry, I will come here. Come here. Okay, look at what is there in your book. In arterial blood, 4th molecule of oxygen is also there. Hemoglobin 15 grams. Hemoglobin saturation 100%. Partial pressure of oxygen 100 mmHg. Oxygen how much? 20 ml. Okay, done. Next, what I should teach you. Look at the level of your tissues. In your tissues, the God have tissues are using oxygen continuously using oxygen. So at the level of your tissues, what happened is, look, the partial pressure of oxygen in your tissues, always this is constant. It is 40 mmHg. Okay, the partial pressure of oxygen, how much? It is constant, sir. It is there, 40 mmHg. It's always God have designed like that. Me tissues, in your tissue, the partial pressure of oxygen is 40 mmHg. Okay, so now what is happening? See, now the arterial blood. Okay, now the arterial blood is coming like this. The arterial blood is coming like this. Look, here is the hemoglobin molecule. Our hemoglobin is in green color, right? Here is the hemoglobin molecule. In all the 4 places, who is there? Oxygen is there. Oxygen, 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 oxygen. All 4 places, oxygen is there. Okay, the last oxygen is a special oxygen, right? It's a new oxygen. Okay, now you tell me, what is the partial pressure of oxygen in the blood? The partial pressure of oxygen here in the blood. Partial pressure of oxygen here is 100 mmHg. You know it, 100 mmHg. Now you tell me, according to the fixed principle, here it is 40, here it is 100, here it is 40, here it is 100. So immediately, do you know what happens according to the fixed law of diffusion? According to the fixed law of diffusion, immediately oxygen, the 3%, the dissolved oxygen, whatever is there, that oxygen is going to diffuse into the tissues. The oxygen is getting diffusing into the tissues. Okay, the oxygen is getting diffusing into the tissues. So as the oxygen is diffused, as the dissolved oxygen is diffused, do you know what happens now? The partial pressure from 100, it is equilibrating. The partial pressure, it is becoming again 40. Now it is becoming 40. Okay, so that's why in the venous blood, now it is becoming venous. See, the partial pressure of oxygen, because the oxygen is dissolved, the partial pressure, it is becoming 40. Now what happened to the partial pressure? Dowry is becoming less. Dowry is becoming less. Now there is less dowry. Oh my God, if there is less dowry, I don't accept. If there is less dowry, I don't accept. Straightforward. So as the partial pressure is decreasing, now immediately hemoglobin, what it will do? It will throw the oxygen to the tissues. Okay, so the oxygen is removed from here. The oxygen is released from here. Now this oxygen will also go to the tissues. Okay, so who determines the release of oxygen or the binding of oxygen? Who determines? It is the dowry. It is a partial pressure. Okay, so you understood? First dissolved oxygen, first the dissolved oxygen will go into the tissues, so that partial pressure will become 40. So whenever there is less partial pressure, see, whenever there is less partial pressure, immediately hemoglobin ingestundi. What hemoglobin will do? Hemoglobin releases the oxygen to the tissues, so oxygen is delivered to the tissues. Okay, so oxygen is delivered. So as the oxygen is delivered, what happens? Here is 20 ml of oxygen, so here it is only 15 ml of oxygen. Means how much oxygen is delivered to the tissues? How much oxygen is delivered to the tissues? 5 ml. 5 ml of oxygen is delivered to the tissues. If 100 ml blood, look, if 100 ml blood is going, 5 ml is delivered to the tissues. 100 ml blood will deliver how much oxygen to the tissues? 5 ml of oxygen is delivered to the tissues. Done. 5 ml of oxygen is delivered to the tissues. Okay, so this is what I want you to know. Again, partial pressure become 40, equilibrated. Here it is 40, here also it become 40. So that's why I said in the venous blood, the partial pressure of oxygen is 40. Okay, when 100 ml of arterial blood, see, when 100 ml of arterial blood, when it is going to the tissues, how much oxygen is delivered to the tissues? 5 ml oxygen is delivered to the tissues. Okay, 5 ml of oxygen is getting delivered to the tissues. So, sir, it's one of the hard topic. Okay, it's one of the highly conceptual topic. Tell me, have you understood or not? Have you understood? Come on, guys. I want the answers from at least 10-15 students. If you confirm me, sir, yes, we understood, then I will feel like, okay, I have done justice. So, okay, done. Now I will ask some questions. You guys try to answer them. Okay, I will ask some questions. You just try to answer them. What is the partial pressure of oxygen in the venous blood? What's the partial pressure of oxygen in the venous blood? Okay. What's the partial pressure of oxygen at the level of tissues? Not 45, 40. 40, 40, 40. What's the partial pressure of oxygen at the level of tissues? Tissues may 40. Tissues may 40. What is the hemoglobin saturation in the venous blood? Hemoglobin saturation in the venous blood? 75%. 75%. Who determines the binding of oxygen? Who determines the binding of oxygen to the hemoglobin? Or who determines the releasing of oxygen from the hemoglobin? Who determines? Partial pressure of oxygen. Partial pressure of oxygen. Yeah, excellent. Partial pressure of oxygen. Okay, PaO2, partial pressure of oxygen. Now tell me, partial pressure of oxygen. I'm giving you a statement. Tell me, is it true or false? Partial pressure of oxygen is due to oxyhemoglobin. True or false? Partial pressure of oxygen is because of oxyhemoglobin. True or false? Partial pressure of oxygen, is it because of oxyhemoglobin? No, it is because of dissolved oxygen, the 3%, not oxyhemoglobin. Oxyhemoglobin is 97%. Okay, so the partial pressure is determined by, that's why here I have given partial pressure is determined by whom? See, dissolved oxygen in the plasma is responsible for the generation of partial pressure. Okay, done, sir. So let me tell you a small calculation. Look, I'm asking you, sir, 100 ml of blood. Just know it. If 100 ml blood, if it goes to the tissues, how much oxygen is delivered? 5 ml oxygen is delivered. But my question to you, do we have only 100 ml blood? No. For example, see, if 1000 ml blood is going to the tissues, how much oxygen is delivered? How much oxygen is used by the tissues? How much oxygen is taken by the tissues? 50 ml. But do we have only 1000 ml blood? No, we have how much blood? 5000 ml blood, which means 5 liters of blood. So if 5 liters of blood, look, if 5 liters of blood every minute going to the tissues, so how much oxygen is taken by the tissues? How much oxygen is delivered to the tissues? 250 ml, which means for your survival, okay, every minute, how much oxygen is delivered to the tissues? 250 ml of oxygen. Understood? See, your tissues will take how much oxygen every minute? 250 ml. Your tissues require 250 ml of oxygen every minute. Okay, that is the thing. So this concept is also done. Next, I have said you in the respiratory, the most important topic, if you want to know only one thing before the exam, that is this only: oxygen hemoglobin. Okay, oxygen hemoglobin association dissociation curve. Okay, this Bohr's effect, Alzheimer's effect, I will tell you in a minute. First, oxygen and hemoglobin, their relationship, association. Their association means marriage, dissociation means breakup. Okay, that divorce. So that we are going to discuss. Oxygen hemoglobin association dissociation curve. First, let me ask you one question. Simple, sir. Hemoglobin will love to bind with oxygen. Hemoglobin likes oxygen, or hemoglobin doesn't like oxygen? Please tell me. Hemoglobin, it loves oxygen or it doesn't love oxygen? Please tell me one thing. Hemoglobin, will it love oxygen or it doesn't like oxygen? Can you tell me? Subhatra is saying love. Satish is saying likes. Priyadarshini is saying, Ovais is saying both. Say here, Rekha, here Ovais is correct. Ovais is correct. Here actually Ovais is correct. Array, I said you hemoglobin is like a boy. Whether he loves wife or doesn't like wife depends on what? Dowry. In the same way, look, hemoglobin at the level of lungs. See, hemoglobin at the level of lungs, it is loving the oxygen. It is binding the oxygen. But the same hemoglobin at the level of tissues, it is kicking the oxygen out. So hemoglobin, will it love oxygen or will it doesn't love oxygen? Depends on what? Depends on partial pressure. Remember, depends on partial pressure. Yes, OIC is true. Will it love oxygen? It doesn't love oxygen. It's love. Hemoglobin love for oxygen depends on partial pressure. Remember that one point. Okay, that's what we are going to discuss now. So, look, the concept is, I have already taught you. Whenever partial pressure is more loving. Whenever partial pressure decreases, more dissociation, breakup, means it is releasing. Okay, so that's the concept. So right here, whenever, see here I have written, whenever partial pressure of oxygen is increasing, whenever partial pressure of oxygen is increasing, more binding. The fourth oxygen molecule is binding. When partial pressure decreases, dissociation. Dissociation means leaving the oxygen. It leaves the oxygen. It kicks the oxygen to the tissues. Okay. So that's it. Same here also. See, whenever partial pressure increases, then hemoglobin binds with the oxygen, so saturation increases. If partial pressure decreases, hemoglobin saturation also decreases because it is leaving the oxygen. So hemoglobin saturation will come to 75. You know it. Okay. So after saying that basic thing, now I'm going to discuss about this curve. Listen with both the ears. If you're having third ear, listen with that also. It's that important. First thing, please make a small correction. There is a small mistake here. The mistake is, this is left shift. Okay, true. Here it is not left shift. This is right. Please write here right. Right. This green color dotted line. This green color dotted line is right shift. Right shift. Okay, it's called as right shift. The green color is the right shift. It's a typing mistake. Now, let me tell you a story. Let me tell you a story first. Imagine, look at me. I'm the person. Imagine I'm the person. So what I'm doing is in the morning, imagine I'm a student. Okay, imagine I'm a student. In the morning, I'm studying. In the morning, every day, I'm studying. Okay, I'm attending the medical college. I'm studying. In the evenings, what I'm doing is, I'm stealing the things.
Okay, I'm going to the banks. I'm going to the bank and I'm stealing the thing every day. What I'm doing is I'm stealing 100 rupees every day. Okay, I'm just stealing only how much? 100 rupees. But I'm a good thief. I'm a good thief. Why I'm a good thief? Because out of that 100 rupees, whatever I'm stealing, in my surrounding area, there is a family, poor family. They do not have anything. So every day, out of that 100, I'm giving 25 rupees charity. Okay, I'm giving 25 rupees. Array, please take it. Okay, you are also in trouble. You take it. So every day I'm doing the same thing. Every day I'm stealing. In that 100 rupees, how much I'm giving the charity? 25 rupees. This is the regular thing I'm doing. But I came to know suddenly the family to which I'm helping, they are into deep shit. They are into deep trouble. Okay. Now they got into some trouble, financial crisis. Now tell me, if I'm a good fellow, if I'm a good Samaritan, okay, if I'm a good fellow, what I have to do? So now I have to give only 25 or I have to give more? You tell me. Now if they're into trouble, financial trouble, now what I should do? You tell me. I have to do more charity. I have to give more. I have to give more. Whenever there is a need, I have to give more. So, okay. Now, after 6 months, for example, after 6 months, they got lottery and they became, for example, a millionaire. They got millionaire. Do you think I will be giving the charity to them? Do you think I will be giving the same charity? No. Simple. Or if they want, I will give them. If there is a need, I will give them. If there is no need, why would I give? I won't give. So hemoglobin also behaves in the same way. Hemoglobin also behaves in the same way. Whenever there is a need, hemoglobin will give more oxygen to the tissues whenever there is a need. Whenever there is no need, it won't give oxygen. It won't give oxygen. So that's what I will tell you right now. That's what I will tell you right now in this graph. Okay, look. First, this blue color line, the blue color solid line is normal. Okay, this blue color solid line is normal. First. So what is this blue color solid line, sir? First, look at the x-axis. In x-axis, I am talking about the partial pressure of oxygen. Partial pressure of oxygen in the blood. Okay, partial pressure of oxygen in the blood. Now, 0, 10, 20, 30, 40, 50, 60, 70, 100. You know it. Partial pressure of oxygen. You know partial pressure of oxygen. Now, in the y-axis, okay, on the y-axis, I'm talking about hemoglobin saturation. You know, hemoglobin sometimes is 100% saturated, sometimes it is 75% saturated. You know it. Aha, okay. So let me tell you what is normal. See, in your arterial blood, what is the partial pressure of oxygen? 100 at the level of lungs in your arterial blood. What is the partial pressure of oxygen? Sir, at the level of lungs, partial pressure of oxygen is more. So it is 100. When the partial pressure of oxygen is 100, look. When the partial pressure of oxygen is 100, what is the hemoglobin saturation? Can you tell me? Sir, hemoglobin saturation is also 100. Hemoglobin is 100% saturated. Okay. One thing completed. Okay. When the partial pressure of oxygen is more, hemoglobin is more saturated. But look at the tissues. Look at the tissues. At the level of tissues, you know, the partial pressure of oxygen is how much? 40. You know it. When the partial pressure of oxygen is 40, hemoglobin is releasing the oxygen. One molecule of oxygen is released. So hemoglobin is becoming how much percent saturated? When one molecule of oxygen is released, hemoglobin is becoming how much percent saturated? Now look at the blue line. Hemoglobin is how much saturated? This one, no, blue line, normal. Hemoglobin is becoming 75% saturated. Okay. So at the level of lungs, high saturation. At the level of tissues, it is getting 75% saturated. You know this. Means 75% saturated means what? 75% saturated means how many molecules is released? One molecule of oxygen is released. That is normal. One molecule of oxygen is released. That is normal. Okay. Now look. Now I'm going to talk about right shift. So what is this right shift? See, now right shift means the person is going on a marathon race. Imagine the person is going on a marathon race. He is exercising. Okay, sorry for the spelling mistake. But anyway, he is going on a marathon race. Exercise. Now, whenever he is doing exercise, his tissues, right? His tissues demand more oxygen. Now his tissues require what? More oxygen. Okay, his tissues demand what? More oxygen.
Okay, his tissues demand more oxygen. Now, let me tell you, sir, whenever he is exercising, okay, whenever he is exercising, what happens in his body? Sir, oxygen levels are going down in his body because oxygen is getting utilized. Okay, oxygen levels are going down. Whenever he is exercising, his carbon dioxide levels goes up in his body. Hypercapnia is going to be say there. There is high, like more hypercapnia or hypercarbia is going to be there. The carbon dioxide levels are going to go up. The oxygen levels are going to go down. Whenever you do exercise, lactic acid is produced. That will cause acidosis, lactic acidosis. Okay, whenever there is acidosis, the proton concentration increases in your body. The pH is going to go down. Acidosis means low pH. And whenever you do exercise, what happened to your body temperature? Your body temperature increases. And whenever you do exercise, biochemistry, whenever you do exercise in biochemistry, there is production of a chemical called as 2,3-BPG in your RBC. Okay, in your RBC, who is getting produced? 2,3-bisphosphoglycerate. Okay, now let me tell you, all these conditions, okay, will influence the hemoglobin. They will influence the hemoglobin in such a way that hemoglobin will deliver more oxygen. Okay, instead of delivering one oxygen molecule, it will deliver two oxygen molecules. Or for example, say your girlfriend, imagine you are having a girlfriend. Sometimes she behaves differently. For example, she behaves differently. Sometimes she behaves completely. Sometimes she's like an angel. Sometimes she's like a devil. According to the situation, she will change. According to the situation, she will change her behavior. In the same way, right now, there is exercising condition. Okay, so whenever there is exercising condition in your body, what kind of environment is generated? There is hypercarbia, hypoxia, acidosis, body temperature increasing, pH is decreasing. So whenever such environment is there in the body, they will change the hemoglobin structure in such a way, rather than giving one oxygen molecule to the tissues, now it will give more oxygen molecules, two oxygen molecules to the tissue. So look here, that's the same thing which I'm showing in the green color dotted line. Okay, the green color dotted line. Okay, so let me erase these things so that you'll have a better understanding. Okay, so right shift. Let me show you the right shift. Green color, right? Look. Now, what is normal? What is normal? At the level of tissues, normal, what is normal? Look here. Normally, hemoglobin should be 75% saturated. But what is happening in the right shift? Right shift is this green color dotted line, right? This green color dotted line. Look, now hemoglobin is how much percent saturated? Sir, hemoglobin is only 50% saturated. 50% saturated means 50% desaturated. Okay, if only 50% saturated, which means the hemoglobin have delivered two oxygen molecules to the tissues. Okay, so hemoglobin is saying, oxygen, you go. Tissues require oxygen. You please go. You please go. So more oxygen is going to the tissues. So that's why hemoglobin, this is a low affinity. Hemoglobin is not binding with oxygen. Hemoglobin is kicking the oxygen. Hemoglobin is throwing the oxygen. So right shift is an example of low affinity state, and right shift is seen in which conditions? Hypercarbia, hypoxia, acidosis, low pH, and increased temperature, and the presence of chemicals in the RBC like 2,3-bisphosphoglycerate. That's it. If you understand this, it's like you got one MCQ. That's it. In your exam, in your June attempt, this question is going to come up in your exam. Right shift is seen in which conditions? Okay, just hemoglobin is like your girlfriend. It behaves differently. Whenever there is a need, it delivers more oxygen. That is called as a right shift. Whenever your tissues require more oxygen, it will deliver more oxygen. Instead of one oxygen, it will deliver two oxygen molecules. That's it. Okay, just like the thief, whenever there is a need, the thief, whenever there is a need, he gave more money to the charity. So something like that. So, guys, can you tell me, like Abra is saying, sir, can't understand. Is it same with everyone? Is it same with everyone? You understood? Yes. I will show you the questions. Okay, I will show you the questions. Don't worry. I will show you the questions. Are abra? Simple. Look, normal. Let me ask you what is normal. Let me ask you what is normal. How many oxygen molecules are delivered to the tissues? What is normally? One hemoglobin, where it is going to the tissues. One oxygen molecule is delivered. Last fourth oxygen molecule is delivered to the tissues. That is in a normal resting state in me. I'm resting. One oxygen molecule is delivered. Okay. But imagine right now, if I start to run, I'm starting running. Okay, marathon race, I'm starting running. So there will be hypoxia in my body, hypercarbia in my body. Okay, hypoxia, hypercarbia, temperature increases, 2-3 BPG is produced in my RBCs. Lactic acidosis is going to be there. These conditions, whenever these conditions are there in the body, hemoglobin structure is altered. The structure of hemoglobin is changed in such a way. Now, instead of delivering one oxygen molecule to the tissue, the hemoglobin will deliver more oxygen to the tissue. That is something good, because when you are doing exercise, more oxygen should go to the tissues. So that is called as a right shift. Okay, that is called as right shift, because the curve is shifting to right. Okay, the curve is shifting to right. Okay. Now look at the left shift. Look at the left shift. Now you will have better clarity, better understanding. Okay. Now imagine the person. So here I'm talking about the left shift. Imagine the person is not doing any work. He is into hibernation. Okay, he is not doing any work. He is in the cold climate. He's in the cold climate. So look, cold climate. Okay, his body temperature is going down. In cold climate, you know, your metabolism decreases. Your metabolism decreases. When your metabolism is decreasing, you require more oxygen or less oxygen? You require less oxygen. Less oxygen is enough. So now, see, whenever you are in the cold climate, or when you are hibernating, when you are not doing any work, okay, resting conditions, what happens? Your body temperature decreases. Okay. And whenever you are hibernating, when you are not doing any work, mild alkalotic environment is developing in your body, alkalosis. What happens when you are not doing any work? Proton production decreases in your body. Carbon dioxide levels decreases in your body. So if you do more work, more carbon dioxide production. If you do less work, less carbon dioxide production. What happened to your pH? pH increases. Alkalosis means more pH. So these conditions will influence the hemoglobin in such a way. The patient is not doing any work, there is no demand of oxygen. So hemoglobin will say, you don't want any oxygen. So hemoglobin delivers less oxygen. Hemoglobin delivers less oxygen. So that is the left shift. Okay, left shift. Look here. Let me show you the left shift. Okay, let me copy this. Okay, no issue. Let me show you the left shift. Here, this is the left shift, right? Here is the left shift. Let me erase and let me show you. First, what is normal? What is normal? Sir, in a normal person, at the level of tissues, the partial pressure of oxygen is 40. When the partial pressure of oxygen is 40, what is the hemoglobin saturation? In a normal person, hemoglobin saturation will be 75. Okay. Which means one molecule of oxygen is delivered. Okay. Now, in right shift, what is the hemoglobin saturation at 40? Hemoglobin saturation is 50. Hemoglobin is 50% saturated, which means 2 molecules of oxygen is delivered. 2 molecules of oxygen is delivered to the tissues. But in right shift, what is happening? Look, in right shift, this is right shift. This is the right shift, right? In right shift, look carefully. What is the hemoglobin saturation? Hemoglobin saturation is almost 90%. Hemoglobin is highly saturated, 90% saturated, which means not even one molecule of oxygen is delivered to the tissues. Okka molecule got release avatledu. Not even one molecule of oxygen is getting released to the tissues. Okay. So which means what? Hemoglobin is binding with the oxygen. In the body, there is no need of oxygen. Tissues doesn't require oxygen. When tissues doesn't require oxygen, it won't give the oxygen unnecessarily. Oxygen is not a good thing. Oxygen can form free radicals. So if tissues doesn't require oxygen, hemoglobin will not give oxygen. That's it. So that is called as right shift. Right shift means low. Sorry. This is left shift. Okay, left shift is high affinity state. Left shift means what? Left shift means what? Left shift means hemoglobin is not releasing the oxygen. Hemoglobin is not releasing the oxygen. Left shift is a high affinity state. Hemoglobin is tightly binding with the oxygen. Is tightly binding with the oxygen. It's not releasing the oxygen. So that's it. So that's it. Okay. So I have explained you what is left shift, what is right shift. Sometimes hemoglobin deliver more oxygen. Sometimes hemoglobin deliver less oxygen. Right shift and left shift. That's it, sir. Now I will show you the question which was asked in the exam. Direct question which I will show you. Look at here. Look at this. The question which was asked is, for example, see. Look at this. Now left shift in oxyhemoglobin association dissociation curve is seen in which of the following condition? They are simply asking left shift. You should know left shift means, see, left shift, this is the left shift. Left shift means high affinity state. Left shift means high affinity state. Okay, right. It is high affinity. It is seen in which conditions? Sir, whenever the body tissues, whenever they don't require oxygen, maybe the person is in the cold environment, his metabolism is going down. Okay, he's in coma, his metabolism is going down. There is no need of oxygen. Which condition? Alkalosis. In alkalosis condition, there will be left shift because acidosis, hypercarbia, and increase in 2,3 ppg, they will cause right shift. Okay, these three things will cause right shift, sir. Don't forget. Increase in 2,3 ppg, acidosis, hypercarbia, what they will cause? They will cause right shift. But alkalosis will cause left shift. So such kind of questions will be asked in your exam. Such kind of questions will be asked, tested in your exam. Okay. So now, Abra, is that clear? Now, so hemoglobin is like a girlfriend. Sometimes it behaves differently. Okay, hemoglobin also, sometimes it shows right shift, sometimes it shows left shift based on the environment in the body, like acidosis or alkalosis or high temperature or low temperature. Okay, high pH or low pH, high temperature, low temperature. Based on that, it will change. Is that clear, Abra? Yeah. So we are at the end. So regarding this oxygen hemoglobin association dissociation curve, okay, sir, what else you should know? Okay, what else you should know is P50 value. What is the P50 value, sir? Simple. P50 value. Let me explain you what is the P50 value. Let me just copy this once. Copy. Let me teach you what is P50 value. Let me teach you in a new slide. Yeah. Okay. Now, so far where we have concentrated. Look, we have concentrated on this 40. Okay, mainly where we have concentrated on this 40. We know where the partial pressure of oxygen is 40. In a normal person, hemoglobin is 70%, 75% saturated. In right shift, the hemoglobin is 50% saturated. In left shift, the hemoglobin is 90% saturated. We have discussed this. So now don't concentrate on this black line. Forget about it. Now concentrate on this dotted line, this line. Okay, this line. So what is this, sir? What is this P50 value? Okay, what is this P50 value? See, when hemoglobin saturation is 50%, when the hemoglobin is 50% saturated. See, let's see in the normal person, normal. What is normal? Normal is, see here, this is the normal thing, right? Normal curve mein, hemoglobin here, it is 50% saturated. But at which partial pressure? Hemoglobin is 50% saturated? Look. Here. Not at 40. So at this partial pressure, do you know what is the value? 27 mmHg in a normal person. If you reduce the partial pressure to 27, if you reduce, again I'm repeating, if you reduce the partial pressure to 27 mmHg, now in a normal person, hemoglobin will become 50% saturated. What is the normal P50 value? Normal P50 value is 27 mmHg. Now, you tell me what is P50? First of all, what is P50, sir? P50 means the partial pressure at which, see this one, the partial pressure at which hemoglobin is 50% saturated. Okay. So, the same thing. Here also look, the partial pressure at which, see P50, the partial pressure at which 50% of the hemoglobin is saturated, which means 50% is desaturated. What is the normal value? 27 mmHg. Hemoglobin is 50% saturated. Okay. Next, look at here. In right shift. Okay, this is the right shift, right? Okay, let me hear here. This is the right shift. In right shift, what happened to the P50 value? What happened to the P50 value? P50 value is more 40. In left shift, what happened to the P50 value? P50 value is less, maybe 10. Maybe 10. So this is what I want you to know. Left shift may P50 value is less. Right shift may P50 value is more. Okay. So this is also the question which was asked in exam. So in right shift, P50 value is more. In left shift, please make a correction. In left shift, P50 value is less. So that's it. What is the normal P50 value? Normal P50 value is 27. In right shift, P50 value is more. In left shift, P50 value is less. Okay. So done, sir. This is also completed. Now, this is the oxygen hemoglobin association dissociation curve, right? Normal. See, for example, how the curve is looking, it's looking like this. Oxygen hemoglobin association dissociation curve. It is like which shape? It is like S shape. So, right. The oxygen hemoglobin association dissociation curve is in which shape? It is sigmoid shape. It is sigmoid shape. Why it is sigmoid shape? Why it is not parabolic? Why it is sigmoid? Only one line, single liner. I'm not going into the concept. If you're first year student, I would have explained. But right now, simple remember, oxygen hemoglobin curve is sigmoid shape due to a phenomena called as positive cooperativity. So there is something called as positive cooperativity of hemoglobin. I'm not going into details. Simple. Because of this phenomena called as positive cooperativity, oxygen hemoglobin curve is a sigmoid. It's like a S shape. It's like a S shape. That's the third MCQ which I want you to know. First MCQ is right shift, left shift conditions. Second MCQ is P50 value. Third MCQ is it is a sigmoid shape due to positive cooperativity. So with this, the main important topic in the respiratory physiology is completed. Oxygen hemoglobin association dissociation curve khatam ho gaya. Ho gaya sir, done. So just sit back and relax. Just sit back and relax for 1 minute. Just relax for 1 minute. Okay, relax for 1 minute. Is everything clear, guys? Oxygen hemoglobin association dissociation curve. Just sit back and relax. Just tell me, is everything going? Like, why you guys are like in your university? Like, I think you guys are not graduated yet, right? You guys are not graduated. You are doing your internship in your university. Still, you are not graduated, but you are giving the exam. You are giving the exam in the upcoming June or July, but still not graduated. Yeah, understood. Graduated. So, okay, some students are not graduated, some students are graduated. Oh, graduation on 13th. Okay. But anyway, you have taken a better decision. You have taken a better decision because, like, yeah. So you can complete certain subjects there itself. So how was the studies in your colleges? How was the studies? Is it good? Physiology, what about physiology? Will you come to RS Jaipur? Yes, definitely I will come to RS Jaipur. I will come to RS Jaipur. But if you have already attended these sessions, we have already attended these sessions, what's the point of again, like, again, you don't need to attend physiology again, because it's the same thing. If you want to attend, you can attend, okay? But physiology is same. There also I'm going to teach the same. Physiology, what about the physiology in your university? Most Harish is saying physiology is not good in your university. Okay. I will come to RIS Jaipur, RIS Delhi, RIS Kerala, RIS Hyderabad, everywhere except RIS Chennai. Except RIS Chennai, I will cover all the RIS branches everywhere: Hyderabad, Chennai, Kerala, Delhi. Okay, except Chennai. Chennai, other teacher is taking there. Local Chennai teacher is there. Tamil teacher is there. She is taking in Chennai. Not at all. Indian students are better compared to foreign students. Who said? Not at all. Not at all. Not at all. Foreign students are better because foreign students have better theory knowledge. Okay. Chalo. So this is done. Now, after this, let's discuss about the regulation of respiration. There is a small topic called as the carbon dioxide transport. I'm not discussing about the carbon dioxide transport. It's not needed. It's not needed, carbon dioxide transport. Now let's discuss about the regulation of respiration. Okay, regulation of respiration. What is this regulation of respiration? Let me tell you. See, is your respiration under your control? I'm asking. Is your respiration, is it under your control? No, definitely not under your control. You are not controlling it. Okay, like you are sleeping and respiration is happening on its own. For most of the time, it's happening on its own. Of course, you can control it. You can take charge, but for most of the time, it is happening on its own. Right? Who is controlling? Is these centers. Okay, this is your brainstem. This is your medulla. Hey, kya hai medulla? So this is your medulla. This is your pons. Okay, this is your pons. Pons mein dekho, two centers are there. Okay, there are two pontine centers. And medulla mein dekho, there are three centers. There are three medullary centers and two pontine centers. What are the centers which are there in the pons? Look, in the pons, there is a pneumotaxic center above and apneustic center below. Okay, pneumotaxic center and apneustic center. Now itself, I am telling you, from the beginning, I am telling you, pneumotaxic center always inhibits apneustic center. Okay, it always inhibits apneustic center. So remember, like PA, pneumotaxic center, apneustic center. P inhibits A, P inhibits A, P inhibits A. Okay, tell 5 times. P inhibits A. Okay, pneumotaxic center inhibits apneustic center. Remember that point. Next, sir, medulla mein, how many centers are there? 3 centers are there. What are they? Pre-Botzinger complex. It's a pacemaker. You know it. Pre-Botzinger complex in yesterday's class, I have told you. Pre-Botzinger complex is the pacemaker of respiration. Interstitial cell of Kajal is the pacemaker of GIT. Something like that. Okay, and who else are there? There is something called as a ventral respiratory group, VRG, and dorsal respiratory group, DRG. Dorsal respiratory group and ventral respiratory group. Dorsal respiratory and ventral respiratory group. Two things are there, DRG and VRG. Okay, so the same things, let me write here. Pons mein, two centers are there, pneumotaxic center, apneustic center, right? Pneumotaxic center inhibits apneustic center. First, I'm going to teach you ABCD. First, I will teach you ABCD. A, B, C, D, E, F, alphabets. Later on, I will teach you the concepts. First, know the basics. This slide is all about the basics. Okay. Pons में कितने centers है? 2 centers है. Pneumotaxic center, apneustic center. Medulla में कितना centers है? 3 centers. What are they? Dorsal respiratory group, ventral respiratory group, and pre-Botzinger complex. Pre-Botzinger complex is the pacemaker, you know it. Okay. Now, little pharma integration. Pharma integration is, there are drugs called as opioids, like morphine, painkillers, opioids. When you take opioids, what happened to your respiratory rate? You know, it decreases. Why? Why taking opioids decreases the respiratory rate? Because opioids inhibit pre-Botzinger complex MCQ. If you take opioids, mere opioids తీసుకుంటే, if you take opioids, what they will do? It inhibits pre-Botzinger complex. If pre-Botzinger complex is inhibited, that's a pacemaker. So respiratory rate comes down. Okay. Next, again ABCD basics. Your medullary centers, the three medullary centers are there. No, medulla mainly controls the initiation. Okay, initiation, right? Initiation of respiration. Mainly medulla starts the inspiration. Okay, medulla is the one which going to start. It starts the respiration. It starts the respiration. Medullary centers. What pons will do? Pons is mainly doing the regulation. How much should go in, how much should come out, when respiration should stop. That all done by the pontine centers. Pontine centers too. Pontine centers, pneumotaxic center, apneustic center. So medullary centers, what they do? Medullary centers initiate the respiration. Pontine centers regulate the respiration. Why this is important, you will understand in a minute. Next, sir. Pneumotaxic center, I have told you. Pneumotaxic center, it inhibits apneustic center. Okay. Sir, pneumotaxic center का काम क्या है? Pneumotaxic center the pons. What it will do? Pneumotaxic center, see, it limits inspiration. Okay, it's limiting, it's stopping. Array, 500 ml came in, 500 ml of air came in. Now stop. Inspiration should stop. Who stops inspiration? It's the pneumotaxic center. Pneumotaxic. Okay, it's stopping. Pneumotaxic center limits inspiration. Then what apneustic center will do? Apneustic center, if you wish, see, you try to do the prolonged inspiration, something like that. So if you want, the apneustic center, it prolongs the inspiration. Okay. So pneumotaxic center limits the inspiration normally, and apneustic center, it prolongs the inspiration. Okay. So ABCDs: pneumotaxic center stops, apneustic center prolongs. Okay. Now DRG and VRG. Sir, what is dorsal respiratory group doing? Dorsal respiratory group, it controls inspiration. It also controlling respiration. What it will do is, it produce electrical impulses called as ramp signals. Action potentials called as ramp signals. I will discuss. Okay. So DRG and range. What this DRG is doing? The DRG, the dorsal respiratory group, is producing the action potentials or electrical impulses called as ramp signals. So what these are responsible for? They are responsible for slow rise in the tidal volume, not a sharp rise. So tidal volume is first 100 ml goes in, next 200 ml, 300 ml, 400 ml, 500 ml. So there is slow rise in tidal volume. Okay. Once you have 500 ml of air, pneumotaxic center stops inspiration. Okay, there is slow rise in tidal volume, gradual rise in tidal volume. Who is going to do the job for you? Dorsal respiratory group. Okay, it produces ramp signals. Okay, it gradually produces the ramp signals. With the help of ramp signals, diaphragm is contracting slowly. That causes the slow rise in the tidal volume, smooth rise in the tidal volume. Then what is VRG doing? VRG is very simple. VRG को कोई काम नहीं है. Normally, VRG doesn't have any function. VRG, remember, I used to remember, like when I was a student, I used to remember like VRG is waste. VRG, V for V, VRG for waste. It doesn't have any function. But that's the question which was asked in the FMG exam. That's the exact question asked in the FMG exam. VRG does not have any role normally, but when it is helpful, VRG is needed during forceful expiration. When you are trying to do forceful expiration, normal expiration के लिए, expiration is passive. Expiration के लिए कोई center use नहीं है. There is no use of any, like I should say, there is no use of any centers. There is no need of any center. But if you want to do forceful expiration, then what do you require? VRG. Okay, just let me show you what is the kind of question that was asked in the exam regarding the center. Let me see whether I have kept it or not. Yeah, this is the question saying, which of the following neurons fire during forceful expiration? Okay, it is a ventral respiratory group. Okay, that's the exact question was asked. So ABCDs, okay. Now after ABCDs, now let's start. Let's start the real thing. So what is this real thing? Let me write one by one. See, first you need to start the inspiration. I'm talking about the inspiration. Inspiration. Now first you need to start it. You need to start it. Later on, you need to maintain it. And later you have to stop it. Okay, first start it, maintain it, later stop it. These are the three things. Look at me. Look at me. Sir, first you need to start it. Okay. Now what you need to do? Look, you need to start it. You need to maintain it. And there is a point you have to stop it. Okay. Now, look. How initiation will occur. First, what happens is your pre-Borzinger complex. Your pre-Borzinger complex is first activated. It's a pacemaker, right? It is going to generate an action potential. First, pre-Borzinger complex is activated. It fires. It gives the action potential and it activates phrenic nerve C3, C4, C5. When the phrenic nerve is activated, okay, it generates the action potentials. Now, because of the contraction of phrenic nerve, you know, the diaphragm will contract. Because of the phrenic nerve firing, the diaphragm is contracted. In last class, you know, when the diaphragm is contracted, you know, inspiration is started. The parietal pleura will move away from visceral pleura. The intrapleural pressure will move from minus 2.5 to minus 6. More vacuum is there. Lungs are going to inflate. Inspiration started. Airs have started to enter into the lungs. In last class, I have discussed. So pre-Borzinger complex, it's the pacemaker. It causes the contraction of the diaphragm. So inspiration is initiated. Okay. Later on, what happens? Immediately, these are pacemakers. One after other, they will activate. So immediately, apneustic center is activated. Automatic. By default, they are activated. Apneustic center is activated. Once the apneustic center is activated, apneustic center, which is there in the pons, see, apneustic center is there in the pons. The apneustic center activates the dorsal respiratory group. The dorsal respiratory group sends continuous signals called as the ramp signals. Okay. Slowly ramp signals are generated. Now these ramp signals, they will keep the diaphragm in contracted state. The diaphragm is further contracting. Slowly the diaphragm is contracting. That causes smooth rise in tidal volume. Okay, slowly the air have entered into the lungs. How much air? 500 ml of air enters into the lungs. So who is maintaining the inspiration? Who is maintaining the inspiration? It's the pneumotaxic center along with the dorsal respiratory group. Apneustic center. Apneustic center along with the dorsal respiratory group. Apneustic center. Later on, once you have 500 ml of air, now what should happen? Termination. Now, once you have 500 ml of air in your lungs, lungs are stretched. Lungs are stretched. Now, lungs are stretched. Now, when the lungs are stretched, see, now lungs are having how much air? 500 ml of air. Now, from the lungs are getting stretched. In the lungs, stretch receptors are there. Now, from the lungs, this information is going to the brain. From the lungs, see, from the lungs, this information is going to the brain via the vagus nerve. A vagus nerve, it is also sensory nerve. It takes the information to the brain. So through the vagus nerve, this information is going to the brain. Do you know what this vagus nerve is going to do? Vagus nerve immediately inhibits apneustic center. So apneustic center is inhibited. When apneustic center is inhibited, automatically DRG is also inhibited because it's the apneustic center which activates the dorsal respiratory group. So apneustic center inhibited, DRG inhibited. When the DRG is inhibited, no ramp signals, no ramp. If the ramp signals are not there, no further rise in tidal volume. So tidal volume stopped. That's it, 500 ml. That's it. Tidal volume is not going to increase. So inspiration stopped. Inspiration stopped. And not only that, what I want you to know is, sir, this vagal afferents. Okay, this vagal afferents also activates the pneumotaxic center. The vagal afferents also activates the pneumotaxic center. I have told you, P always inhibits A. Pneumotaxic center inhibits the apneustic center. Now the pneumotaxic center is inhibiting the apneustic center. DRG is inhibited. No ramp signals, no tidal volume increased. So that's it. Okay. So this is how termination occurs. So inspiration, initiation, maintenance, and termination are completed. Once lung have 500 ml of air, the lungs are going to stretch. The stretch is going to activate the stretch receptors. Now that stretch receptors via the vagal afferent. See, now here are the stretch receptors. The stretch receptor activate the vagus. So information is going to the brain. Array, enough amount of gas is there, enough amount of air is there. So immediately the vagus will inhibit the apneustic center. Okay. The same vagus also activates pneumotaxic center. P inhibits A. So done, sir. Regulation of normal respiration. Is it clear? Tell me. Is it clear? What topic I'm going to do in the last class? Tomorrow morning session I will be doing tomorrow morning I will be doing the central nervous system. Tomorrow morning 9 till almost 4 9 till 4 I will be doing the central nervous system. From 4 till night, whatever, from 4 till night I will be doing the general physiology. So tomorrow class is not there. I don't know about the Kolkata. I don't know about the Kolkata. I don't know about the Kolkata. So far Kolkata में arise नहीं है ना? Yeah, tomorrow class is there. Tomorrow class is there. I haven't seen your timetable, but tomorrow class is there. Okay. If by chance, if we couldn't complete any topic, any leftover, if there is any leftover topic, we'll be doing it on the day after tomorrow. Like we'll be doing it for like 1-2 hours. We'll be doing it on day after tomorrow. Tomorrow and day after tomorrow also. Okay, I will check. According to table, I know. Okay, I will check. But no issue. If there is class. Actually, the class, if there is any leftover topic, I will do it on Monday. If not, by tomorrow it will be completed. Okay, understood. So, buddies, hello. Okay. Now, look at this table. Look at this table. Come to this table. Okay, don't look at this table. I will explain this. In FMG exam, one question was asked. I will tell you what is that question. Guys, normally respiration, is it under your control? No, sir, it's not under your control. But I'm asking you, try to control it. Yes, you can control it. Group, ventral respiratory group, pneumotaxic center, apneustic center. So what I'm trying to put into your mind is, array, your brain hai na, the higher centers, the higher cortical centers, they can influence, they can control these brainstem centers. So you can take charge on your respiration. Okay, when you are doing meditation, when you are doing yoga, you can control. Breathe in, breathe out, breathe in, breathe out. Which means you can control your respiration. So voluntary, that is voluntary. So now the point which I want you to know is, once look at this table, come to this table. Sir, if there is a lesion above the pons, means there is a damage because of some motor vehicle accident or because of something. Sir, there is a cut. Where is the cut? Here, there is a damage. Here, cut, sir. Okay, there is a damage over there. Cut means this area cut ho gaya, damage ho gaya. Means lesion where? Lesion above the pons. Above the pons, here there is a cut. Now tell me, can you have voluntary respiration? Can you control your respiration? No, because the higher centers cannot control the brainstem centers. Your cortex, your brain, your cortex cannot control the brainstem. So now tell me what happens if there is a lesion above the pons. Look, the higher centers, right? The higher centers can no longer influence the brainstem centers. The higher centers can no longer influence the brainstem centers. So what is lost? Loss of voluntary control. What is lost? Loss of voluntary control. Okay, voluntary control gaya. Okay, you can't have voluntary inspiration or expiration. Okay. Next, where is the lesion, sir? Don't write each and everything. First, let's go one by one. Where is the lesion, sir? Sir, lesion is in the mid pons. Where is the lesion? Mid pons. Mid pons mein lesion hai. Middle of the pons. So look here. Sir, where is the lesion? Where is the lesion? Middle of the pons. Look here. Pons mein middle mein. In between where? In between where? Between pneumotaxic center and apneustic center. In between here. Okay. Now the pneumotaxic center cannot inhibit the apneustic center. Okay. Now the pneumotaxic center is not able to inhibit apneustic center. So what happens? Apneustic center is working. So apneustic center will activate the dorsal respiratory group. So dorsal respiratory group is producing the RAM signals, and RAM signals are working. What happens? There is continuous raise in the tidal volume. So now the apneustic center is continuously working. I have taught you what is the function of apneustic center. It prolongs the inspiration. So that's why, look, see, whenever the pneumotaxic center and apneustic center are separated, mid-pontine lesion, what happens? See, inspiration is markedly prolonged. Okay, markedly prolonged. So this breathing pattern is called as apneosis. Okay, that breathing pattern, prolonged inspiration, is called as apneosis. Okay, that prolonged breathing is called as apneosis. For a long time, you will breathe. After that, vagus nerve is going to be activated. Vagus nerve will inhibit apneustic center. Okay, that will happen later. But if you have lesion in the mid-pons, mid-pontine lesions are going to cause prolonged inspirations. They are called as apneosis. They're called as what? Apneosis. Next, where is the lesion, sir? Now the lesion is in the pontomedullary junction. Pontomedullary means between the pons and medulla. Between pons and medulla are separated now. I have said you in the beginning alpha, like no, in the basics, see, look, I have said you pons is mainly responsible for the regulation of respiration. Pons regulates. Now pons is separated. So the patient is going to have irregular respiration. So if there is a lesion between pons and medulla, there will be irregular respiration. See, here I have given explanation. This is because regularization of rhythm is lost. This is because regularization rhythm by pons is not there. Now pons is not able to control medulla. So the rhythm is going to be lost. Okay, that's it. Now the last one, what if there is a lesion below the medulla? Okay, below medulla if there is a lesion. Now there is cut below the medulla, which means, if there is a cut below the medulla, now the pons and medulla, they are totally not able to control the pons and the medullary centers. They cannot control the diaphragm. So what happens? Now the patient cannot do inspiration. The patient will die. Okay, below medulla, respiration stops. If there is a lesion below the medulla, the respiration is going to stop completely. Respiration stops. Okay, done. Respiration stops. So with this, lesions at different levels and their effects. Okay, lesions and effects are completed. So is that clear, guys? So tell me, is that clear? In tables, can you zoom? Yeah, sure. Take a screenshot if possible. I think screenshot are not permitted. I think that your device won't support for the screenshot. I don't know if it is permitted, you take it. Otherwise, you have your other mobile so that you can click the photos whenever you want. Respiration stops if there is a lesion below the medulla. Screenshots are not permitted. Okay, none understood. So shall I give you a break now? Now still we have to in respiratory, what is left over? I have to discuss about the reflexes. These reflexes are important. This table is there. The last thing, there is this reflex table. This is what I have to teach you. Okay, reflexes. Herring-Brewer inflation reflex, Head's paradoxical reflex, J receptor reflex. These reflexes I have to teach you. Okay. And last thing that I have to teach you is the types of hypoxia. Hypoxia and reflexes. Hypoxia and reflexes I have to teach you. Okay, that I will teach you after the break. Okay, that I will teach you after the break. And after respiratory, we will be starting with the renal. After respiratory, we will do the renal. Okay. So today we have to complete as much as renal as possible. Don't worry. Again, I'm assuring from my side. If there is any leftover topic, Monday I will take the class. Okay, Monday I will be taking the classes. I will complete them. Okay. Okay, sir. Bye. Bye. Have you same break up to 2 o'clock as usual. Break up to 2 o'clock. Bye bye.
Okay. Hello, good afternoon, guys. Can you hear me? Good afternoon, guys. It's 2 o'clock. Where are you guys, sir? Good afternoon, Pawan. Can you tell me what is the next class after physiology? What is the next class? Okay. Of course, there are break days are there. What is the next class after next subject? Next subject after physiology? Biochem. Biochemistry by Azam, sir. Biochemistry. Any idea about the faculty? Azam sir is taking or Priyan sir is taking biochemistry? Okay, Priyan sir. Priyan sir, okay. Okay, even I don't know. But anyway, both teachers are good, no doubt in that. So without any further late, now let's continue with the respiratory system. So let's continue. So respiratory reflexes. Now we have to discuss about these reflexes, right? So let's try to understand these reflexes one by one. I'm not going to explain you the reflexes in this table. I'm not going to explain in this table. Now take the heading. Take a white paper. Take the white paper. Take the white paper and write the heading. What is herring brewer inflation reflex? Okay, herring brewer inflation reflex. Herring brewer inflation reflex, you already know it, guys. You already know it. Now I'm asking you one question. So try to take as much air as possible. Of course, it is little difficult after eating food, but try to do it as much air as possible continuously. Try to do it. Why you are stopping? Why you are stopping to take the air? Because you can take only till certain volume. Okay, so you can't continuously take the air. You can't take the air continuously, otherwise your lungs will rupture. Okay, so your inspiration will stop. Your inspiration will stop at a time. Okay, so when you are overstretching the lung, remember, okay, when you are overstretching the lung, now what will happen? You already know it. The stretch receptors in the lung are activated. There are stretch receptors in the lung. Now the stretch receptors, they will give the information to the vagus nerve. Okay, they will give the information. For example, if this is the stretch receptor, the stretch receptor is attached with the vagal nerve fibers. Okay, the stretch receptors are attached with the vagal nerve fibers. And you know the story. What this vagus nerve is going to do? The vagus nerve is going to activate the pneumotaxic center. I already have explained you. Vagus nerve, what vagus nerve is doing? Vagus activates the pneumotaxic center. You know, once the pneumotaxic center is activated, P inhibits. Yeah, pneumotaxic center it inhibits the apneustic center, and you know the story. Once the apneustic center is inhibited, the DRG is inhibited. Once the DRG is inhibited, no ramp signals. No ramp signal means no further inspiration. So inspiration stops. So this reflex is called as Herring-Brewer inflation reflex. What is this reflex? What is happening? When you stretch the lung, when you overstretch the lung, inspiration automatically stops. Okay, inspiration automatically stops. Okay, why? Stretch receptors are activated. Slow adapting myelinated vagal fibers. Okay, slow adapting myelinated vagal fibers are taking this information to the brain. Now, the slow adapting myelinated vagal fibers, they activate the pneumotaxic center. They activate the pneumotaxic center, and pneumotaxic center inhibit the apneustic center. That's it. When you stretch the lung, inspiration stops. When you stretch the lung, inspiration stops. This is Herring-Brewer inflation reflex. When you stretch the lung, inspiration stops. But only once in your lifetime. Only once in your lifetime, opposite happens. Only once in your lifetime, opposite happens. That reflex is called as Head's paradoxical reflex. Paradox means something not normal. Paradox means something abnormal, which is not usual. Paradox means unusual, right? So what is that? Head's paradoxical reflex. What is this Head's paradoxical reflex? Means when you
take birth for the first time, when you are a newborn, for the first time you are breathing, when you stretch the lungs, your lungs are totally collapsed. Your lungs are totally filled with, like, the amniotic fluid. For the first time, your lungs are stretching. When you stretch the lungs, in order to completely inflate the lungs, in order to completely open the lungs, there will be further increase in inspiration. First, when you stretch the lung, that will further increases the inspiration. This only happens once in your lifetime. That is called as Head's paradoxical reflex. Why it is called as a paradox? Paradox because when you're stretching, it is causing further inspiration to completely inflate the lung. This is called as Head's paradoxical reflex. Previous thing is when you stretch, that stops the inspiration. But in Head's paradox, when you stretch, that increases the inspiration. Okay, so this is the Head's paradoxical reflex. Is that clear? Head's paradoxical reflex. So Herringbrower inflation reflex completed, Head's paradoxical reflex is completed, and the question that's going to show up in your exam is Head's paradoxical reflex is seen in newborns. Okay, stretching the lung causes further inspiration. Stretching the lung causes further inspiration. Head's paradoxical reflex. Head's paradoxical reflex. Don't forget it about it. Okay. Now next thing, I'm asking you guys. Generally, I'm asking you. Look at me. Look at me. My question to you is, for example, in your lungs, because of some reason, in your lungs, there is congestion. Already in your lungs, what do you have? Congestion is there. Whenever there is pulmonary congestion, you have to send more blood to the lungs or less blood to the lungs. Already the blood is getting accumulated. There is congestion, venous congestion in the lungs. During this time, you have to send more blood to the lungs or less blood to the lungs. You have to send less blood to the lungs. You have to send less blood because already there is congestion. If you send more blood, that congestion may transform into pulmonary edema. Right? So what happens is, whenever this pulmonary congestion, automatically heart rate decreases. Less blood will go to the lungs. So that reflex is called as J reflex. That reflex is what? J reflex. This J reflex, this was discovered by an Indian scientist who works in AIMS. This reflex is J reflex. Okay, so J stands for here J receptor. Okay, J receptor. So what is this J receptor? Let me tell you. J receptor means, look, in your lungs there are pulmonary capillaries, right? Pulmonary capillaries. Now surrounding the pulmonary capillaries, what do you have? J receptors are there. These are the J receptors. Now what is this? J stands for juxtapulmonary, side to the pulmonary capillaries, just side to the pulmonary capillaries. What do you have? These receptors are there. So J stands for juxta. Yeah, so J stands for juxta pulmonary capillary receptor. See, these white things are the J receptors. Now what they will detect? See, whenever there is pulmonary congestion, okay, so whenever there's pulmonary congestion, that activates the J receptors. Now the J receptors are activated. Oh, now alarming situation. Now there is pulmonary congestion. Now the J receptors are activated. Now this J receptors, now what will happen is, now from this J receptors, the information will go to the central nervous system. Now the information, where it is going, via the vagus nerve, again via the vagus nerve, this information is going to the central nervous system. There is congestion. So afferents via unmyelinated vagal C fibers. Okay, okay, via the unmyelinated, simply remember the vagal C fibers. Via the unmyelinated vagal C fibers, this information is going to the central nervous system. There is pulmonary congestion. So immediately what will happen? Immediately as a response, see, whenever there is pulmonary congestion, okay, the J receptors are activated. The information is going to the central nervous system that there is pulmonary congestion. Immediately central nervous system, see, decreases the heart rate. This is important. Okay, this is what it is doing. It is decreasing the heart rate, means now less blood is going to the Now the less blood is going to the lungs. Now immediately what will happen to the BP? Your blood pressure decreases. Otherwise, if there is more blood pressure, means that can lead to edema. So your blood vessels will undergo vasodilation. So there will be hypotension. The blood pressure will come down. So there will be bradycardia and hypotension. Bradycardia and hypotension. These two are the important things. So in J reflex, juxtapulmonary reflex, the patient is going to have bradycardia and hypotension. Why? What is the purpose? This is all to prevent pulmonary edema. Okay, this is all to prevent pulmonary edema. Pulmonary edema ni prevent cheyadaniki, to prevent the pulmonary edema. Now the blood pressure will go down and heart rate will come down. This is J reflex. That's it. So the three reflexes which I want you to know for your exam are done. One is Herring-Brewer inflation reflex. Second one is Head's paradoxical reflex seen in the newborn, and J reflex, which is seen in the conditions of pulmonary congestion. Pulmonary congestion. So is that clear? Three reflexes are done. If you want to write. Let me check the chat. Yeah. So again, if you are missing anything, right? Herring-Brewer inflation reflex, Head's paradoxical reflex seen in the newborn, and J reflex seen in the cases of pulmonary congestion. Okay, so done. Next point which I want you to know is now chemical regulation of respiration. Chemicals. Certain chemicals can regulate your respiration. Certain chemicals. Now you might think, sir, these are the end topic, right? End topics, right? Are they important? Absolutely, no doubt. In the last FMG exam, last but one FMG exam, questions has been asked from this area. Okay. So chemical respiration of chemical regulations. Which chemicals will regulate? Okay, I will tell you. So there are receptors called as chemoreceptors in your body. Chemoreceptors. How many types of chemoreceptors are there? First, wait. There are two types of chemoreceptors. Peripheral chemoreceptors. Okay. Central chemoreceptors. Just like baroreceptors, you know, baroreceptors are present in aortic arch and carotid sinus, you know it, right? In the same way, there are chemoreceptors present. How many types of chemoreceptors? Peripheral, central. Peripheral chemoreceptors ekkada untayi? Where are the peripheral chemoreceptors present? Peripheral chemoreceptors are present in carotid sinus. Same carotid sinus mein chemoreceptors are there, as well as baroreceptors are there. Okay. So peripheral chemoreceptors are present in carotid sinus as well as aortic arch. Right? Important. Chemoreceptors, peripheral, seen in carotid sinus as well as aortic arch. Now the central chemoreceptors. Central means brain. Central chemoreceptors, they are present in your brain. Okay. Done. Now, what these chemoreceptors are doing? What is the function of this chemoreceptor? Baroreceptor detects the BP. Baroreceptor measures the what? What baroreceptor measure? Baroreceptor measures your mean arterial pressure. Then a chemoreceptors का काम क्या है? What is the function of these chemoreceptors? Now let me tell you. See, the peripheral chemoreceptors, their function, the peripheral chemoreceptor, they will check how much is the partial pressure of oxygen. Oxygen, how they will check how much is the oxygen, how much is the oxygen in the blood, how much oxygen is there in the blood, how much oxygen is there in the blood. Who will check that? The peripheral chemoreceptors in the aorta and the peripheral chemoreceptors in the carotid sinus, they are sensitive to what? Oxygen levels. If there is any hypoxia, they're activated. If there is any hypoxia, they're activated. Okay. And the central chemoreceptor MCQ, they are sensitive to mainly carbon dioxide levels. They will always check the carbon dioxide levels, blood low, in blood. How much carbon dioxide is there? Enough extra any extra carbon dioxide is there? Something they will check something like that. Okay. So peripheral chemoreceptors check oxygen. Central chemoreceptors check carbon dioxide. And not only that, the peripheral chemoreceptors are also sensitive to. They will also check proton concentration and pH. Okay, they will check pH, not decrease pH. They will check the pH. Okay, they are sensitive to pH. And central chemoreceptors will also check the proton concentration and they will also check the pH. Okay. But main question is, the question which was asked in the FMG exam is, central chemoreceptors are sensitive to, central for C, central chemoreceptors are sensitive to carbon dioxide. Peripheral chemoreceptors are sensitive to hypoxia. Okay. Now, let me show you an image. Look at this, sir. Here I am showing you what? Central chemoreceptor. Now, if I am talking about a central chemoreceptor, where it should be present? Where it should be present? It should be present in the brain. So that's why I say here in the brain, what is there? Central chemoreceptors are there. Okay, no need to draw anything. Just learn this one thing. Brain में क्या है? Central chemoreceptor. Okay. So, for example, let's put it this way. Okay, let's try to understand like this. Now, when you go to the high altitudes, you have gone where? High altitude. Okay, you have gone to the mountains. Okay, China or Ukraine or wherever, like Bishkek, you have gone to the high altitudes. Okay. Now, when you have gone to the high altitudes, now what happens is, see, their oxygen levels are going to be more. Okay, their oxygen levels are going to be more. Okay. Sorry. I'm telling opposite. The oxygen levels are going to be less. When you go to the high altitudes, the oxygen levels are going to be less. Okay. So in your body, carbon dioxide levels will also start to accumulate in high altitudes. Now what happens is, let me tell you. See, the carbon dioxide is going to react with the water. Okay. Carbon dioxide, see, the carbon dioxide is reacting with the water. Now when the carbon dioxide is reacting with the water, it forms carbonic acid, H2CO3. Simple. Let's start from the carbon dioxide. Or carbon dioxide. In your body, carbon dioxide levels are increasing. Because of some reason, sir, your carbon dioxide levels are increasing. Now, carbon dioxide reacts with the water. Carbon dioxide, when it reacts with the water, forms carbonic acid. Let me write here carbonic acid. Now, the carbonic acid, with the help of enzyme carbonic anhydrase, the carbonic acid is going to split into, H plus and HCO3 minus. Now, see what you have formed? H plus. See, carbon dioxide is the source of H plus. Remember, the carbon dioxide is the source of H plus. Okay, so now H plus is forming. See, that's why look here also H plus, the same H plus. Okay, so the carbon dioxide, it can convert into H plus. Okay, now this H plus and carbon dioxide, what they will do? See, carbon dioxide and this H plus, what they can do? They can stimulate chemoreceptors, central chemoreceptors. Yeah, central chemoreceptors are stimulated. When central chemoreceptors are stimulated, what happens? Now the central chemoreceptors, now they will try to activate. They will increase the firing of the pre-Botzinger complex. You are understanding? When the pre-Botzinger complex is firing more, means more ventilation, means more the number of times you are breathing. So if you do hyperventilation, when you do hyperventilation, means more the times you are breathing. So carbon dioxide is going to go out of your body. So carbon dioxide is extra carbon dioxide, whatever is accumulated, that will go out of your body. Okay, so carbon dioxide wash out. This is something good. So at the end of the day, the point which I want you to know is, your chemoreceptors, see, central chemoreceptors and peripheral chemoreceptors, they will regulate your respiration. They will change your respiration. Okay, they will change your respiration. Do you know what is the question which was asked in the FMG exam? High altitudes. When you are at the high altitudes, think logically and tell me, guys. Okay, when you are in the high altitude, you will breathe more number of times or less number of times? You think logically and tell me. High altitude. Okay, high altitudes. Now, you are not getting enough amount of oxygen. So immediately what you will do? You will try to do hyperventilation. You will do hyperventilation. This is the exact question which was asked in the last but one FMG exam. Okay, you check with the previous year questions. You once go through the previous year questions. High altitudes. When you go to the high altitudes, to get enough amount of oxygen, what you will do? Hyperventilation. Okay, so whenever you do hyperventilation, tell me, whenever you are trying to do hyperventilation, what happened to the carbon dioxide levels in your body? Whenever you do, look at me. Whenever you try to do the hyperventilation, carbon dioxide will go out. Carbon dioxide wash out. Carbon dioxide will go out of the body. Carbon dioxide wash out. So whenever carbon dioxide is going out, remember, carbon dioxide is the source of acids in the body. Carbon dioxide is the source of acid. So carbon dioxide is going out. So what happened to the acid production in the body? Acid production decreases. Acid production decreases. And now acid levels are going down because of the respiratory activity. Acid levels are going down. So when acid is going down, that will cause what? Alkalosis. Which alkalosis? Because of the respiratory activity, right? The respiratory alkalosis. Okay, because of the respiratory alkalosis. Okay, the carbon dioxide levels are decreasing. Carbon dioxide levels will decrease. So this is the question which was asked in the FMG exam. In high altitudes, you will have
hyperventilation. మీరు high altitudes కి వెళ్తే, whenever you are going to the high altitude ko janto, like when you are going to the high altitudes, you are going to have the hyperventilation. That hyperventilation can lead to respiratory alkalosis. MCQ, put 5-star marks. Okay, so the clarity unda, do you have clarity? Because of the respiratory activity there is alkalosis in the body. Is that clear? Okay, now tell me, I will ask you, can you explain the before slide? Rekha, which slide do you want me to explain? The before slide means this one? This one? Array, simple. Rekha, it's nothing. Like, no, say, now, if carbon dioxide levels increases in your body, what happens? Let me tell you. Array, in your body. Okay, let me directly take a new slide and let me explain you. For example, say, now, Rekha, look. Now, in your body, carbon dioxide levels are increasing. Okay, so what happens? Carbon dioxide usually reacts with the water. Carbon dioxide is reacting with the water. Forms what? H2CO3. This is what? Carbonic acid. Carbonic acid. Now this carbonic acid, it is going to split into HCO3 minus and H plus. HCO3 minus and H plus. So from where this H plus is coming? From the carbon dioxide only. No. Okay, that H plus, the carbon dioxide, when it reacts with the water, it is helping in the generation of protons. It helps in the generation of protons. Okay, these protons. Now, I have told you, the protons, what they will do? They will stimulate the central chemoreceptors. Central chemoreceptors. The central chemoreceptors are stimulated by carbon dioxide as well as protons. Now, when the central chemoreceptors, which are there in the brain, whenever they are activated, what they will do? They will lead to, they will finally, by activating the pre-Botzinger complex, they will lead to hyperventilation. Hyperventilation. See, now the respiration is changing. Now you will start to do what? Hyperventilation. Whenever you do hyperventilation, something like that, whenever you try to do the hyperventilation, now carbon dioxide will go out of the body. Carbon dioxide wash out. Carbon dioxide will go wash out. So the problem is solved, right? Initially you have more carbon dioxide. So finally carbon dioxide is going out of the body. So carbon dioxide wash out. Okay. So carbon dioxide, increase carbon dioxide in the body or increase acids in the body can lead to hyperventilation. That's a super important medicine thing, related thing. Me body lo, in your body, if carbon dioxide is increasing or protons are increasing or acids are increasing, that will cause stimulation of the central chemoreceptors that will lead to hyperventilation. So the patient is going to have hyperventilation. Okay. Why? To remove the carbon dioxide out of the body. Because carbon dioxide is the source of acid. We have to remove that thing. Understood? Yes, exactly. In diabetic ketoacidosis also, the patient is having acidosis. Now that acidosis is going to stimulate that acids H plus is going to stimulate what? Central chemoreceptors. That will cause hyperventilation. That is called as Kusumal's breathing. Exactly true, Rekha. Okay. The patient is having metabolic acidosis. Then again, the patient is going to have hyperventilation. True. So done. Completed. Next, what else I should teach you in respiratory? Now I have to teach you about the hypoxia. Okay, I have to teach you about the hypoxia. So what is this hypoxia, sir? I'm just taking the new slide. I just delete this because let me write and explain from beginning. Okay, so look at here. Hypoxia. Hypoxia means what? Decrease oxygen. Means oxygen is not going to the tissues. How many types of hypoxia are there? 4 types, right? There are 4 types of hypoxia. Okay, this favorite question for the exam. This is a favorite question for the examiners. Hypoxia are 4 types. First type of hypoxia. Okay, first type of hypoxia is called as hypoxic hypoxia. First type is called as hypoxic hypoxia. It is seen where? In high altitudes. See,
outside, see, you have gone to high altitudes. Listen carefully. You have gone to high altitudes. Meeru high altitudes ki vellaru. You have gone to where? High altitudes. And in the high altitudes, outside oxygen is not there. First of all, outside oxygen is not available. The partial pressure of oxygen in the high altitudes is less. So outside oxygen is not available. That is leading to hypoxia. First of all, outside oxygen is less. Outside, the partial pressure of oxygen is less. That is leading to hypoxia in your body. So hypoxia is seen in high altitudes. Okay, it's an environmental problem. Environment mein oxygen nahi hai, so your body is getting hypoxic. This is hypoxia. Number one. Number two is just wait. Anemic hypoxia. Anemic hypoxia. So what is anemic hypoxia? Anemic hypoxia means, see, your body is having problem. Outside oxygen is okay. Outside it is okay. In your body there is anemia. Okay. You are having what? Anemia. See, when you are having anemia, you are not having enough amount of hemoglobin. Okay. So what happens? Your hemoglobin is less. So when your hemoglobin is less, so less oxygen is going to the tissues. Simple. So again causing hypoxia. So anemic hypoxia is seen in anemia. Okay. And also anemic hypoxia seen in carbon monoxide poisoning. Okay, carbon monoxide poisoning. See what happens whenever there is carbon monoxide poisoning? Sir, all the hemoglobin is binding with carbon monoxide. All hemoglobin is binding with the carbon monoxide. See, I have told you carbon monoxide have 210 times more affinity for the hemoglobin. Now it is simple. Hemoglobin is totally occupied with carbon monoxide. So oxygen cannot bind with the hemoglobin. Oxygen doesn't have any place to bind with the hemoglobin. Okay. So anemic hypoxia is seen in anemia as well as carbon monoxide poisoning. Okay. Next, third is stagnant hypoxia. Okay, stagnant hypoxia. So what is the stagnant hypoxia, sir? Stagnant hypoxia mein outside everything is okay. Okay, outside everything is okay. Environment mein oxygen is there. Your hemoglobin is also okay. But where is the problem? There is heart problem. Okay, so that is congestive heart failure. The patient is having what? Congestive heart failure, CHF. The patient is having congestive heart failure, means heart is not pumping properly. Heart is unable to pump the blood to the tissues. So blood is not going to the tissues properly. So oxygen is not going to the tissues. So it's a heart problem. So that is a stagnant hypoxia. In stagnant hypoxia, the problem is with the heart related problem. Okay, outside oxygen, inside the blood oxygen, everything is okay, but the blood is not going to the tissues because it's a pump problem. That is stagnant hypoxia. And last but very important hypoxia, which is a favorite hypoxia for the examiners, that is fourth one, histotoxic hypoxia. Histotoxic hypoxia. Why there is hypoxia? Because of problem in the histo means tissues. Means the tissues are having the problem. What is the problem? So the example is cyanide poisoning. Cyanide poisoning. So if the patient is taking cyanide, if the person is taking the cyanide, for example, look, now this person is consuming the cyanide salts. Okay, cyanide. Immediately what happens? Now the cyanide, it will enter into the tissues. It will go into your body tissues and it inhibits electron transport chain, complex number 4. Okay. Complex number 4 of electron transport chain is inhibited. The cyanide inhibits the electron transport chain. Complex number 4 of electron transport chain. So what happens? Now immediately ATP production decreases and the patient will die. Guys, remember one point, now electron transport chain, it utilizes oxygen. It utilizes oxygen for the production of ATP. Now when the complex number 4 is inhibited, listen carefully, I am repeating again. Whenever you take the cyanide, what it is doing? It is inhibiting the electron transport chain. Complex number 4. Complex number 4 is getting inhibited. Okay. So now complex number 4 cannot use oxygen. Oxygen hai, but the tissues are unable to use it. So the patient is going to have hypoxia because oxygen is there, but the tissues are unable to use it because the complex number 4 is inhibited by the cyanide. So ATP production goes down and the patient will die. Now itself, I want you to know, most of the doctors don't know this. See, right now I'm asking you, look, right now I'm asking you, I am inhibiting, answer this, I'm inhibiting ATP production in your body right now. Right now, I have inhibited the ATP production. At this second, I have inhibited the ATP production with the already existed ATPs. For how much time you can live? For how many days you can live? Right now, I have inhibited the ATP production in your body. Right this moment, with the already existed stores of ATP, how much time you can live? You can live almost for 5-6 seconds. That's it. Okay, just only seconds, not even minutes. Within seconds you are out. That's why cyanide poisoning is so dangerous. Within seconds you are out. Okay, so 6 seconds, that's the value which was there in the many of the journals. Okay, within seconds you are out. Okay, yeah, Pranati, yes, it's a silent poisoning. There is a new this movie also in Netflix. Okay, that cyanide and curry. Okay, that new movie is there. Okay, so Abra, listen carefully. Okay, listen carefully. Now, look. Now this is a patient. Okay, imagine this is the person. Normally, what he is doing, sir, in his cells, this is one cell. Okay, this is cell. Now the cells will take the oxygen. Okay, the cells will take the oxygen, and the oxygen will be utilized by the electron transport chain. In the electron transport chain, complex number 4. Okay, so oxygen will be used in the electron transport chain by complex number 4 for the production of what? For the production of ATP. Okay, normally tissues are using what? Oxygen. Okay, now whenever you use cyanide, okay, whenever you use cyanide on a person, if you give cyanide to this person, what will happen to the what cyanide will do? Cyanide will directly go and inhibit the complex number 4. Okay, complex number 4 is not working now. When the complex number 4 is not working, see, oxygen is there, but the complex number 4 is not working. Means there is problem in the tissues. The complex number 4 is not able to use the oxygen. Now it is not able to use the oxygen because complex number 4 is totally totally changed because of the cyanide. Cyanide inhibits the complex number 4. So oxygen hai, but your tissues are not able to use it. So as the tissues are unable to use the oxygen, ATP production goes down. When ATP production goes down right now, immediately you are going to die within seconds. Okay, so every second in your body, ATP is producing. Every second, ATP is producing, and you are using that ATP for maintaining the homeostasis in the body. Okay, so let me show you the question which was asked. Yeah, this is the question which was asked. Okay, in the FMG exam, the question which was asked is this: adequate oxygen delivery to the tissues, means adequate amount of oxygen is getting delivered to the tissues. In which type of hypoxia? Good amount of oxygen is going to the tissues. Histotoxic hypoxia. In histotoxic hypoxia, oxygen is going to the tissues, but the tissues are unable to use it. Look, in hypoxic hypoxia, oxygen is not going to the tissues because outside oxygen is not there. In anemic hypoxia, the patient is having anemia, oxygen is not going to the tissues. In stagnant hypoxia, pump problem, heart is not beating properly, so oxygen is not getting delivered to the tissues. But in histotoxic hypoxia, oxygen is going to the tissues, but the tissues are unable to use it. Okay, so in histotoxic hypoxia, where is the problem? The problem is within the cells. The problem is within the tissues. Okay, so that's the point which I want you to know. Okay, let me take this and copy. Paste. So done with this, respiratory is completed. With this, respiratory is completed, sir. So shall we start the renal? Abra, you understood? Right. So shall we start the renal? Our time is 2:30. Now we have to do it. 2:30, 3:30, 3:30, 4:30, 4:30, 5:30, 5:30, 6:30, 6:30, 7:30. 5 hours. Chalo, just I'm stopping the screen share for a minute. I have to download the thing. I'm just stopping the screen share for 1 minute. 1 minute, okay? Okay, downloaded. I'm sharing the screen. 3, 2, 1, start. Okay, see, now itself without any further late from my side. Okay, so this is the respiratory that we have discussed. All the included things, all things I have included everything. See, now itself, I'm sharing this to Andy, Mr. Andy. It is done. Okay, from my side, it's done. You can get it from the management. Okay, ask that person to forward it to you. Respiratory completed. Now, the fifth system that we are going to start is the renal. Sir, in renal, what is the most important uh, area where you can get the questions? The most important area is cystometrogram. Okay, cystometrogram is the most important area. Okay, lot of questions will come from the cystometrogram. Okay, that's the one important area which you need to know. See, renal, my renal physiology. Okay, my renal physiology. I'm going to integrate lot of things with the medicine. Lot of topics are going to be integrated with the medicine. Okay, even though it takes some time, sir, in your book, in your booklet, whatever is there, in your workbook, whatever I have provided to you, okay, in that workbook, almost 40 pages, I think, are renal only. Okay, lot of pages are renal. Lot of pages are there only for the renal. See, look, you can check it. Lot of pages are there for the renal. Okay, it's a very high yielding. Why, you can ask me, sir, I can teach renal within 1 hour. I can teach the entire renal for 1 hour, within 1 hour. But I will try to integrate as much as possible because it will be easy for you to answer the medicine questions. Okay, so without any further late, let's begin. Now, kidneys. How many kidneys do you have? I'm asking you. How many kidneys do you have, sir? Most of you, I think, have only one kidney. Okay, because for your girlfriend, you have you have sold one kidney, no, to buy her all the gifts, to buy her iPhone. You sold your kidney. Are you having 2 kidneys or only one kidney? I sold one of my kidney to gift my girlfriend. Okay, I'm having only one kidney right now. Just kidding. So we are having how many kidneys? 2 kidneys. Where are these kidneys present? See, kidneys are present between which vertebra levels? T12 to L3. Your kidneys, your lovely kidneys, 2 kidneys are present where? Between the 2 vertebrae. Like T12 to L3. Between the vertebra levels T12 to L3. Okay. Now, my question to you. Answer. Sir, kidneys are getting the blood supply from where? From where the kidneys are getting their blood supply? From where kidneys are getting the blood supply? Renal artery. But the question which was asked in the FMG exam is renal artery is a branch of. Renal artery is a branch of. Look, this is the question. So here is the abdominal aorta. Here in the center, abdominal aorta will be going. From the abdominal aorta at the junction of L1, L2. Okay, at the junction of L1, L2, in between, see, L1, L2 junction mein, so the renal arteries are coming. Okay, so renal arteries are the direct branches of abdominal aorta. Okay, so write these 2 points. Come. So kidneys are located between the T12 to L3, T12 to L3, T12 to L3. The renal artery arises at the level of L1, L2 junction. Okay, you can say not just L1 vertebrae, between L1, L2 junction. Okay, L1, L2 junction. If you have to pick only one thing, pick L2. If you have to pick only one thing, pick L2. Pick L2. Renal artery arises at the level of L2 vertebra. Okay. Now, kidney ka kaam kya hai? Functions of the kidneys. Kidneys, they have these 5 important functions, which at least I want you to know. The kidneys will filter your blood. Kidneys are going to filter your blood and excrete the waste products. Okay, the excretion of nitrogenous waste products. What are the nitrogenous waste products? BUN, blood urea nitrogen, and creatinine. Okay, not creatine, creatinine. Creatine is different. Creatine phosphate is different. This is creatinine. These are the waste products that are produced in our body. Okay, these 2 are the waste products. We need to excrete them. Okay, done. And your kidneys, your cute little kidneys, they will produce something called as erythropoietin. Erythropoietin. Who produces the erythropoietin? Which part of the kidneys? Kidneys may there are structures called as peritubular capillaries. Now students will scratch their head. Sir, what is peritubular capillaries? Let me tell you. Look at here. What is this? This is your kidney. This is your nephron, right? This is your nephron. Now your nephrons are surrounded by what? Blood vessels. Your nephrons are surrounded by the blood vessels. So these blood vessels are called as peritubular capillaries. Peritubular capillaries. These peritubular capillaries will produce. Okay, these peritubular capillaries, they will produce something called as erythropoietin. Okay. Now what is the function of erythropoietin? The function of erythropoietin is to increase the RBC production, blood production. Okay. So now you know erythropoietin is produced by kidneys. Which part of the kidneys? Nephrons. Which part of the nephrons? The peritubular capillaries of the nephrons. The peritubular capillaries of the nephrons. But in the exam, this option is not there. Peritubular capillaries is that option is not there. Then what do you have to mark? The best answer is the interstitial cells of, right? Is the interstitial cells of peritubular capillaries. So peritubular capillaries may there are interstitial cells. Okay, the interstitial cells of peritubular capillaries. The interstitial cells of peritubular capillaries produces erythropoietin. Yeah. Your kidneys also produce something called as renin, an enzyme. Renin is an enzyme, not hormone. It's an enzyme. Kidneys produce renin. Which cells of the kidneys? Nephrons. In nephron, which cells? There are cells called as juxtaglomerular cells in your kidneys. I will show you later. I will show you when you go into the topic. Me kidneys low. In your kidneys, there are cells called as JG cells. JG for juxtaglomerular cells. They produce renin. Renin helps in what? RAS pathway. Okay. Next, in your kidneys, vitamin D is activated. Okay, in your kidneys, vitamin D is activated. In kidneys, where? In your nephrons. In your nephrons, which part? PCT mein. PCT means proximal convoluted tubules. So the proximal convoluted tubule of the nephrons are the place where vitamin D activation will occur. We will discuss about this, don't worry. Okay, the last and final function is acid-base balance. Okay, acid-base balance. Your pH, how much is your pH? 7.35 to 7.45. 7.35 to 7.45, and it need to be maintained. Okay, your pH, your blood pH, your body pH should be always maintained at this level, 7.35 to 7.45. And who is maintaining that? Who is maintaining that acid-base balance? Any idea? The number one thing which balances the pH is your buffers in your blood. Buffers. Okay. Second thing is your lungs. Lungs can regulate your pH. Yes, true. And third is your kidneys. This is the order. Order you have to know. So buffers, lungs, and kidneys, they maintain your pH. So yes, kidneys maintain the acid-base balance. True. How, I will discuss later. So these are the functions of the kidneys. Okay, these are the functions of the kidneys. Now, let me ask you some questions. Just try to answer them. Sir, who is producing the renin? Renin is produced by juxtaglomerular cells. Excellent. Sir, erythropoietin is produced by don't look in your book. Erythropoietin is produced by interstitial cells of peritubular capillaries. True. Excellent. Next, vitamin D activation occurs in which part of the nephrons? Vitamin D activation. Excellent, Rekha. Yes, PCT. Excellent, Rahul. Yeah, everyone. Otherwise, Pranati, Satish. Yeah, true. Rahul, Subhatra, PCT. Done. Next. So let's start one by one. Important topics. Vitamin D activation. Listen carefully, sir. This is your sun, not your sun, our sun. Okay. So we are only having one sun, right? Yeah, sun. So what sun is releasing? The sun is releasing the UVB radiation. Okay, UVB radiation. We all know when you go and stand in the sun, you will get vitamin D. How, sir? This is your beautiful skin. Okay, this is your skin. Under your skin, what do you have? You are having a lot of cholesterol. You are having a lot of fat is there. Okay, that is the subcutaneous fat. So what is this fat? This is 7-dehydroxy cholesterol. Okay, so this 7-dehydroxy, not dehydroxy, sorry, it's a dihydroxy. Okay, 7-dihydroxy cholesterol. So under your skin, what do you have? The 7-dihydroxy cholesterol is there. Okay, whenever you expose your skin, to the sun, okay, in the morning, okay, you are exposing your skin to the sun by using this energy. Sir, UVB, it's a radiation, sir. It's a radiation. Whenever this radiation is falling on your skin, the molecule, the 7-dehydrocholesterol, okay, sir, the 7-dihydrocholesterol, it is converted by taking this energy, by using this energy. The 7-dihydroxy cholesterol is converted into a substance called as cholecalciferol. Okay, under your skin, it is changed. Now, what do you have? You have having cholecalciferol. Okay. Now, this cholecalciferol, where it will go? Now, this cholecalciferol, CCF, through the blood, via the blood, it will go to your liver. Okay, in the liver. So now CCF is going to the liver. Now, in the liver, do you know what happened to the cholecalciferol? Look. So this is the cholecalciferol molecule, cholecalciferol. Now, on the 25th carbon position, see, it's having the carbon chain. Okay. On the 25th carbon position, one hydroxy group is added. One hydroxy OH group is added. Now, what is happened? Now it becomes 25 hydroxy cholecalciferol. So in the liver, what is happening? So the cholecalciferol is converted into 25-hydroxycholecalciferol. This is inactive vitamin D. Okay, this is inactive vitamin D. This is inactive vitamin D. Okay, now this inactive vitamin D, look, now this inactive vitamin D, where it will go? It will go to the kidneys. Okay, through the blood, it will go to the kidneys. Kidneys where? To the nephrons. In the nephrons where? PCT. In the nephrons where? PCT. Okay, in the nephrons where? In the PCT. So this 25-hydroxycholecalciferol, it will go to the kidneys, to the proximal convoluted tubule. Now in the proximal convoluted tubule, this inactive vitamin D, the inactive vitamin D will be converted into, look, this is cholecalciferol. On 25th carbon position, one hydroxy group is there. But do you know what happens in the PCT? On the first carbon position, one more hydroxy group is added. So now it becomes 1,25 dihydroxy cholecalciferol. So 1,25 dihydroxy cholecalciferol. So this is the active vitamin D3. Okay, this is active vitamin D. Active vitamin D, that is cholecalciferol. Cholecalciferol is also called as a D3. Okay, active vitamin D. So where this activation is occurring? PCT. Why in PCT, sir? Because the enzyme alpha-1 hydroxylase is present in the PCT cells. So alpha-1 hydroxylase on the first carbon position. One hydroxylase on the first carbon position. Hydroxylation is happening. So alpha-1 hydroxylase ekkada untundi? Where alpha-1 hydroxylase is there? Alpha-1 hydroxylase is present in PCT. Okay, now you have active vitamin D. Okay, now what is the function of this vitamin D, active vitamin D? Sir, this active vitamin D, it will go to your intestines and it increases the absorption of calcium and phosphates. Calcium metabolism, very important. It increases the absorption of calcium and phosphates through your intestines. Okay, so that's it. So I can say simply vitamin D increases your blood levels of calcium as well as blood levels of phosphate. Okay, now this active vitamin D is also called as calcitriol. Okay, calcitriol. Okay, the active vitamin D, and one more name is there. 1,25 dihydroxycholecalciferol is also called as calcitriol. Increases the blood levels of calcium and phosphates. Okay, now my question to you, when this vitamin D activation occurs, when the vitamin D will be activated, in which conditions vitamin D will be activated? Let me tell you, sir, whenever the blood calcium level goes down, that is hypocalcemia. Okay, whenever the patient is having hypocalcemia, right? With me, right? Whenever the patient is having hypocalcemia, who is going to detect this hypocalcemia? Who will detect the calcium levels in your body? Who detects the calcium levels? Sir, this hypocalcemia is going to activate parathyroid glands. Now these parathyroid glands, they will produce a hormone called as parathyroid hormone. Okay, parathyroid glands produces parathyroid hormone. Now this parathyroid hormone, look what it is doing. It is activating alpha-1 hydroxylase. Now, only now the inactive vitamin D here. Now this inactive vitamin D will be converted into active vitamin D. Okay, now the inactive vitamin D is converted into active vitamin D in the PCT with the help of alpha-1 hydroxylase. So tell me, alpha-1 hydroxylase is under the control of which hormone? Alpha-1 hydroxylase is under the control of which hormone? Parathyroid hormone. So parathyroid hormone, right, with a big note. Let me write here. That's the question tested. So alpha-1 hydroxylase in a simple form, alpha-1, this is hydroxy. Alpha-1 hydroxylase is under the control of parathyroid hormone. So till here, do you have clarity?
See, there is a lot of controversy. There is a lot of controversy. People will say only early morning sun is going to give you that vitamin D, but it's not just something like that. As far as I know, and as far as I have gone through the journals, okay, the publications. Anytime when you go and expose yourself to the sun, okay, anytime when you go and expose yourself to the sun, that UVB radiation can give you vitamin D synthesis. Okay, inactive vitamin D is going to be produced. Okay. Nahala, yeah, Nahala. Okay, Nahala, I'm asking you. See, imagine, in your home. Okay, imagine in your home, there is 25 kilo rice bag. Okay, there is 25 kilo rice bag. So, are you going to cook? Okay, are you going to cook 25 kilos rice at the same time? See, ఉన్నాయని చెప్పేసి వండేలేం కదా like sir, you are having 25 kilos of rice. Do you think, will you say, sir, we are having 25 kilos of rice, let's cook 25 kilos of rice at the same time? No, you are not going to do that. Whatever is needed, whenever is needed, only then you are going to cook it. In the same way, when do you think this activation is going to happen? When do you think this activation will happen? When the activation will happen is, let me tell you, whenever your blood calcium level goes down. Okay, whenever you are having hypocalcemia, whenever your calcium levels are going down, that activates the parathyroid glands. First, hypocalcemia activates the parathyroid glands. Now the parathyroid glands produce parathyroid hormone. Okay, now this parathyroid hormone, what it will do? It activates alpha 1 hydroxylase. Only now, only whenever it is required. See, when alpha 1 hydroxylase is now active, then it converts the inactive vitamin D. Okay, inactive vitamin D, that is 25 hydroxycholecalciferol, whatever is coming to the kidney. Now this inactive vitamin D will be converted into active form only whenever it's required. Okay, so the alpha 1 hydroxylase is being activated by whom? Who is activating the alpha 1 hydroxylase? Parathyroid hormone. So alpha 1 hydroxylase activity is regulated by whom? Parathyroid hormone. Okay, you understand, Nahala? Done. Next, chalo. The next topic which I want you to know is, this thing is bullshit, not needed. Next is renin angiotensin aldosterone system. Simple thing, you have already done this in your first year. Renin angiotensin aldosterone system, RAS, RAAS. So if I am asking you, can you tell me what is the one function of RAS? I'm asking you. Okay, I'm asking you, can you tell me one function of RAS? RAS, tell me, it increases your BP. Okay, RAS pathway, what it will do? It increases your BP. RAS pathway increases your BP. That's it. That's at least minimum thing that you have to say. RAS pathway, sir, increases the BP. RAS pathway, sir, increases the BP. Done. Okay, so how it increases the BP? Let me tell you. Let's make a story here. Okay, let's take a story. So imagine the person is there. There is this one person. He is going on his motorcycle. Okay, he is having some hemorrhage, for example, hemorrhage. He had an accident, RTA, road traffic accident. He had a hemorrhage. Okay, whenever there is hemorrhage, what happened to his blood volume? Blood volume decreases. Okay, blood volume decreases. Whenever the blood volume decreases, sir, now what happened to the BP? Sir, BP will go down. First, here make a small correction. BP will go down. His BP is decreasing. That's the problem. Sir, blood volume is decreasing, so his BP decreases. Sir, now the patient is having low BP, shock. He's going to shock. Now tell me, during this condition, in order to increase the BP, whenever BP is decreasing, which nervous system is going to be activated? We have to increase the BP. Whenever your BP decreases, immediately your central nervous system activates sympathetic nervous system. So sympathetic nervous system is activated. Oh my God, BP is going down. Okay, sympathetic nervous system is activated. Now the sympathetic nervous system, the sympathetic neurons, what they will release? Epinephrine, norepinephrine. Now, this epinephrine, norepinephrine, now they are acting on juxtaglomerular cells. Why they are acting on juxtaglomerular cells? Because these juxtaglomerular cells having the receptor.
Okay, receptor. Which receptor? Beta 1 sympathetic receptor. Okay, pharmacology important. On the juxtaglomerular cells, which sympathetic receptor is present? Beta 1 sympathetic receptor is present. Now this beta 1 sympathetic receptor is getting stimulated. Okay. Now this JG cells in your nephrons release renin. So this is how renin is released. Okay, this is how renin is released. So whenever your BP decreases, yes, renin is released. Now what this renin should do? It should increase the BP. How it will increase the BP, sir? I will tell you. Okay, so at the end of the day, renin is released. Now what this renin will do? Now renin is in the blood. It's where? It's there in the blood. Now it's an enzyme. Renin is an enzyme. Don't forget, it's an enzyme. It's not a hormone, it's an enzyme. Now this renin is going to break angiotensinogen. It's always there in the blood. Angiotensinogen is produced by the liver. It's always there in the blood. Always there. Now this angiotensinogen will be converted into angiotensin 1. Okay, angiotensin 1. So renin is converting angiotensinogen into angiotensin 1. Now angiotensin 1, through the blood, it will go to the lungs. Okay, through the blood, it will go to the lungs. So in the lungs, the angiotensin 1, with the help of enzyme, angiotensin converting enzyme, with the help of angiotensin converting enzyme, the angiotensin 1 will be converted into angiotensin 2. Okay, angiotensin 2. Angiotensin 1 is converted into angiotensin 2. So now, in the name itself, it says, look, angiotensin. Angio means blood vessel. Tensin means constriction. So what it will do is, immediately it will cause the blood vessels in your body to undergo constriction. The blood vessels in your body are undergoing constriction. You tell me, when the blood vessels are constricted, what happened to the BP? The blood vessel is now constricting. So what happens? So when the blood vessel is constricting, the BP increases, the blood pressure increases. So the BP increases. So the problem solved or not? Yes, the problem is solved. So the problem is BP is low. Now, by doing the vasoconstriction, the angiotensin 2, by causing the vasoconstriction, it tries to increase your BP. Okay, it will increase your BP. So done. So tell me, what is the purpose of RAS pathway? The purpose of the RAS pathway is the minimum thing which you need to say, the purpose of the RAS pathway is to increase the BP. How? Angiotensin 2 causes vasoconstriction. Now, the angiotensin 2 is not satisfied. Okay, now this angiotensin 2 is not satisfied. Now this angiotensin 2, it will go and act on the adrenal gland. Okay. When it is acting on the adrenal gland, okay, when it's acting on the zona glomerulosa of the adrenal gland, endocrine. When angiotensin 2, when it acts on zona glomerulosa, now the adrenal gland will produce aldosterone, mineralocorticoid. You know the story. What aldosterone will do? Aldosterone, it increases the sodium absorption, right? It increases the sodium absorption or reabsorption from the urine. It increases the sodium reabsorption. So what happened to the sodium levels in the body? The sodium levels increases. Sodium, what it will do? It increases the BP. Even your mother and grandmother knows. Your mother knows that sodium increases the BP. So sodium increases what? Sodium increases the BP. So that's it. So problem is solved or not? Solved. Okay. So this is how RAS pathway is going to increase the BP. So RAS pathway increases the BP. True. RAS pathway increases the sodium reabsorption. True. Okay. When RAS pathway started, when you stimulate the beta 1 receptors, RAS pathway started. True. Okay. So now first tell me, do you have the clarity or not? Clarity? Vitamin D as well as RAS pathway. Just say yes is enough. Aliskiren, I will come, right? Aliskiren, I will come. Okay, don't worry about the Aliskiren, I will come. So now, if you want to inhibit the RAS pathway, there is a drug. There is a drug called as Aliskiren. Okay, it's a drug. What this drug will do? It inhibits the renin. When renin is inhibited, RAS pathway is inhibited. When RAS pathway is inhibited, you can control the BP, you can decrease the BP. Okay, so direct question is, Aliskiren is renin inhibitor. Aliskiren is a drug which inhibits the renin and RAS pathway. So what Aliskiren will do? It decreases the BP.
Aliskiren is inhibiting the RAS pathway. If RAS pathway is inhibited, BP decreases. BP decreases. Okay, so it can be used in the treatment of BP. It can be used in the treatment of hypertension. Okay, that's it. Now, question asked in FMG exam: what is the stimulus for RAS? RAS pathway activate होने को. Like, what are the stimulus? Okay, one thing you know already, hypotension activate the RAS. Okay, beta 1 receptor activation activate the RAS. True. And look, not only that, sir, hyponatremia means low sodium levels. Okay, if you have low sodium levels, that also activate RAS. Why? Because you know RAS increases, RAS can increase sodium reabsorption. RAS में aldosterone is there. Aldosterone can increase the sodium reabsorption. That's why. So what are the stimulus for the RAS activation? Hypotension is a stimulus. There is a low BP. Okay, whenever your BP goes down. Hypotension is a stimulus. Hyponatremia is the stimulus. And beta 1 receptor activation, or the sympathetic activation of beta 1 receptors, is a stimulus. Okay, these are the points which I want you to know. Next, some important single liners are: what is the renal blood flow? How much blood is going to both your kidneys? Both your kidneys every minute. How much blood is going? Almost 1.2 liters of blood is going, sir. Blood means what? Plasma plus cells, both together. How much blood is going? 1.2 liters. That is 20% of the cardiac output. Okay, you're 20% of your cardiac output. How much is the cardiac output? 5 liters, for example, round figure. 5 liters. Out of that 5 liters, almost 1 liter. That is the 20%. 5 liters low. In 5 liters, 1 liter is going to the kidneys. That is 20% of the cardiac output. Now, if I'm talking about only renal plasma flow, only plasma, not the blood. How much plasma is going? I'm removing the cells because cells are not filtered. Forget about the cells. How much is the renal plasma flow? 625 ml. Okay, blood flow is 1.2 liters. But if I'm talking only about the plasma, how much plasma is going? 625 ml plasma is going. Okay, look here. Look, imagine this is the blood vessel. How much is coming? 625 ml plasma is coming. Because only plasma is filtered. Only plasma is filtered. Now, what is this one? Here down. Now, you should tell me what is this. This is the nephron, right? This is the nephron. Okay. Sir, 625 vastundi. Okay, how much is coming? 625 is coming. Okay, 625 is coming to the kidneys, to the nephrons. In that 625, in all the nephrons together, okay, in all the nephrons together, how much is actually filtered? Out of the 625, every minute only 125 is filtered. Not in one nephron, sir. Not in one nephron. I'm talking about all the nephrons together. Anni nephrons lo kalipi. Okay. So 625 ml of plasma is coming. Okay, 625 ml of plasma is coming. Out of that 625 ml, 125 ml is getting filtered. So this 125 ml is called as 125 ml per minute. This 125 ml is called as GFR. Okay, GFR. Okay, that's the thing. So GFR is 125 ml per minute. So what is filtration fraction? So out of 625, 125 is filtered. That is 125 divided by 625. That is 20%. Okay. How much is filtered? 20% is getting filtered. 625 low. 625 में 125 filter हो गया. So that is 20% filtered. That is the filtration fraction. So now tell me, what is the renal blood flow? Renal blood flow is 1.2 liters. Okay, renal blood flow is 1.2 liters. Renal plasma flow. How much is the renal plasma flow? Renal plasma flow is 625 ml. What is the glomerular filtration rate? Glomerular filtration rate is 125 ml per minute. And what is the filtration fraction? Filtration fraction formula is GFR by renal plasma flow, that is 20%. And final thing, sir, now you know, if I ask you, sir, what is the renal blood flow? You will simply say 1.2 liters, the renal plasma flow, 625 ml. But imagine 100 years back.
or 200 years back. They are for the first time they are calculating. So for the estimation of GFR kanukodaniki, to estimate the GFR, to calculate the GFR, they use certain substances. They will inject such substances in your body. Okay, they will use certain substances. They will inject certain substances into your plasma. Okay, and they will look how much is the plasma concentration, how much is getting filtered into the nephron. So they will do a lot of calculations. Okay, but at the end of the day, what I want you to know is GFR is calculated or estimated by using which substance? Creatinine. Okay, creatinine is used. Creatinine or also inulin. Okay, inulin, creatinine, and also one more substance, cystatin C. So GFR is estimated by using which substances? GFR is estimated by using creatinine or inulin. And same renal plasma flow. GFR by, you know it. GFR estimated by creatinine. Renal plasma flow. Plasma, P for P. Renal plasma flow is estimated by injecting which substance into the body? So renal plasma flow is estimated by P for P, para-aminohippuric acid. So para-aminohippuric acid is used to calculate renal plasma flow. Renal plasma flow ni meer calculate cheyalanunte. If you want to calculate the renal plasma flow, what is the marker that should be used? What is the substance that should be injected into your body? Para-aminohippuric acid. That's it. Done. So we have completed the basic things. Functions of the kidneys. We have seen the activation of vitamin D. We have seen the activation of we have seen the RAS pathway. Okay, and some basic stuff. What's the time now? 3:15. Now I will give you a break. I will give you a break. Okay, I will give you a break. Later I will give you a break. First, let me ask you one thing. For example, in this class right now, whoever are listening, I'm asking this question to the girls. Okay, I'm asking this question to the girls. Do you think all boys are same? Rekha, do you think all boys are same? No, right? All boys are not same. Some boys are good boys. Some boys are like naughty boys. So something like that. Some boys are like bad boys. All boys are not the same thing, right? Yeah, boys is a good boy. So in the same way, you have millions of nephrons. 3.5 millions of nephrons are there in the kidneys. Okay, you have millions of nephrons. Do you think all nephrons are same? Definitely not. Just like all boys are not same and all girls are not same. Even your nephrons are not the same things. Okay, you are having two different types of nephrons. Sorry. Okay. So look here. There are two types of nephron. Two types of nephrons are there. What are they? First type is called as the juxtamedullary nephron and cortical nephron. Cortical nephrons and juxtamedullary nephrons. Look at this. Okay. Look at this. So this is your kidney. Okay. So kidney is having two areas. The outermost area of the kidney is called as what? Cortex. The innermost area is called as what? Medulla. Okay, cortex and medulla. Now, look what I'm drawing here. Here I am drawing in your kidneys. There are such things which are called as the renal pyramids. These are not the pizza pieces. Okay, these are your renal pyramids. Okay, renal pyramids. So here it's the cortex, here it's the medulla. Now I'm showing one such renal pyramid. Okay, these are the renal pyramids. Now, carefully look. There is this one nephron. Here, look, there is this nephron with the proximal convoluted tube, something like this. So this nephron, where it is present? Sir, this nephron, see, this is the Bowman's capsule. So this nephron is present in the cortex. So this is cortical nephron. Cortical nephron. Okay. So cortical nephron, look, it's a loop of Henle. This is the loop of Henle. No, this is the loop of Henle. Loop of Henle is short. It's a short loop of Henle. It's a short loop of Henle. Now, why I'm showing, saying it is a short loop of Henle is because, look, sir, एक और nephron है. Look carefully. Look carefully. Sir, this nephron, it is very near to the medulla. Okay, it's very, this is the medulla, right? This is the medulla. So this nephron, this nephron, or this nephron. So their Bowman's capsules are very near to the medulla. So that's why they are called as juxtamedullary. Juxta means side, just side to the medulla. These nephrons are there. These are the juxtamedullary nephrons. Okay, what are they? They are juxtamedullary nephrons. Now, if you look at the juxtamedullary nephrons, look at their loop of Henle. Their loop of Henle is very long, sir. They are going deep into the medulla. They're going deep into the medulla. Okay, so now at the end of the day, I have shown you cortical nephrons, which are more in number. MCQ. Cortical nephrons that are there in the cortex. 85% of the nephrons are the cortical nephrons. Okay, juxtamedullary nephrons are 15%. Okay, they will be 15 to 20%, somewhere around that. Okay, so juxtamedullary nephrons are less, cortical nephrons are more. You know, where is the Bowman's capsule? Renal capsule means Bowman's capsule. Bowman's capsule. Where is the Bowman's capsule of the cortical nephrons? In the cortex, outer cortex. Juxtamedullary nephrons, they have their Bowman's capsule where? In the inner cortex near to medulla. Okay. Okay. Cortical nephrons already discussed. They have short loop of Henle. Short loop of Henle. Juxtamedullary nephrons, they have long loop of Henle. Long loop of Henle. Function, cortical nephrons, they forms the urine. Normal urine, they forms the urine. But juxtamedullary nephrons, they concentrates the urine. The concentration of urine is done by juxtamedullary nephrons. Juxtamedullary nephrons can concentrate the urine. Okay, that's the difference. Cortical nephrons produce the urine. Juxtamedullary nephrons, they can be used to concentrate the urine. Okay, now let me draw here the two nephrons. You should tell me what is what. So there is this one nephron. This is the proximal convoluted tubule, and this is the loop of Henle. Here is the distal convoluted tubule. This is the collecting duct. This is, for example, nephron A. Now let me draw one more nephron in other color, green color or blue color. This is the other nephron. This is the proximal convoluted tubule. See, this is the loop of Henle. Okay. So what is this blue color nephron and what is the red color nephron? What is the blue color nephron? What is the red color nephron? Sir, A is a cortical nephron. It's a cortical nephron because it's having short loop of Henle. Okay. But B, this blue color thing, is having a long loop of Henle. Long loop of Henle. So this is juxtamedullary nephron. Okay, juxtamedullary nephron. So the difference, look. Sir, this cortical nephrons, they are surrounded by the blood vessels. These blood vessels are called as peritubular capillaries. Okay, peritubular capillaries. Juxtamedullary nephrons, they are surrounded by the blood vessels. Those blood vessels are called as vasa recta. Simple. Okay, so the blood vessels, see, tubule blood supply. Peritubular capillaries are present around cortical nephrons. Vasa recta is a blood vessel. Vasa recta is nothing but a blood vessel which is present around juxtamedullary nephrons. So these are the differences. That's it. So two types of boys. Okay, one is a short boy and one is a long boy. Okay, tall boy, not long boy, tall boy. Okay, so cortical nephrons and juxtamedullary nephrons. That's it. So done, completed. Now I will be giving you a break. Just I will give you, what's the time now? 3:20. We'll meet at 3:25. Okay. So respiratory, lot of concepts completed. Now renal also we have started now. Just to take a 5 minutes break. Okay. Yes, is this peritubular? Yes, exactly. Peritubular capillaries produce same peritubular capillaries produce erythropoietin. Abra, you're asking last day ECG and respiratory. What respiratory? Which respiratory? I have done the entire respiratory. No. What respiratory, Abra? Last day. No respiratory. Respiratory is already completed. Do you want me to invent something and teach you? Okay. So just relax. 2-3 minutes, just relax. We'll start again. Okay. Some parts have little confusion, little difficult. Abra, if you have any difficulty in understanding the concept, please message me personally. Please message me personally. I will explain you in detail. I will give you the voice message, okay, and video message if possible. So you ask me, sir, this is the place where I'm getting the difficulty. I can't understand this concept. Yes, I will explain it again. Okay, for you personally. Okay, let's continue. Now, after discussing about the two types of nephrons, now let's discuss about the structure and function of the nephron. Okay. Now, guys, look carefully. First, let me draw here what is normal. Okay, what is normal? Okay, normal structure of the nephrons. See, there is a blood vessel. Look, there is a blood vessel. which is bringing the blood to the nephron, not to the kidney. I'm not talking about the kidney. This is the blood vessel which is bringing the blood to the nephron. Okay. So this blood vessel is dividing into capillaries. And these capillaries, they are not forming venules. See, they are not forming venules. These capillaries are fusing and forming arteriole again. See, this is afferent arteriole. Okay, arteriole. It is divided into capillaries. It's divided into capillaries. And all these capillaries, they are not forming venules, but they are rather again forming arterioles again. So that is efferent. Okay, they are forming again arterioles. Afferent arteriole, capillary, efferent arteriole. Afferent arteriole is bringing the blood, or you can say plasma, simple. So here it's taking the blood. Efferent arteriole is taking the blood back. Okay. Now who is this one? Who is here? So here is the Bowman's capsule. Here is the Bowman's capsule, the first part of the nephron, into which the filtration is happening. Here the filtration will occur, GFR, glomerular filtration. Okay, glomerular filtration, GFR, glomerular filtration, right? So the plasma is going to be filtered. The plasma is going to be filtered. Okay. So the same thing, let me show you here. So this is the afferent arteriole. So this is the afferent arteriole which is bringing the blood. Now this afferent arteriole, it's coming like the same. It is dividing into small capillaries. These are all the glomerular capillaries. Okay. Now all these capillaries are fusing again, and what they are forming, sir? They are forming the efferent arteriole, taking the blood back. But here, what is this structure? Sir, this is the Bowman's capsule. Okay, this is the Bowman's capsule. Now this is the place where filtration will occur. Here, from here, the plasma is going to be filtered. Okay, plasma ikkada filter avutundi. Okay, the plasma is going to be filtered here into the Bowman's capsule. Now understood? Now down to it, what is this one? This is the PCT, proximal convoluted tubule. The first, like after the Bowman's capsule, we have the proximal convoluted tubule. Okay, into the part. Afferent arteriole, glomerular capillaries, efferent arteriole, Bowman's capsule. Bowman's capsule continues as proximal convoluted tubule. Okay. Now, here, I want to add a little bit in detail. What is the filtration barrier? What does it mean by filtration barrier? Filtration barrier means what? Look carefully. Again, let me draw the same diagram. Here, I'm talking only about the glomerular capillary. Okay, I'm talking about what? Glomerular capillary, not about the afferent and efferent arterioles. Arterioles, I'm not talking about that. This is the glomerular capillary. Okay, it's the glomerular capillary. This one. Okay, this one, capillary. I'm talking only about this area. This area I'm talking about. Glomerular capillary. Now, glomerular capillaries, they are lined by what? They are lined by these epithelial cells. Okay, glomerular capillaries, okay, they are lined by these epithelial cells. Now, in between these epithelial cells, there are gaps. Are you able to appreciate the gaps? Okay, are you able to appreciate the gaps? These gaps. These gaps are called as what? These gaps are called as fenestrations, right? Okay, they are called as what? Fenestrations. Now, these epithelial cells, these are all the epithelial cells, right? Now, these epithelial cells, where they are lying, the epithelial cells, they are lying on the basement membrane. All the epithelial cells, doesn't matter where, they're all lying on what? They're lying on the basement membrane. So this is the basement membrane, basement here. Epithelial cells are sitting on this green color thing. What is this green color thing? This is green color thing is nothing but the basement membrane. Let me write here. Let me write. This is BM, basement membrane. Basement membrane is made up of type 4 collagen. MCQ. Okay, basement membrane is made up of type 4 collagen. Okay. Now, down to the capillaries, what do you have? No, you tell me. Down to the capillaries, what do you have? Down to the capillary, we are having the Bowman's capsule. We are having this Bowman's capsule. Let me draw the Bowman's capsule for you. Let me use which color? Pink color. Bowman's capsule. So look. Here I am drawing the Bowman's capsule. Okay. This is the Bowman's capsule. Now the Bowman's capsule is also lined by the cells. Okay, the Bowman's capsule, it is also lined by the cells. So these cells which I am drawing here, so what are these cells called as? they're having these foot-like processes. Okay, these Bowman's capsule, they are lined by the cells with the foot-like processes. These cells are called as, right, podocytes. So podocytes, sir. Okay. Now, what is the gaps between the podocytes? See, in between the podocytes, are you able to appreciate the gap or not? This gap is there. This gap is called as this gap. See, there is a gap. So this gap is called as slit pores or fenestration slits. Okay, slit pore. Simply remember them as a slit pore. That's a slit pore. That's a slit pore. Now, in the slit pore, okay, in the slit pore, there is a structure present. Look, in the slit pore, there is a structure present. In the slit pore, who is there? There is a structure. There is a proteinaceous structure present. Okay, there is the structure which is made up of proteins. That is called as slit diaphragm. That is called as what? Slit diaphragm. Okay. So now, sir, the plasma, where is the plasma? Here is the plasma. The plasma have to cross how many layers to enter into Bowman's capsule? You tell me. So the plasma have to cross how many layers? The plasma have to filter the plasma from the glomerular capillaries. The plasma from the glomerular capillaries, it have to be filtered into the Bowman's capsule. So how many layers it have to cross? Layer number 1 is this epithelial layer. Okay. Layer number 2 is this basement membrane, and the layer number 3 is the podocytes. So these are the 3 gates. These are the 3 barriers for the filtration. Filtration ki 3 gates unnai. There are 3 gates for the filtration. Okay, so plasma have to cross 3 layers. So that's the same thing. Here I have written. So filtration barrier include the 3 structures, which includes the capillary endothelial layer. Okay, this is the endothelium. Okay, the lining of the blood vessels. Okay, this lining of the blood vessels. Okay, those epithelial cells lining the blood vessels. Those epithelial cells lining the blood vessels are called as endothelial cells. Kada. Endothelial. So these endothelial cells are the first layer. Okay. Next, glomerular basement membrane made up of type 4 collagen. And third layer is the podocytes. Okay, podocytes. So the same thing see here. Here, I'm showing you one glomerular capillary. This is the glomerular capillary in the center. That's the glomerular capillary. Now, if I make a little zoom, see, this is endothelial layer. See, endothelial layer is having fenestrations. These are the small holes, fenestrations in between the endothelial cells. Next, there is glomerular basement membrane. This is a basement membrane. Down to the basement membrane, what do you have? These are the podocytes. Okay. In between the podocytes, are you able to appreciate there is slit diaphragm? Look here, there is slit diaphragm. The structure is called as a slit diaphragm. Okay. This image, if you don't understand, just leave it. Okay. If you can't understand this image, just leave it. You just follow my image. This one. This one. So how many structures are involved in the filtration barrier? 3 structures: capillary endothelium, glomerular basement membrane, and podocyte foot processes. Done. Now, my question to you, see, which substances are going to be filtered? Array, now from the plasma, the substances have to filter. One substance, for example, substance X, it have to filter down. Now, which substances are filtered? Small substances or very large substances? Small substances are filtered. So, look, size of the particles which are freely filtered, 4 to 8 nanometers. Okay. So, which size particles are freely filtered? 4 to 8 nanometer particles. 4 to 8 nanometer particles are freely filtered. Gaps between the endothelial cells. Okay. Gaps between the endothelial cells. What are the gaps called as? Fenestrations. Already I have discussed with you. Gaps in it. See these gaps through which the substances are filtered. Those gaps are called as fenestrations. The gaps between the podocytes, they are called as slit pores. The gaps between the podocytes are called as slit pores. Okay. So done. Now, please add one more thing in the same diagram. Please add one more thing. What is that? Sir, look at the glomerular basement membrane, sir. Basement membrane. Okay. Let me take some color. Yeah. Glomerular basement membrane is green color thing, right? Green color thing, basement membrane. Now it is having a charge, sir. It's having a charge. Which charge? It is having negative charge, right? This glomerular basement membrane is having which charge? Negative charge, right? Now, why there is this negative charge? That negative charge is because of, right? The glomerular basement membrane, here itself, right? It is having negative charge. Why there is negative charge? Because of certain negative proteins. Here there are negative proteins present. Here there are negative substances present. Because of those negative charged substances, the glomerular basement membrane is having negative charge. Okay, because of the negative substances which are present in the glomerular basement membrane, it is having negative charge. So what are those substances? Recent question. Heparan sulfate. It's present in the glomerular basement membrane. So this is a negative charge substance. Next, proteoglycans. Okay, proteoglycans, and third one, sialoproteins. So these substances like heparan sulfate, main important, heparan sulfate, proteoglycans, and sialoproteins, these are present in the glomerular basement membrane. So because of these three substances, the glomerular basement membrane is having negative charge, and that is normal. So ikkada daaka clarity unda. If you say, sir, it's okay, I will go forward. If you say, sir, it's clear, I will go forward. No, slit pores. Who is Jyoti Sharma? You're asking. Slit pores are the gaps. Slit pores are the gaps. Imagine this is the slit pore. This is the slit pore. In the slit pore, there is slit diaphragm present. In the slit pore, there is slit diaphragm present. They are not the same. Slit pores में slit diaphragm है. Okay. Now, see the glomerular filtration barrier. Okay. See, for example, I don't know how many of you see football. See, in football, we say Messi. Okay, Messi is there, right? Messi. We say him GOAT, greatest of all time. GOAT. Okay, we gave him like, these things, like, these names. For example, in India, for example, for Shah Rukh Khan, he was given a name like a superstar, like, mega star, kind of, right? Things, right? So this glomerular basement membrane, it is also having a name. We gave certain names. What are they? This glomerular basement membrane, it is called as size barrier. Why it is called a size barrier, or why it is a size barrier, and why it is a charge barrier? See, glomerular basement membrane or the glomerular filtration barrier, glomerular filtration barrier includes three things: capillary endothelium, glomerular basement membrane, and podocytes. This filtration barrier is a size barrier. Why it is a size barrier? Because it allows only small substances to filter. It's a barrier to bigger substances. It's a barrier to large particles. So that's why it's called as a size barrier. It allows the filtration of only small substances. That's why it is a size barrier. Okay. Then why it is called as a charge barrier? Why it is called as a charge barrier? The glomerular filtration barrier is a charge barrier. Why? Because it doesn't allow the negative charge substances to filter. Okay, it doesn't allow the negative charge substances to filter because the stuff, the story. Already glomerular basement membrane is having which charge, sir? It is having negative charge. They go here. It is having which charge? Negative charge. If any negative substance, look at me, sir. There is this one substance. Okay, let me take which color? Some special color. Let me take. Okay, let's take for example this one. Some X substance. X. Now this X substance is having negative charge. Okay. Now this X substance, can it come down? No, it can't come down because physics. Negativity will repel the negativity. Negative charges repel. Okay. Same charges repel. So here it is negativity. Here it is negativity. So those charges are getting repelled. So negative charges are not filtered. But positive charges, the negative will attract the positive. So that's why the glomerular filtration barrier is a charge barrier. Because the negative charge substances are not going to be filtered. Okay, I have already taught you. Glomerular filtration barrier is having which charge? Negative charge. Negative charge is because of what? Heparan sulfate, sialoproteins, and proteoglycans. And proteoglycans and even glycoproteins. Proteoglycans. Okay, so these are all the things. But in your exam, one question was asked. That question is heparan sulfate. This is the one question which was asked in the exam. So there are glycoproteins, proteoglycans, heparan sulfate, sialoproteins. These are all negative things. These are all negative things. Okay, next, sir, which substances are not filtered? Are your RBCs are going to be filtered into the nephrons? RBCs, are they filtering into the nephrons? No. If they are filtering into the nephrons, you will have bloody urine. Okay, so substances which are not filtered, RBC is not filtered in the nephrons, into the nephrons. RBCs are not filtered. WBCs are not filtered. Platelets are not filtered. Plasma proteins like albumin, globulin, fibrinogen, they are not filtered. Clotting factors, not filtered. Why they are not filtered? Because they are bigger size. They're all bigger size. Bigger size substances are not filtered. Okay. Now I'm asking you one question. See, look at here. Sir, this is a glomerular capillary. Imagine this is the glomerular capillary. Okay, glomerular capillary. Then what is this? Is the glomerular capillary. What are these cells? Can you tell me? These are endothelial cells. Okay, endothelial cells. Now, can you tell me what is this one? Basement membrane, glomerular basement membrane. If that is a glomerular basement membrane, what is the structure? Bowman's capsule with which cells? You know the stuff. Podocytes. Okay. Now, my question is, same. There is a substance which is called as albumin. See, albumin. See this albumin. Do you know what is the size of albumin? 3 nanometers. Very small. 3 nanometers. Albumin. Very small. Now I'm asking you, which substances are normally filtered? 3 to 4 nanometer substances are normally filtered. It can be easily filtered. 3 to 4 nanometer. 4 to 8 nanometer substances. I have already told you 4 to 8 nanometer substances are freely filtered. I gave you already. Where? Here. 4 to 8 nanometer substances are normally filtered. Now my question to you. Albumin, will it filter or not? Try to answer it. Sir, albumin is very small. Very small. 3 nanometers. 3 to 4 nanometers. Is it filtered or not? Is it filtered or not? No, it is not filtered. Why it is not filtered? Albumin, plasma protein. It is not filtered because it's not filtered because it's having negative charge. Excellent. Albumin, though it is small, it is having negative charge. So that's the question. Okay. So it is negative charge. Here also negative charge is there. So it is not filtered. Okay. It is not filtered. So albumin will be repelled. Albumin molecules are repelled. So look here. Albumin, small in size, but negatively charged. So it's not filtered. Okay. If I am talking about glucose, look here, the down. Glucose. Sir, glucose, is it filtered? Yes, absolutely, no doubt. Glucose is freely filtered into the nephrons. Okay, glucose is freely filtered. And amino acids also. Glucose and amino acids are freely filtered. But RBC, WBC, platelets, plasma proteins, clotting factors are not filtered. Okay, glucose is freely filtered. But it is completely reabsorbed. We'll reabsorb the glucose. Completely will reabsorb the glucose. Okay, amino acids are also freely filtered, but we reabsorb it. Okay, so done, sir. The substances which are filtered and substances which are not filtered. Completed. The topic is completed. Okay, now I'm going into little clinical integration from patho and medicine. Little clinical integration. Okay. Guys, look carefully at this diagram. Okay, look carefully at this diagram. What is this? Here I'm talking about glomerular capillary. Look. What is this? The glomerular capillary domain. Okay. Now, here what are these cells? Capillaries are lined by which cells? These are the endothelial cells. What is the gaps between the endothelial cells? What is this gap? These gaps are called as fenestrations. Okay. These endothelial cells are lying on which membrane? Glomerular basement membrane. I'm showing in the reverse direction. Okay. Now, the other side of the glomerular basement membrane, which cells are there? What are these cells? These are the podocytes. This is a podocyte. These are all the podocytes. Okay, these are all the podocytes. Okay, sir. Understood. Podocyte. Now, look. So what is the gaps between the podocytes? What are these gaps between the podocytes? So the gap between the podocytes is called as slit pores. You know. Okay, this is called as a slit pore. And in the slit pore, what is the protein that is present? Sir, there is slit diaphragm. Look. Array, sir, there is slit diaphragm here. Look, there is a slit diaphragm. Okay. Slit diaphragm is there. Slit diaphragm is there. Now, my question to you. Actually, slit diaphragm is acting like a gate. Okay, it's also acting like a gate. So it doesn't allow the substances to easily filter. It's like a gate, sir. These are the gates. Okay, these are the gates. Now, if there is any damage to this gate, now tell me, if there is any damage to this gate, now even big size substances are filtered. Even big size substances like plasma proteins, they will start to filter. Okay, so that's the concept which I want you to know. So the number one point is, sir, there are these gates called as slit diaphragm. First, number one point. Sir, the slit diaphragm is made up of proteins. Which proteins? Look here. Sir, slit diaphragm, it is made up of podocin. Okay. So slit diaphragm is made up of, right? Slit diaphragm is made up of podocin, nephrin, and alpha actinin. So podocin, alpha actinin, and nephrin. Podocin, nephrin, and alpha actinin. Podocin, nephrin, and alpha actinin. These are the proteins which are forming the slit diaphragm. Okay. Now, integration, medicine integration. Okay, medicine integration. Look, all these things are not needed for you. These are all bullshit, garbage, not needed. Now, look, what they will ask in your exam is, nephrin, nephrin is a protein which is forming the slit diaphragm. Nephrin is a protein, right? Yes, see, it's a protein. If it is a protein, definitely it should have a gene. Proteins are coded by the genes. So there is a gene, NPHS1. Okay, there is NPHS1 gene, which is coding for a protein called as nephrin. Now, what if this NPHS1 is mutated? This NPHS1 is mutated. NPHS1 mutate aite. If the NPHS1 is mutated, then nephrin will be affected. If nephrin is affected, slit diaphragm is affected. If slit diaphragm is affected, proteins will leak into the urine. Okay. So mutation in NPHS1 can lead to congenital nephrotic syndrome. Okay. What is nephrotic syndrome? Loss of proteins. So the patient is losing the proteins. If the patient is losing the proteins, every day the patient is losing the proteins. Every day he's losing the proteins. How much proteins, sir? More than 2.5 grams of proteins every 24 hours in a day. In a day, if the patient loses more than 2.5 grams of proteins, sorry, not 2.5 grams, 3.5 grams of proteins. Okay. If the patient loses more than 3.5 grams of proteins in a day, okay, if the patient loses more than 3.5 grams of proteins in a day, then it is called as nephrotic syndrome. Okay. So what you need to know is, sir, NPHS1 gene mutation can lead to, okay, NPHS1 gene mutation can lead to damage to nephrin. If nephrin is damaged, mutated, slit diaphragm will be affected. Okay, slit diaphragm will be affected. SD, slit diaphragm will be affected. That will lead to losing of proteins. That is called as, this disease is called as congenital, means by birth. By birth, the patient is losing the proteins. The congenital nephrotic syndrome of Finnish type. It's a type of nephrotic syndrome. Okay, it's a type of nephrotic syndrome, right? So tell me, congenital nephrotic syndrome of Finnish type is due to mutation of NPHS1. Okay. Next thing, sir, there is one more gene which is called as NPHS2. Okay, there is one more gene which is called as what? NPHS2. If this gene is mutated, the patient is going to have defect in podocin. Okay, the patient is going to have what? Defect in podocin. When podocin is defective, okay, when podocin is defective, again slit diaphragm is affected. When the slit diaphragm is affected, again the patient will lose the proteins. Again he will lose the proteins. Okay, again he will lose the proteins. So that disease is called as steroid resistant nephrotic syndrome of childhood onset. Okay, so it's a different type of nephrotic syndrome. Okay, it's not treated with steroids. It's not able to treat this. You can't able to treat it with the steroids. So steroid resistant nephrotic syndrome of childhood onset is due to mutation of NPHS2. Which protein is affected? Podocin protein is affected. Okay, so that's the point which I want you to know. So, clarity unda leda? This is, do you have clarity or not? Podocin, nephrin, NPHS1, NPHS2. What is the question which was asked in the exam? NPHS2 codes for is a question which was asked. NPHS2 codes for podocin. Podocin defect will lead to steroid resistant nephrotic syndrome. Okay, steroid resistant nephrotic syndrome. NPHS1 mutation causes defect in nephrin. Nephrin defect will cause which type of nephrotic syndrome? Congenital nephrotic syndrome of Finnish type. Good answer. Do you have clarity or not? Simple. Let me ask you one question. You just tell me, sir, steroid sensitive congenital nephrotic syndrome of Finnish type is due to a mutation of which gene? Is due to mutation of which gene? Is due to mutation of which gene? Are NPHS2? NPHS1. Okay, steroid sensitive. I'm talking about steroid sensitive. Look, steroid sensitive means NPHS1. Steroid resistant means NPHS2. Don't confuse. Steroid sensitive. Okay, this disease is treated with the steroids. Okay, the first one can be treated with steroids. Okay, the first disease can be treated with steroids. Okay, why? We exactly don't know. Still, like, researches are going on. Research is going on. So that's the thing. Integration with medicine, highly important. Okay, sir. Next, chalo. Why filtration is happening? Okay, why filtration is happening? Let me tell you. First of all, 125 ml per minute filtration is happening. But why? But why filtration is happening? Let me show you here. Glomerular capillary. Okay. Down, what is this? This is the Bowman's capsule. You already know it, sir. From yesterday's class, you know almost 80% you already know. Sir, in the glomerular capillary, this is the glomerular capillary. Now, what is happening here? Here, filtration is happening. Glomerular filtration rate. How much? 125. But why that filtration is happening? Okay, let me tell you why that filtration is happening. Because here, what do you have? Plasma is there. And what do you have here, sir? The water, the plasma, you can say. Plasma is there. Okay, so that plasma, what it is doing, it exerts the pressure on the walls. The plasma, it exerts the water molecules, it exerts the pressure on the walls of the blood vessel. That pressure is called as hydrostatic pressure. Okay, so there is hydrostatic pressure. How much is that hydrostatic pressure in the glomerular capillary? 60 mmHg. 60 mmHg. So this hydrostatic pressure always wants to move the plasma out. Okay, hydrostatic pressure always, see, hydrostatic pressure always wants to move the plasma out of the blood vessel. Okay, in this direction also. Okay, the water molecules are exerting their pressure on the walls. Okay, I said you, in your blood vessels, there is also something called as albumin. Albumin. Okay, albumin is there. Albumin molecules. What they will do? They are like a sponge base. Albumin molecules, they will try to attract the water. They will try to keep the water within the blood vessel. They will try to do what? Keep the plasma within the blood vessel. That is called as what? It will creating an opposite pressure called as oncotic pressure. And how much is that oncotic pressure? That oncotic pressure here, it is 32. Okay, the oncotic pressure here, it is 32. Okay, let me write here itself. 32 mmHg. Okay, so hydrostatic pressure is a favoring force. It's hydrostatic pressure, it favors the filtration. Oncotic pressure opposes the filtration. Okay, there are two forces: hydrostatic pressure, oncotic pressure. My dear students, please tell me, sir, in the Bowman's capsule also some fluid is there. Okay, here also fluid is there. after filtration. Here also fluid will be there, no? Okay, it's not a dry land, it's not a dry area. Here also fluid is there. Now tell me, sir, this fluid, okay, this fluid, what it will do? It will exert pressure like this. It is exerting pressure in this direction. What is this? This is also the hydrostatic pressure. So this is, say, P, capital P, W. Sorry, not W, B. So hydrostatic pressure in the Bowman's capsule, B for Bowman's capsule. Here it is hydrostatic pressure in the capillary, PC. Hydrostatic pressure in the capillary is how much? 60. What is the hydrostatic pressure in the Bowman's capsule? Do you have any idea? It is 18. Okay, it is 18. Okay. So now this 18, is it favoring the filtration or opposing the filtration? It is opposing the filtration. Okay, because it is showing the pressure from the opposite direction. Okay. So now tell me, how many forces are there? 3 forces. Who is favoring the filtration? This hydrostatic pressure, it favors the filtration, but the other two opposes the filtration. Okay, so let me draw the same thing here. Let me write one by one. So Starling forces. Okay, net filtration pressure, final filtration pressure, how much? Favoring forces. Okay, favoring forces minus opposing forces. Okay, favoring forces minus opposing forces. What is the favoring force? Hydrostatic pressure in the glomerular capillary, how much? 60 mmHg. What are the opposing forces? Opposing forces are oncotic pressure. Okay, let me write here. Sorry, small change which I want you to know is, this is actually denoted not with the letter, this one, pi, the letter pi. Please make it pi. Okay, oncotic pressure. Here it is denoted with letter pi. Okay, oncotic pressure with the letter pi. Okay. Now, let's continue. So, what is the oncotic pressure here? Oncotic pressure, how much? Sir, oncotic pressure is 32 mmHg. Students will confuse. Sir, here is the osmotic pressure. Oncotic pressure is nothing but osmotic pressure because of albumin. Oncotic, osmotic pressure, they are the same. Okay, don't get confused. Oncotic pressure is the osmotic pressure exerted by albumin. Okay, just no issue. And what is the pressure in the Bowman's capsule, PB? It is 18 mmHg. So final, tell me, add these two. 32 plus 18 is 50 mmHg. And what is the favoring force? Favoring force is 60. Favoring force is 60. Opposing force is only 50. So now tell me, who is more? Favoring force is more. So 60 minus 50, how much? 10 mmHg. Okay, 60 minus 50, 10 mmHg. So favoring forces are greater. Okay, favoring forces are greater. So now the question which will come in your exam is, glomerular filtration occurs with a pressure difference of, okay, with a pressure difference of 10 mmHg. Okay, so there is 10 mmHg pressure difference. So favoring forces are more. Okay, so that's it. Now already I have explained you. So how you can estimate the GFR? GFR is estimated. GFR estimation ke liye we can use inulin, creatinine, cystatin C. Already we have discussed this. Cystatin C, creatinine, and inulin. These are the markers which can be used to estimate the GFR. These are the markers which can be used to estimate the GFR. Done. Okay. So now tell me, glomerular filtration rate occurs with a pressure difference of only 10 mmHg. That's why, as a doctors, we should be very much concerned. If there is any pressure changes in our body, if hypertension, hypotension, that will greatly affect the kidneys. Hypertension, hypotension, that will affect the kidneys because kidneys are functioning. Kidneys are functioning based on the pressure difference. If there is any pressure fluctuation in our body, the BP fluctuation in the body, automatically kidneys will be affected. Glomerular filtration rate will be affected. Okay, that's important. So here I have written, no, Najib, you're asking, if they ask you, what is the most commonly used? Creatinine. Okay, creatinine is most commonly used. Okay, creatinine is most commonly used. But what is the best gold standard? Inulin.
Okay. Creatinine is most commonly used. Best is inulin to estimate the GFR. To estimate the GFR, inulin is best. Inulin is best. So done. This is also completed, sir. Now, sit back, relax, take a deep breath. Relax, just relax, make yourself calm. Whatever you are learning, okay, whatever you are listening to, okay, it's very easy. All these are very easy. What you need to do is just you need to by heart them. Okay, you need to memorize them. You need to memorize this concept. First, simple. So there are two types of nephrons. What are the two types of nephrons? Juxtamedullary nephrons, cortical nephrons. Two types of nephrons. Who are more in number? Cortical nephrons are more in number. Okay. Glomerular filtration barrier includes three structures: endothelial layer, glomerular basement membrane, and podocytes. Slit diaphragm is present in the slit pores. Slit diaphragm is made up of, close your eyes and think, slit diaphragm is made up of podosin and nephrin. Nephrin and podosin. Nephrin is coded by NPHS1. Podosin is coded by NPHS2. Okay, something like that. Steroid sensitive is Finnish type. Steroid sensitive is congenital nephrotic syndrome of Finnish type. Steroid resistance is because of NPHS2 mutation. Okay, only negative charge substances are not filtered. Albumin is negative charge, so it is not filtered. But the glucose and amino acids are filtered. Okay, think about RAS pathway. Think about vitamin D activation. Okay, RBC, WBC, platelets, clotting proteins, plasma proteins are not filtered. There is a size barrier and charge barrier. Glomerular filtration barrier is a size and charge barrier. It's having negative charge because of heparan sulfate. Just think. You can close your eyes and you can just memorize it. Okay. So having said that, chalo, let's discuss about the formula to calculate the GFR. So GFR, already 125 ml per minute. But how to calculate it? GFR calculation करने के लिए, this GFR calculation करने के लिए, and the same formula is used for clearance of any substance. Okay. Clearance. So for the clearance as well as for GFR, it's the same formula. So what is the formula for the calculation of GFR? The formula is UV by P. Simple, UV by P. UV by P is the formula for GFR. UV by P is the formula for GFR. Okay. So what is this UV by P, sir? U stands for here urine concentration of a substance. For example, what is that substance? Creatinine. You can take creatinine or inulin. Okay, you have injected the inulin. So how much inulin is there in the urine? And how much volume of urine is getting produced? And what is the P for? Plasma concentration of that same substance, inulin. So how much inulin is there in the plasma? How much inulin is there in the urine? And how much urine is getting produced, volume? So if you know these three parameters, you can calculate the GFR or clearance of the particular substance. How much substance is getting cleared every minute? Every minute, how much substance is getting cleared? Or every minute, how much GFR is happening? So the formula is UV by P. Okay, UV by P. So now I have given a question here. You just try to tell me the answer. Okay, just try to answer this. Urine flow rate. Okay, urine flow rate is 2 ml per minute. Okay. So you know one thing, urine flow rate, that is the volume of urine. 2 ml per minute. Okay. They're asking, see, what is the clearance? Immediately you have to say, clearance ka formula, sir, UV by P. Clearance of the substance whose plasma concentration is 10 milligrams per ml and urine concentration is 100 milligrams per ml. Okay. So you know the values. Let's put it one by one. What is the U value? U value is urine mein how much is there? 100. V, what is the urine flow rate? 2 ml per minute. And what is the P value? UV by P. P value is 10. So now tell me, what is the clearance of the substance? What is the clearance of this particular substance? So 100 into 2 is 200 by 10. So how much is that? 20.
So the answer is the substance, 20 milligrams of substance is getting cleared per minute. So that's the clearance formula. The same formula can be used for GFR also. Same formula can be used for GFR also. Okay, now you understand? Okay. So that's it. So that's the formula for GFR. Next, after this, if I am the examiner, I will give the question from this area only. Changes in GFR. How your GFR will change? Glomerular filtration rate 125. Okay, but it changes. It changes. How? Don't write anything. Just look at the slide. Okay, just look at the slide. It's very easy. Very easy. Now, sir, here I am talking about. This is afferent arteriole. Here is the glomerular capillary. And here is what? Efferent arteriole. This is what? Efferent arteriole. Efferent. Okay. This is afferent arteriole. Here it is efferent arteriole. Now, you please look here. Now, what I have done here. This is afferent arteriole, right? What I have done to the afferent arteriole, you please tell me. Afferent arteriole is dilated. Now, afferent arteriole is just dilated. So, afferent arteriolar dilation. When you dilate the afferent arteriole, what happened to the GFR? When you dilate the afferent arteriole, more blood will come. Here, more pressure will be there. So, more filtration will occur. Simple, right? So, afferent arteriolar dilation increases GFR. Okay, simple thing. Afferent arteriolar dilation increases the GFR. Exactly opposite thing. So, what you are doing here? Afferent arteriole is constricted. Okay, afferent arteriole is constricted. So, when you constrict the afferent arteriole, look, when you have afferent arteriole constricted, when you constrict the afferent arteriole, what happened to the GFR? GFR decreases. That's it. The two things. Okay. So the same thing I have shown here. First, the last one. Look at the last one. Look at the last one. So this is the afferent arteriole, sir. Okay, here is the afferent arteriole. Okay, let me take some other color. Okay. Yeah. See here, afferent arteriole is getting dilated. Afferent arteriole. When the afferent arteriole is dilated, what happened to the GFR? See, GFR increases. GFR increases. Now, who causes afferent arteriolar dilation? Prostaglandins cause afferent arteriolar vasodilation. Okay, afferent arteriolar vasodilation. Who the hell is going to cause afferent arteriolar vasodilation? It's the prostaglandins. Also write atrial natriuretic peptide (ANP). Both these two things. MCQ. Atrial natriuretic peptide as well as the prostaglandins are going to cause the afferent arteriolar vasodilation. When you do the afferent arterial vasodilation, that increases the filtration GFR. That increases the GFR. More GFR. Okay. So one thing completed, D completed. Now the other thing, sir, here a afferent arteriole is constricted. Okay. When you constrict the afferent arteriole, okay, afferent arteriole, right, constricted. What happened to the GFR? See, GFR decreases. GFR what happens? GFR decreases. When the see, now my question is, who is causing the contraction of the afferent arteriole? Who is causing it? Okay, so answer is norepinephrine. Okay, look, your norepinephrine and adenosine. This is important. Norepinephrine, adenosine. What they can cause? They can cause afferent arteriolar vasoconstriction. Okay, norepinephrine and adenosine, they can cause afferent arteriolar vasoconstriction. Thereby, they decreases the GFR. GFR को decrease करेगा. Okay. Next, so two things are completed. Two things are completed. Now, again, I'm drawing one more diagram. Look, sir. Now I'm not talking about the afferent arteriole. Afferent arteriole, I'm keeping it normal. Afferent arteriole, I'm just not talking about it. Here is the glomerular capillary. Here is the glomerular capillary. Now I'm talking about the efferent arteriole. Efferent arteriole, it is getting constricted. Okay. So efferent arteriole constricted. Efferent arteriole is constricted. Now, when the efferent arteriole is constricted, now you tell me, sir, blood is coming, no doubt. So initially, blood is coming here, and it's unable to go out. So what happened to the back pressures? Sir, blood is unable to escape. Blood is unable to escape. So here, blood pressure increases. So what happens? Now more filtration will occur. Okay. So initially, GFR increases. Okay, when the efferent arteriole is constricted, GFR increases. But if there is, like, see, now you know, now you have, see, you have to know something. Blood will move from high pressure to low pressure. Normal, I'm talking about the normal thing. Blood will move from high pressure to low pressure. Not only blood, any fluid will move from high pressure to low pressure, right? See, now after some time, what happens is, if there is severe constriction, if there is so much increase in pressure here, now here the pressure is increasing. So automatically the amount of blood that is coming in is also going to decrease, because here you are developing the higher pressure, here you are developing the higher pressure. So now the amount of blood that will come here also decreases. Blood flow decreases because already here there is higher pressure. Okay, so the blood that will come decreases. So later on, if there is severe constriction, GFR later decreases. So initially, or if there is less constriction, is GFR increases. But if there is severe constriction for so long time, later GFR decreases. Okay, both will happen. If efferent arteriole is constricted, initially GFR increases, but later it can decrease, it can go down. So this is called as biphasic response. It's called as a biphasic response. Who will cause the efferent arteriole to constrict? Angiotensin 2. Okay, angiotensin 2. Okay. So angiotensin 2, what it causes? Angiotensin 2, it increases the GFR, true. Angiotensin 2, it increases the GFR. So RAS pathway increases the GFR, true. Okay. So the same thing, look here. See here, the efferent arteriole is constricted, the B1. See here, the efferent arteriole is constricted because of angiotensin. Okay, angiotensin 2 constricts efferent arteriole. GFR initially increase, later decrease. GFR initially increases, later decreases. This is called as what? Biphasic response. Okay, biphasic response. Angiotensin 2. From where it is coming? It is coming from RAS pathway. Last thing. Okay, last thing is, sir, here is your afferent arteriole. No doubt, this is normal. Here is the capillary. Now your efferent arteriole, look, your efferent arteriole is dilated. Okay, so efferent arteriole dilation. When your efferent arteriole is dilated, now you tell me, sir, blood is coming here, and blood is not staying here. Very easily it is escaping. Blood can easily escape. So what happened to the GFR? Simple, GFR decreases because blood is not staying here. Blood is easily going. Okay, going out, escaping. Blood is easily escaping the glomerular capillaries. So what happened to the GFR? GFR decreases. Okay, so that's the point which I want you to know. Efferent arteriole, if it is dilated, okay, if someone asks you, efferent arteriole, if it is dilated, what happened to the GFR? Simple, GFR decreases. Okay, so simple thing. Here I have given. So if, see, look here, efferent arteriole, if it is dilated, okay, how you can dilate it? By using the drugs like ACE inhibitors. If you use the drugs like ACE inhibitors, RAS pathway is inhibited. No angiotensin 2. If angiotensin 2 is not there, it is dilated. It's dilated. When the efferent arteriole is dilated, what happens? GFR decreases. That's it. Not initially, not later. Simple. GFR decreases. That's it. GFR decreases. So now I will ask you certain questions. You just try to answer them. Okay. I will ask you certain questions. You just try to answer them. First, tell me, is it clear? Guys, is that clear? So let's check. Sir, norepinephrine, norepinephrine, what they will do to the GFR?
epinephrine, norepinephrine, what they will do to the GFR? You think, sir, epinephrine, norepinephrine causes afferent arteriole to constrict. Afferent arteriole to constrict. So GFR, afferent arteriole to constrict. Rekha, concentrate. Afferent arteriole constrict aite. If afferent arteriole is constricted, blood is not coming to the glomerulus. So what happens? GFR decreases. GFR decreases. If afferent is constricted, GFR decreases, Rekha. Don't confuse. Next, sir, prostaglandins, what they will do? Prostaglandins, what they will do to the GFR? Prostaglandins, what they will do to the GFR? Prostaglandins, what they will do to the GFR? They increase the GFR. Prostaglandins and atrial natriuretic peptide. Prostaglandins and atrial natriuretic peptide, they increases the GFR. Next, efferent arteriole dilated. Efferent, exit E. Efferent arteriole vasodilation. If efferent arteriole is dilated, what happens to the GFR? Decreases the GFR. Okay, so these are the topics. These are the changes which you need to know regarding afferent arteriole constriction dilation, efferent arteriole constriction dilation. Okay, if I am the examiner, definitely I will give from here only. And when you are doing the Q banks and when you are doing through the books MCQs, a lot of questions will come from this area. Okay. Now, see. Now, see. I'm talking about this glomerular capillary here. Now, this capillary which I am showing you, this is the glomerular capillary. Okay, glomerular capillary. Cross section, I'm showing the glomerular capillary. How can we say this is the glomerular capillary? This is the glomerular capillary, sir. This is the glomerular capillary. How can you say? Because are you able to appreciate these gaps? What are these gaps? Fenestrations. Glomerular capillaries have holes. Glomerular capillaries, they have these holes, which are called as fenestrations for the filtration purpose. Okay. Look, these glomerular capillaries, they're in certain places, they are surrounded by cells. Okay, the cells, which are called as mesangial cells. Okay. Glomerular capillaries are surrounded by what? Mesangial cells. Okay. Now, these mesangial cells are like smooth muscles. Okay, they are like smooth muscles, mesangial cells, like smooth muscles. Sometimes they will undergo contraction. Sometimes they will undergo relaxation. Okay, sometimes what they will do, they will undergo contraction, they will undergo relaxation. Now tell me, look at me. Sir, imagine this is the glomerular capillary. Okay, this is the glomerular capillary. Imagine this is the glomerular capillary. Now this glomerular capillary is surrounded by what? Mesangial cells. Okay, this is the mesangial cell. It's like this. No, you think logically and tell me. If the mesangial cells are contracting, if the mesangial cell is contracting, what happened to the GFR? A mesangial cell, if it is contracting, it is closing the glomerular capillaries. Now the glomerular capillaries are getting collapsed. Now the glomerular capillaries are getting collapsed. So blood flow is not happening to the glomerular capillaries. So what happened to the GFR? What do you think? What happened to the GFR? If the glomerular capillaries, if they are contracting, okay, the mesangial cells, first the mesangial cells are contracting, so the glomerular capillaries are collapsing. The glomerular capillaries are collapsing. So what happened to the GFR? Simple, decreases. Yes, excellent. So when the mesangial cells are contracting, what happened to the GFR? GFR decreases. When they are relaxed, when the mesangial cells are relaxed, more blood flow will be there. When the mesangial cell, when it is relaxed, more blood flow will be there through the glomerular capillaries. So what happened to the GFR? GFR increases. So these are the questions which you can find in the Q banks. Mesangial cells. Mesangial cell contraction mesangial cell contraction decreases the GFR. Mesangial cell relaxation increases the GFR. Contraction decreases the GFR. Relaxation increases the GFR. That's it. Okay. So done. Mesangial cell and GFR changes also completed. Mesangial cell and GFR changes also completed. Okay. Now just sit back and relax. Sit back and relax for a minute. See, we are getting lots and lots of concepts, no, at the same time. Renal is highly conceptual and so many questions will come. Sit back just and relax. Later I will explain you about the that tubuloglomerular feedback. Okay. In a minute I will be explaining you the tubuloglomerular feedback. Now, chalo, let's start. See, here is the afferent arteriole. Okay, now from this side, I am showing the afferent arteriole. Okay, this is the afferent arteriole. Here is the glomerular capillary. And this side, this is the efferent arteriole. Okay, so this is afferent arteriole, glomerular capillaries, efferent arteriole. So blood is coming in this direction. Okay, now what I'm showing you here, what is this? This is the Bowman's capsule. This is the proximal convoluted tubule. You know, after that, what is this? Loop of Henle. After the loop of Henle, it's coming like this loop of Henle. And here, what do you have? The distal convoluted tubule. After that, what do you have? Collecting ducts. So we are having collecting duct. Listen here carefully. Sir, on the afferent arteriole, there are modified smooth muscles present. Okay, there are these modified smooth muscles present. Modified smooth muscles which are present on the afferent arteriole. Okay. What are these modified smooth muscles called as? These are called as juxtaglomerular cells. Okay, JG cells. Juxtaglomerular cells. JG cells. Now tell me where JG cells are present? JG cells are present on afferent arteriole. Why they are called as juxtaglomerular? See, because they are present side to the glomerular capillaries. Side to the glomerular capillaries. J means side. Juxta means side. G for glomerulus. This whole area is called as the glomerulus. So they are juxtaglomerular cells. They are what? Modified smooth muscles. Not modified. Modified smooth muscle cells. Okay, modified smooth muscle cells. Next, on the ascending limb of loop of Henle. See, look carefully here. This is the descending limb of loop of Henle. This is the ascending limb of loop of Henle. This is ascending limb. At the last part of the ascending limb of loop of Henle. Look, this is the, imagine this is the last part of the ascending limb of loop of Henle. On the last part of ascending limb of loop of Henle, there are these cells. Okay, where they are present? And the ascending limb of loop of Henle. Okay, and the ascending limb of loop of Henle, there are these black colored cells present. These black colored cells, thick black colored cells present, these are called as macula densa. These cells are called as macula densa. Where the macula densa is present? On the ascending limb of loop of Henle. That's the best answer. On the ascending limb of loop of Henle, who is there? Macula densa is present. Juxtaglomerular cells are present where? On the afferent arteriole. Okay, juxtaglomerular cells are present in the afferent arteriole. They are just like, I used to remember them like, you know, boyfriend and girlfriend. Okay, the juxtaglomerular cells are like boyfriend, macula densa is like girlfriend. So boyfriend, girlfriend. So in between boyfriend, girlfriend, some useless fellows are always there. Okay, some useless fellows who doesn't have any work, they are there, right? Even between this juxtaglomerular cells and macula densa, some useless cells are there. We don't know the function of these cells. Okay, so between boyfriend, girlfriend, who is there? Besties are there. Okay, they don't have any function. Stupid fellows. So here also in between these two cells, some cells are there which we don't know what is the function of them. They are called as, okay, extraglomerular. They are extra fellows. Extraglomerular mesangial cells. Okay, extraglomerular mesangial cells. Okay, now all these three together called as, all these three structures together, they are called as
juxtaglomerular apparatus. Okay, so this is juxtaglomerular apparatus. It's made up of 3 cells. The juxtaglomerular apparatus, the juxtaglomerular apparatus is made up of the JG cells, macula delsa, as well as some non-functional cells, which are called as extraglomerular mesangial cells, also called as Paul-Kissing cells. Okay, extraglomerular mesangial cells, that bestie cells. The extraglomerular mesangial cells are also called as Paul-Kissing cells. Paul-Kissing, P-O-L, Paul-Kissing, K-I-S-S-E-N, Paul-Kissing cells. Okay, extraglomerular mesangial cells are also called as Paul-Kissing cells. The same thing. Okay, same thing. I have written over here. Look, JG apparatus is made up of JG cells, macula densa, as well as extraglomerular mesangial cells, also called as Paul-Kissing cells. Okay, forget about the slashes. They're called as Paul-Kissing cells. Forget about this. Paul-Kissing cells are extraglomerular mesangial cells. JG cells are also called as granular cells. Okay, done. Now, just wait, let me see. How many questions from renal? See, I have told you already. Renal is highly integrated with medicine. Okay. Now you can't say which is the renal question, which is the renal physiology question, or which is from the renal medicine question. You can always say every system have a base weightage of 2. Okay, every system can have a base weightage of 2. Renal also 2. Okay. But indirectly, if we talk indirectly, see, there is something called as SIADH, diabetes insipidus, Conn syndrome, Bartter syndrome, Fanconi syndrome, Liddle syndrome. Okay, see, we'll discuss about many syndromes. They will all come in, they will all show up in medicine. Okay, they will all integrate with the patho and medicine. So weightage will be somewhere like 4 or 5 questions. Okay, chalo. Next, why we have to understand? Okay, why we have to learn about this juxtaglomerular apparatus? Sir, if you ask me, sir, juxtaglomerular apparatus ka function kya hai? Okay, what is the function of this juxtaglomerular apparatus? That I will tell you now. Okay, look, the topic which I am going to discuss is called as the auto-regulation of GFR. Okay, auto-regulation of GFR means your GFR will be regulated 125 ml per minute. It's always 125 ml per minute. It's getting regulated. Means it's not going up, it's not going down. Means it's not going down means, okay, it might go to 120, it might go to 115. Okay, but it is not going too much down, or it's not going too much up. So there is someone who is always regulating. Okay, how it is regulated, let me tell you. First, mechanism number 1. Mechanism 1. What is this? For example, say, because of some reason, sir, because of some reason, your GFR is increasing. Is that good or bad? Tell me. Arey, sir, if your GFR is increasing, that is bad, because the kidneys can undergo damage. If too much filtration is happening, that hyperfiltration can lead to injury. Hyperfiltration injury can occur. So that's bad. That can lead to glomerulosclerosis. That's bad. So too much GFR is bad. So whenever there is too much GFR, do you know what happens? Sir, when there is so much filtration, automatically more sodium is also filtered. It's a simple no. See, this is the glomerular capillary. Here is the Bowman's capsule. Now, here more filtration is happening. If more filtration is there, means automatically more sodium is filtered, more chloride is filtered. Okay, that's what I have written here. So whenever your GFR increases, more sodium is filtered, more chlorine is filtered. Okay. Now, where the sodium and chlorine are going? So through the Bowman's capsule, proximal convoluted tubule, loop of Henle. Now the sodium is coming to macula densa. Okay. Now where the sodium is coming? Sodium is coming to macula densa. Now macula densa will understand. Macula densa is like a brain. Let me write here. It is no way lesser than the brain, sir. In your kidney also there is a brain. In your kidney also there is a brain. Who is that brain? Macula densa. It understands the things. Array, so much sodium chloride is coming to me. So much sodium chloride is coming to me. Means it understand. Array, GFR increased. It's GFR increased, that's bad. GFR increased, that's bad. So imagine I am the macula densa. Okay, I am the macula densa. Look at me. Look at me, sir, once. Imagine I am the macula densa, sir. Now, if I see more sodium chloride going in the urine, I will understand. Array, sir, there GFR increased in the Bowman's capsule. At the glomerulus, GFR is more. So immediately, do you know what I will do? Now immediately the macula densa will produce a substance called as adenosine. Now you know about the adenosine. Now adenosine, I have discussed causes adenosine and epinephrine, norepinephrine. They causes afferent arteriolar vasoconstriction. When afferent arteriolar vasoconstriction occur, what happened to the GFR? GFR decreases. Good. GFR decreases. So problem solved or not? Yes, problem solved. Whenever GFR is increasing, your macula densa, which is a part of juxtaglomerular apparatus. Okay, macula densa, what it is trying to do? It is trying to decrease the GFR, and that is good. That's good. Okay. Now, for example, say, whenever your GFR is going down, okay, whenever your GFR is going down, automatically the amount of sodium that is getting filtered also decreases. Less sodium chloride is getting filtered. Okay, let me write here, less sodium chloride filtered. Okay, less sodium chloride is filtered. Now, when less sodium chloride is filtered, yes, less sodium chloride is going to the macula densa. Okay, less sodium chloride is going to the macula densa, so less sodium chloride is there. Now, macula densa will understand, array, less sodium chloride is coming means, okay, less sodium chloride is coming means, it will understand, sir, GFR is decreased. So immediately, do you know what macula densa will do? Macula densa will release certain chemicals which we haven't discovered. Now, so far, no one have discovered what is this chemical. Macula densa releases certain chemicals which will activate the JG cells on afferent arteriole. Now macula densa will activate the JG cells. Okay. Some unknown signal is getting released from the macula densa. It activates the JG cells. Now JG cells release renin. You know the stuff. JG cells, what they are doing? Renin. You know the later story. Renin activates which pathway? RAS. RAS में who is produced? Angiotensin 2. Angiotensin 2 I have just discussed with you. Angiotensin 2. Don't forget, students. Angiotensin 2, what it will do? Angiotensin 2 causes efferent arteriolar vasoconstriction. Okay. When the efferent arteriolar vasoconstriction occur, what happened to the GFR? GFR increases. So that's why I say now efferent arteriolar vasoconstriction occurs, that increases the GFR. So problem solved or not? Problem solved. The problem is less GFR. So GFR is being increased. GFR is trying to come back to normal. Okay. Okay. So your GFR will be auto-regulated with the help of macula densa, and juxtaglomerular cells. Or I can say your GFR is getting auto-regulated with the help of JG apparatus. Okay. So this is called as a tubuloglomerular feedback. This is called as what? Tubuloglomerular feedback. What is the tubuloglomerular feedback? What is the name? Array, there is someone who is sitting on the tubule. Who is that? Macula densa, which is sitting on your nephron. That is the tubule. It is giving signal to the glomerulus, that is afferent arteriole and efferent arteriole, to contract or relax. You are understanding? See, here, afferent arteriole is getting constricted. Here, efferent arteriole is getting constricted. With the help of what? Macula densa. Macula densa is doing the job. Where is macula densa present? It is present on the tubule. So it is giving the feedback. It is giving the feedback to the glomerulus to constrict or dilate, to maintain the GFR. So this is called as tubuloglomerular feedback. The direct questions which was asked in the exam, the tubuloglomerular feedback is mainly given by macula densa. Where is macula densa present? On the tubule. Which tubule? Ascending limb of loop of Henle. Okay. Now this macula densa, it's like a brain, I have said you. What it is sensing? It is sensing the sodium chloride levels. It is looking at the sodium chloride levels. By looking at the sodium chloride levels, it will understand whether the GFR is increasing or decreasing. It's by sensing the sodium chloride levels, it will understand whether the GFR is more or less. So macula densa, MCQ, macula densa is sensitive to, I don't know whether you can see it or not. Macula densa, it is sensitive to what? Both sodium and chloride, not just sodium. In one of the FMG exam, they have given macula densa is sensitive to option number A, sodium. Option number B, chloride. Option number C, both. Option number D, none. Both sodium chloride. Macula densa is sensitive to both sodium as well as chloride. This is called as what? Tubuloglomerular feedback, maintaining the GFR. Is that clear? If you say clear, I will go forward.
Give me the confirmation. Now I'll show you one question which was asked in the exam. Just try to answer them. Okay, you don't know it. But anyway, you don't know it. But anyway, I will first show you the question. You just try to answer it at least. Renal, right? See, for example, I will come. For example, say, okay, I haven't explained you this, but still, you try to answer it. You try to answer it. This is the question. It's little confusing, but you can still, if you use your brain, you can still answer it. Sir, efferent arteriolar constriction means efferent is constricted. Think. Yeah. So efferent arterial constriction causes all except. Sir, efferent, when efferent is constricted, initially GFR increases, later GFR decreases. Yes, GFR decreases, true. When efferent is constricted, okay, when efferent is constricted, what happens to the renal blood flow? I have said you, look, sir, this is the efferent. When efferent is constricted, here pressure increases. So the amount of blood that comes here, the amount of blood that will come is also going to decrease, no doubt. Because the back pressures are generated, back pressures are generated. So the amount of blood that will come into the kidneys also decreases because now there is more pressure inside the kidneys. The blood is not going forward. The blood is unable to go forward. So the amount of blood that will come also decreases. So this is also true statement. Okay. Now, look, just let me clear. When you constrict the efferent arteriole, look here. When you constrict the efferent arteriole, just see. Initially, what will happen? Initially, filtration will happen here. Means more fluids are getting filtered, more plasma is getting filtered. Now, will plasma proteins are filtered? Any plasma proteins are filtered here? No, plasma proteins are not filtered. Only you are removing what? Only you are removing plasma. Only the plasma is getting filtered, not the plasma proteins. So plasma proteins are getting concentrated, like albumin, say albumin, globulin, okay, fibrinogen. See, they are getting concentrated now because you are removing the fluid. As you are removing the fluid, now the plasma proteins are getting concentrated. Now, when the plasma proteins are getting concentrated, see, now the plasma proteins, now slowly they will go. Slowly they will go into the efferent arteriole. Okay. See, here it is constricted, not totally collapsed. It is constricted, but still the blood is going slowly. Now, tell me, as you have removed the fluid, what happened to the concentration of plasma proteins increased, albumin is increased, the concentration increased. So what happened to the oncotic pressure? Oncotic pressure increases, not decreases. So not decreases, increases. Okay. So as you are removing the fluid, here the plasma proteins are concentrated. Okay. The plasma proteins are concentrated. So because of the plasma proteins, because of the albumin, what do you have? Oncotic pressure. So what happened to the oncotic pressure? Increases. So here they accept no. This is the wrong statement. Decrease in oncotic pressure. No, not decrease. Increase. Okay. So this is the wrong statement. Now you understood. Now you understood it or not? It's a little tricky question. So such kind of questions were asked in FMG exam. So that's why. Understood? Maria, you understood? You don't understand? Say simple. Efferent arteriole is not. Yeah, super question. Yeah. When efferent, look, when efferent arteriole is constricted, efferent ni constrict cheste. When you constrict the efferent, filtration is happening. Okay, initially, see, even if it takes some time, no issue. But this, like, you are not supposed to lose even one question. See, now, when you constrict the efferent arteriole,
Okay, when you constrict the efferent arteriole, what happens? Initially, GFR increases. Initially, the fluid is getting more fluid is getting filtered. GFR increases. So what does it mean GFR increases? You are removing the plasma. You are removing the more plasma is getting filtered. More plasma is getting filtered. Sir, when more plasma is getting filtered, now tell me, what happened to the plasma proteins here? The plasma proteins are not filtered. So plasma proteins are getting concentrated. Okay, you are removing only the fluid. The plasma proteins are concentrated. As the plasma proteins are concentrated, as the plasma proteins are getting concentrated, what happened to the oncotic pressure? Oncotic pressure increases. Okay, oncotic pressure increases. If you constrict the efferent arteriole, oncotic pressure here increases, no doubt. Okay, so that's the question. So let me copy this. Let me paste it in our thing. Paste. Now, let me show you one more question. You just try to answer it. Let me show you one more question. So simple. See, such kind of questions are also asked in the exam, FMG exam. Renin is secreted by unite, juxtaglomerular cells, JG cells. Okay. See, this is also FMG question. Okay. Sir, the protein in the glomerular basement membrane responsible for the charge dependent filtration is, I have said you, heparan sulfate. It gives the negative charge. It prevents the loss of albumins. I have discussed. Okay. Yeah. This is the question. Okay. Anyway, it was already given. What is the function of tubuloglomerular feedback? What is the function of tubuloglomerular feedback? Just now I have explained you tubuloglomerular feedback with the help of macula densa. What it is doing? It regulates the GFR. It regulates the GFR. FMG question. Let me copy and paste it over there. But before that, one more question is also there. Okay, first let me paste it over there. Let me paste it. Now, look at this question. You just try to answer it. Okay, it was anyway. See. PYQ previous year question. According to the myogenic hypothesis. So there is something called as, okay, myogenic hypothesis. You don't know. Don't worry about it. Don't worry about it. Sir, according to myogenic hypothesis. See, again, renal autoregulation. Okay, renal autoregulation of GFR. Means autoregulation of GFR. The afferent arterioles contract in response to stretch induced by. Now, most of the students will scratching their heads. Hey, sir, what is this? What is this? Very simple. Now, I have told you one way to regulate the GFR. One way to regulate the GFR. What is the one way to regulate the GFR? Tubuloglomerular feedback. It regulates the GFR. Okay, that's the first way. Now, the other way to regulate the GFR is myogenic hypothesis. Myogenic hypothesis also regulates your GFR, and it's a proven FMG question. It was asked. Why would I teach you if it is not important? I won't teach you, first of all. So first let me teach you what is that myogenic hypothesis. Second mechanism, myogenic hypothesis. Simple. Myogenic hypothesis means, look, here is afferent arteriole. Okay, let me draw it here. Afferent arteriole, glomerular capillary, and efferent arteriole. Okay, here is the afferent arteriole. Okay, now look, whenever more blood is coming, for example, more blood flow is coming, sir. More blood flow. More blood flow is coming. Whenever more blood flow is coming, what happened to the GFR? The GFR may go up, increases the GFR. That is good or bad? That's bad. GFR is increasing. That's bad. So whenever more blood is coming here there will be more blood pressure. More blood pressure is there. So this is bad, right? More blood is coming. That's bad. That's bad. That's not good, because that can lead to increase in the GFR. That is again bad. So what happens is, whenever here BP is more, what happens is, look, around the smooth muscle, see, around the afferent arteriole, there are smooth muscles. Afferent arterioles are surrounded by smooth muscles. These are the smooth muscles. Whenever here BP increases inside the afferent arteriole, whenever there is more blood pressure, that opens the calcium channels here. That's going to cause stretch. That increase in BP, that increase in blood flow will stretch the afferent arteriole. First, it will stretch the afferent arteriole. Because of that stretch, these calcium channels are opened. Okay, the calcium channels which are present over here, the calcium channels are opened. Now calcium will go into the muscle from outside. The calcium will go into the muscle. Okay, so the calcium causes contraction. The calcium causes contraction of the afferent arteriole. So afferent arteriole will undergo constriction. Okay, the smooth muscle will undergo contraction. Smooth muscle undergoes contraction. ఈ స్మూత్ మజిల్ కాంట్రాక్ట్ అవుతుంది. ఓకే, ద స్మూత్ మజిల్ విల్ అండర్గో కాంట్రాక్షన్. The smooth muscle contraction will undergo, sorry, the smooth muscle contraction leads to afferent arteriolar constriction. So again, GFR will be decreased. GFR will come back to normal. Initially, GFR increased, but it will be brought back to normal. Means regulated. This is all because of the muscles. Muscles are doing that job. The smooth muscles are doing that job with the help of which ions? Calcium. Aha, okay. So again, one by one. Whenever there is more blood flow coming, or whenever there is more BP, that stretches the afferent arteriole. That first stretches, that increase in BP causes the stretch in afferent arteriole, which will open the calcium channels. Calcium will go into the smooth muscles. That smooth muscles, by using the calcium, smooth muscles will undergo contraction. When the smooth muscles are contracted, immediately afferent arteriole will undergo vasoconstriction. Okay, when afferent arteriole is vasoconstricted, you know the story. When afferent arteriole, now it will immediately undergo vasoconstriction. So that will lead to decrease in the GFR. Okay, so this is called as myogenic hypothesis. Okay, now based on this, what is the answer? According to myogenic hypothesis, renal autoregulation of GFR, the afferent arterioles contract in response to the stretch induced by opening of calcium channels. So this is the answer. Okay, it's the FMG question. If you say, sir, we have never seen this, I can't help you. These are the questions which were asked. Okay, it's also asked in one of the PG exams. In PG exams also same question was asked. So let me take this too. Okay, let me copy, let me paste it here. Okay, done. It was pasted already. So renal autoregulation of GFR is completed. Renal autoregulation of GFR is completed. Now I will give you break. Okay, I will give you break. You just go and relax for some time. Now what's the time? Today class will be, now just the time is 4:49, 4:50. I will take the class till 7 o'clock. You just go and relax, and later we will do the more concepts. You want the break? Why 15 minutes? Rekha, you are tired. People, you are tired? Please tell me. Rekha is tired. What about the others? Yeah, Rekha is saturated. Okay, I will give you the break. So in the break, what you do is, okay, I will give you the break. In the break, you just try to revise. Okay, just try to just go like that. Okay, just revise. Have a cup of coffee. Revise. I will give you 15 minutes break. Okay, I will give you 15 minutes break. Now it's 4:50. 4:50. I will meet you at 5:05. Yeah, of course, for some students, these are interesting. For some students, it's boring. If you are a student like me, you will feel bored. Okay, I'm a very bad student. Okay, I'm a very bad student. But anyway, okay, I will meet you at 5:05. Take 15 minutes break. 15 minutes break. Take.
Okay. Okay, guys. Break completed. So got refreshed. Yeah. Is pre-PG question bank good? Definitely good. No doubt in that. It's good. It's good. Pre-PG question bank is good. Yeah. So what I used to do is I used to collect all the MCQs. Like, yeah. If you are in this profession, you have to go through each and every Q bank. Like, I have gone through all the Q banks. Yeah, pre-PG is also good. Pre-PG will directly target the PG. Okay. So chalo. Without any further late, now let's go further. So far what we have discussed is all the basic things. Okay, basics in renal is completed. Okay, now we are going into parts of nephron and their functions. Okay, for the next 1.5 hour, we'll be discussing about the parts of the nephrons and their function. The first part of the nephron, after the Bowman's capsule. No, I shouldn't say first part of the nephron. After Bowman's capsule, what do we have? Proximal convoluted tubule. Okay, so okay, look at here. This is Bowman's capsule. Down to the Bowman's capsule, what is this? Proximal convoluted tubule. Now, I'm talking about this PCT, proximal convoluted tubule. See, this proximal convoluted tubule, it have brush border epithelium. Okay, the epithelium is going to have brush border. For example, let me show you what I'm talking about. For students who doesn't know, look, if this is the part of PCT, if I'm showing you this is the PCT, see these epithelial cells, they will have border like this. Okay, they will have a border like this. Why border is like this? Because it increases the surface area. It increases the surface area for the reabsorption. So more substances can be reabsorbed. So the PCT may. So in the PCT, you have cells with the brush border. The cells are having this brush border. What is the importance of the brush border? Increases, right? Increases surface area. Now, in the PCT, most of the substances are reabsorbed. Most of the substances are reabsorbed. For example, glucose, reabsorbed. So, maximum substances are reabsorbed. So, it is highly active segment. Highly active segment. It uses more ATP. More ATP. This PCT is going to use more ATP to reabsorb the substances. So, it is highly metabolically active. So, if it is working more, it requires more oxygen. So in the conditions of hypoxia, so whenever there is hypoxic condition, who is going to die first? Who is going to die first whenever there is hypoxia? The PCT is going to die first. So proximal convoluted tubule is going to be highly susceptible for the hypoxia. Okay, PCT is highly susceptible for what? Hypoxia. Okay, done. So PCT, brush border, high surface area, high metabolic activity, high ATP usage, high mitochondria will be seen here because they generate more ATP. So high mitochondria will be there. High amount of reabsorption, maximum reabsorption, highly susceptible to hypoxia. So which substances are reabsorbed in the PCT? A substances reabsorb both eye. Okay, which substances are reabsorbed in the PCT? So in the PCT, 100% of the glucose amino acids are reabsorbed. 70% of sodium, chloride, water, urea, potassium, 70% of calcium, and 80% of bicarbonates are reabsorbed in the PCT. So all substances, maximum substances are reabsorbed in the PCT, except magnesium. Write this. So most of the substances are reabsorbed in the PCT. Maximum reabsorption of water, sodium, calcium. Okay. Maximum substances are reabsorbed in the PCT except calcium. Okay. Now look at this. See, I will say this is a part of PCT. Okay, this is a part of this is a segment of the PCT. How can I say? See, here you are having what? This is a brush border. Brush border increases what? Brush border increases the surface area. So this is definitely a part of PCT. Now, here is the urine going. This is the place where urine is going. Urine. So substances first reabsorbed into the cell. Substances first reabsorbed into the cell. Later on, the substances will go into the peritubular capillaries. The substances are going to be reabsorbed back into the blood. So that's what I want you to know. Okay. So from the urine, substances will first come into the cells. From the cells, the substances will go back into the peritubular capillaries. Substances are getting reabsorbed. Okay. Now next, here, first let me discuss about the glucose reabsorption in the PCT. Take the heading. Glucose reabsorption in PCT. How much glucose is reabsorbed? Just now I have explained you. 100% of the glucose is reabsorbed in the PCT. Just now here I have shown you 100% of the glucose is reabsorbed in the PCT. Every molecule of the glucose is reabsorbed in the initial part of the PCT. Okay, in the initial parts of the PCT itself, the glucose will be reabsorbed. All glucose molecules, we want the glucose. So every damn glucose molecule is reabsorbed in the beginning of the PCT itself. But important point is, look, so this is the PCT, no doubt. This is the PCT epithelial cells. Urine is coming like this. Okay, urine is coming down like this. In the urine, what is there, sir? Glucose is there. See, dekho, glucose. So glucose is getting reabsorbed into the cell only along with sodium. So glucose is like a girlfriend and boyfriend. Glucose and sodium, they are like girlfriend and boyfriend. Both goes together. Okay. See, this glucose and sodium, they are going into the cell. Okay, both they are going into the cell. So glucose is reabsorbed along with sodium. With the help of this transporter, there is a transporter. This transporter is called as SGLT2. Okay, so sodium glucose co-transporter. Sodium glucose co-transporter type 2. Okay. Now my question to you: are glucose is getting transported or not into the cell? Yes, the glucose is getting transported. So is it active transport, passive transport? You tell me, is it active transport, passive transport? Is it facilitated diffusion, or is it simple diffusion, or is it primary active transport, secondary active transport, or is it osmosis, or is it endocytosis? What kind of transport? Glucose is reabsorbed with sodium with the help of a transporter called as SGLT2. What kind of transport it is? Is it an active transport, passive transport? What do you think? Awais Khan, Vishnu, Yadav, yeah, Subhatra, you're all saying active, but you should be more specific. Please be more specific. This is an example of secondary active transport. Okay, this is an example of secondary active transport. Lifelong, remember one point. See, this is the golden point that I'm teaching you today. Golden point, because 100% this question will come up in your exam. So that's why I'm keeping here star. Okay, let me keep golden star. Okay, let's see. For example, see, the question that will come up in your exam is, see, SGLT, sodium glucose transporters. Doesn't matter type 1 or type 2, SGLT type 1, SGLT type 2. Wherever you see them, they're all examples of secondary active transport. So sodium glucose co-transport. The moment you see the word co-transport, whenever you see the word co-transport, doesn't matter sodium and glucose, doesn't matter sodium amino acid, sodium chloride. Okay, so the moment you see this word co-transport, definitely it is example of secondary active transport. By heart it. Or for example, if you see the word symport or antiport, okay, co-transport or exchanger, these are all examples of symport, antiport, exchanger, co-transport. All are example of secondary active transport. Okay, lifelong, remember this. Next thing, if you see the word gluts, G-L-U-T, the recent question which was asked in the exam, the recent 20 days back, wherever you see the word glut 1, 2, 3, 4, doesn't matter. Glucose transporters, glut, glucose transporters. They are all examples of facilitated diffusion. Okay, they're all example of facilitated diffusion. Okay, so now let's come back to our topic. So here, see, the glucose is getting reabsorbed from the urine along with sodium. Glucose is absorbed only with the sodium, along with the sodium. Okay, so this is an example of secondary active transport. Okay, now the glucose came into the cell. Now the same glucose, it is going back into the blood. See, it is going back into the blood with the help of
Glucose transporter type 2. Please make a small change here. It is GLUT2. It is GLUT2. Okay, with the help of GLUT2, here it is SGLT2. On this side, SGLT2. On the opposite side, on the basolateral side, it is GLUT2. So what is example of GLUT? GLUT is an example of facilitated diffusion. Facilitated diffusion is automatically passive, right? It's a passive. Facilitated diffusion means passive. Passive, no need of any energy. Okay, so GLUTs are example of facilitated diffusion, no need of any energy. So it's a passive process. So done. Completed. Okay, completed. One thing, glucose is reabsorbed with the help of SGLT2. MCQ, with the help of SGLT2, which is an example of secondary active transport. Okay, let me write here. Let me please take a note. SGLT type 2. Big words. It is an example of secondary active transport. Okay. So glucose is reabsorbed with glucose. Reabsorbed along with what? Sodium. MCQ in FMG exam. Okay, done. Now after this, the next question which I want you to know here is, see, sir, this is the afferent arteriole. Here is the afferent arteriole. Okay. Now the blood is coming like this. See, the blood is coming like this. Now here the plasma is going to be filtered, right? The plasma is going to be filtered. Okay, the plasma will be filtered. Now question number 1 is, sir, here in the blood, okay, the plasma, here the plasma. What is the plasma concentration? Can you tell me the plasma concentration? Our plasma concentration or osmolarity. My plasma osmolarity is 300 milliosmoles. This is normal. My plasma osmolarity is 300 milliosmoles. Okay, so let me write here clearly. Plasma osmolarity. Our plasma osmolarity is 300 milliosmoles. Now, students, let me tell you what is osmolarity in a simple way. Imagine there is a beaker. Okay, you are having a beaker. Okay, in that beaker there is pure water. Does it have any concentration? It's a pure water. Pure water. See, its osmolarity is 0. Its osmolarity is 0. It's because it's pure water. Nothing is there. Now you try to add sodium into it. Now you are adding some salt into it. Sodium chloride. Okay, you are adding what? Sodium chloride. As you are adding this solutes, see, look, you are adding solutes. Sodium chloride is a solute. If you add solutes, now what happened to the concentration of water? Now what happened to the osmolarity of the water? Osmolarity is a fancy word. Concentration, you can simply say concentration. So osmolarity from 0, it increases to 10. If you put more sodium chloride, okay, more sodium chloride or more, like, solutes, what happened to the concentration? The concentration may even go to the 100. So tell me, osmolarity is dependent on what? It depends on osmolarity, depends on solutes. Okay, osmolarity depends on solutes. My blood, right now I'm talking, sir, my plasma mein sodium, potassium, chloride, magnesium, calcium, so many things are there, so many solutes are there. So even my plasma is not a pure fluid. Plasma is not a pure fluid. It have a lot of solutes. Because of that solutes, the plasma is having some concentration. How much concentration? 300 milliosmoles. That's the concentration of the plasma. Okay, so plasma concentration is how much? 300 milliosmoles. Okay, okay. Now what happens? Now you should tell me. Look at this diagram and you should tell me. Sir, here is the nephron. This is the proximal convoluted tubule. Here I am showing the proximal convoluted tubule. Here is the glomerular capillary. Here is plasma. What is the osmolarity? 300 milli osmoles. 300 milliosmoles. Now here the filtration is happening. Here the plasma is there now. Plasma came here. Now you can't call it as plasma. Now it is urine. But anyway, here also osmolarity is 300 milliosmoles. Now look, in the PCT, how much water is reabsorbed? 70% of the water. Right now I'm talking about water. 70% of the water, I'm removing the water. I'm removing the water. So in the PCT, 70% of the water is reabsorbed. Now tell me, what happened to the osmolarity here? Osmolarity. In the PCT, osmolarity of urine. Now, what is the osmolarity of the urine in PCT? I am removing the water. What happened to the osmolarity of the urine in the PCT? Will it increase or will it decrease? What do you think? Will it increase or will it decrease? So everyone is saying increase, 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 but all of you are wrong. All of you are wrong. Maria, you are true. Maria Jan, you are true. See, because you should tell me how much sodium is getting reabsorbed. 70%. Okay, 70% sodium chloride is reabsorbed and the same amount of water is reabsorbed. So, solute and solvent, both the solute and solvent, both are reabsorbed in same proportion. Okay, you are removing the same amount of water and you are removing the same amount of solute. So there is no change in the osmolarity of the fluid, same 300. Okay, so that's the question which was tested many times. Okay, so look at here. So the urine ultrafiltrate in the PCT, it is isotonic to plasma. Isotonic means equal. It is isotonic to plasma. It is similar to plasma, that is 300 milliosmoles. Because you know the reason, because 70% of the solute is reabsorbed and 70% of the solvent is reabsorbed. Okay, same amount of ions and same amount of water is reabsorbed, so it is isotonic to plasma. Okay, now you understood. So in the PCT, here in the diagram I am showing you, look, array, in the PCT, this is the PCT, no, what is happening? First, 70% sodium chloride is reabsorbed, 70%. Wherever you go, I will follow. That Hutch dog. No, wherever sodium goes, water follows. So 70% of the sodium chloride is reabsorbed. So 70% of the water is also reabsorbed. So here the osmolarity remains constant, 300 milliosmoles. Okay. So now one more thing, tell me. First solute is reabsorbed, later solvent is reabsorbed. Any hormone is acting here. Do you require any hormone for the water reabsorption? No need of any hormone. Simple. Sodium reabsorbed followed by water reabsorption. So that's why, look here. In PCT, see, water reabsorption in PCT is not under any hormonal control. No need of any hormones. No need of antidiuretic hormone. Okay, no need of antidiuretic hormone. So that's why this type of water reabsorption is called as obligatory water reabsorption. Okay, obligatory means 100% it should happen. Sodium is getting reabsorbed, so water should reabsorb. So this is called as obligatory water reabsorption occurs in the PCT. True. Okay, obligatory water reabsorption. 70% of the water reabsorption occurs in the PCT. It is driven by solutes. Solute is reabsorbed, solvent is reabsorbed. Simple. So clarity. Hai or nahi hai? Do you have clarity or not? In PCT, urine is having same osmolarity to plasma. So there is no change. It is same. So know that one point. Chalo. Next, what else I want you to know is, look at this. Already I have explained here. Already I have explained this to you. Glucose and amino acids. How much percent they are reabsorbed in the PCT? 100% they are reabsorbed. You already know it. I have told you this is sodium SGLT type 2. SGLT type 2 is an example of secondary active transport. See, sodium is getting reabsorbed along with the glucose. Sodium is getting reabsorbed along with glucose. And the same glucose is going into the peritubular capillaries with the help of, I told you, GLUT2. With the help of GLUT2 here, SGLT2, here GLUT2. This, wherever you see the word GLUTs, they are example of facilitated diffusion. SGLTs are example of secondary active transport. GLUTs are example of facilitated diffusion. Now pharmacology integration, sir. Pharmacology integration, there is a drug which can block in pharmacology. Okay, anti-diabetic drug. There is a drug which will block the SGLTs.
The sodium glucose transporters can be blocked with the help of which drug? SGLT, sodium glucose. See, if you block this, glucose is not reabsorbed. If you block this, glucose is not reabsorbed. So glucose will be lost in the urine. If you block this, glucose is not reabsorbed. Glucose is lost in the urine. Can you tell me what is the drug? Can you what is the drug? They are SGLT2 inhibitors. Okay, in the next slide it is there. Look. Canagliflozin, dapagliflozin, empagliflozin. What are they? They are SGLT2 inhibitors. Okay, they are SGLT2 inhibitors. What they will do? They will cause the loss of glucose in urine. Okay, they will cause the loss of glucose in the urine. So urine is going to be, glucose is going to be lost in the urine. Okay, so that can be used in the treatment of diabetes mellitus. Okay, that can be used in the treatment of diabetes mellitus. Okay, SGLT2 inhibitors. Can you tell me what is the side effect of this SGLT2 inhibitors? Famous question in your FMG exam. Can you tell me if you use SGLT2 inhibitors, glucose is not reabsorbed? Okay, glucose is not reabsorbed. So glucose is lost in the urine. So glucose is going into where? Glucose is going into urine. So tell me, if glucose is going into urine, what is the side effect? If you have glucose in the urine, infections can occur. So that is urinary tract infections. Okay, urinary tract infections MCQ, tested MCQ. So SGLT2 inhibitors, side effect is urinary tract infections. Yes, Pawan. Pawan is the first one to answer. Yeah, Pawan Meena, you're true. Okay, infections, Maria, true. Rahul, Rekha, true. Next, and already I have told you something. Wherever you see the word co-transporters, sodium glucose co-transporters are example of secondary active transport. Don't forget. Okay, done. Next, what I want you to know is, let me show you one question. This is a little tricky question, but you should know it. The question which was asked in the FMG exam. Let me show you that. Let me copy this first. Copy. Try to answer this question, which I'm going to show you now. Paste. Yeah. Try to answer this. Identify the correctly matched pair of a substance with their renal clearance from the graph below. So students will be like, oh my God, what is this, sir? I can't understand anything. What is this graph? Oh my God. Don't worry. Simple. So first look. This is the x-axis. Always look what is there on the x-axis and what is there on the y-axis. Okay. Now, x-axis, I am talking about the parts of nephron. Here, parts of nephron. Okay. So this is the bound in space. Proximal convoluted tubule, distal convoluted tubule going into the urine. Now, see, there are 4 substances A, B, C, D. Now, look, this substance, all substances are getting filtered. How much? 100% substances are getting filtered. First, initially, substances are getting filtered into the Bowman's capsule. Okay. Now, this A substance, the substance number A, immediately coming to 0. Here it is 0, no? 0. This is 100%. Let's take this is 100%. Okay. Now, here it is 0. Here it is 100. Maybe this is 150. Maybe here it is 200. Okay. So, there is this A substance which is coming to 0 immediately. Okay. In the proximal convoluted tubule itself, in the initial parts of, in the beginning of the proximal convoluted tubule itself, that substance concentration becomes 0. Means all that substance is reabsorbed. All that substance is reabsorbed. Okay, its level almost came to 0. There is nothing in the urine. Now there is the substance B. Its level also, see, now it is coming 100% filtered, 100% filtered. But in the proximal convoluted tubule, almost in the proximal convoluted tubule, it's also coming to 0. And in the urine, there is nothing.
You can't see anything in the urine. It's a zero. It's a zero. There is third substance C, 100% filtered. Same 100 molecules is there in the urine. Okay, in the urine also, how much is there? Same 100 is there. In the urine also, same 100 is there. No change, which means it is not reabsorbed. The substance is not reabsorbed. Substance A is highly absorbed, highly absorbed. Substance B is also highly absorbed, but less than A. Now there is substance D. Look carefully. Substance D. 100% it is filtered, but in the urine you are having 200%. 200 molecules are there, which means this substance is secreted. Secreted means a new substance. Newly the substance is getting added. Now let me tell you what is that secreted. Some students will have a doubt. Dekho guys. So this is substance D. Right now I'm talking about substance D. This is glomerular capillary. Okay. This is Bowman's capsule. Okay, this is proximal convoluted tubule, loop of Henle. This is ascending limb of loop of Henle, distal convoluted tubule. Okay, like this. Now, guys, look here. Let me show, for example, here that substance D, it is filtered. Okay, how much filtered? 100 molecules are filtered. Okay, in the urine, how many molecules are there? 200 molecules are there. Sir, how it becomes 200? Because of secretion. See, from the peritubular capillaries, this substance is also secreted. So, newly, that D substance is also not only filtered. This is filtration. This is secretion. Newly, that substance D is getting added. So, that's why the number of D molecules are increasing. Okay. So, now based on this, who is A, who is B, who is C, and who is D? Now you have to know. Okay, can you tell me what is the answer? A, B, C, or D? Who is A, sir? Who is A? The substance is highly getting reabsorbed. Who is that? Glucose. Next, B. This substance is also getting highly reabsorbed. So its levels in the urine is almost zero. Almost zero. Its levels are almost zero. So that is, what is that? Almost that levels are also zero. Bicarbonates. Bicarbonates are also highly absorbed in the PCT. Okay, in the PCT, 80% of the almost bicarbonates are reabsorbed. So that's why in the PCT, see, it almost reabsorbed. And there is the substance C, not reabsorbed at all and not secreted. That is inulin. Inulin is a substance you should know. It is not reabsorbed and not even secreted. And the substance D is a para-aminohippuric acid. It is both filtered. As well as para-aminohippuric acid is secreted also. So that's why its level is high in the urine. So this is the answer. So such kind of question was tested once in the exam. Most of the students, they simply leave it. Array sir, we don't know what is this graph. It's a little confusing. Just left it. Okay. So you should know in the PCT, first glucose is absorbed. Maximum glucose is absorbed. Now, okay, just look at this diagram again. So look at this. So this substance A, from 100, it is coming to 0 immediately because reabsorbed. The initial part of the proximal convoluted tubule itself, everything is reabsorbed. So its level comes to 0. Bicarbonate, it gradually reabsorbed. Almost in the proximal convoluted tubule, 80% is reabsorbed. And in the urine, bicarbonates are not there usually. You are not losing the bicarbonates. So its level is also coming to 0. Okay, sir, tell me, do you understand this question or not? Point is, glucose is highly reabsorbed in the early part of PCT itself. Glucose anedi first part of PCT lone, like most of the glucose is reabsorbed. 80% of the bicarbonates are reabsorbed. Inulin is not reabsorbed. Para-aminohippuric acid is even secreted, filtered as well as secreted. So its level is more in the urine. It is going up. So do you understand this? So Rekha is saying it's clear. But what about the others? Satish, Abra. What about the others? Pranati, Ovais, Rajib, Maria. It's not insulin, inulin, not insulin, inulin, not insulin. Inulin is different. Insulin is different, not insulin, inulin.
Option B is bicarbonate. True. Option B is bicarbonate. What? Look. Okay, see this B. B is bicarbonate. This B is bicarbonate. Okay. So let me take this. Okay, anyway, it's pasted. Sorry, I forgot it's pasted already. So know this one MCQ. Now let me give you the MCQ which was asked in FMG exam. One more MCQ. Which of the following substance concentration decreases in, see, concentration word is important. Which of the following substance concentration decreases in PCT? Option A, B, C. Sodium concentration, chloride concentration, glucose concentration. Which of the following substance concentration decreases in the PCT? Now you tell me. Which of the following substance concentration decreases in the PCT? Sodium, chloride, glucose. Who will decrease? Fourth, option number D. All. Now you tell me. D, para-aminohippuric acid. PAH, para-aminohippuric acid. P for, that's like someone is asking, para-PAH means para-aminohippuric acid. So all, everyone is saying all gone, sir. So whoever are saying all, that's wrong. Why? Let me tell you. See, guys, this is this is glomerular capillary. Okay, na? This is the glomerular capillary. This is what? Bowman's capsule. Okay. Here is what? PCT. Listen carefully. This is PCT. Now, look. For example, how much sodium is filtered? For example, 100 molecules of sodium is filtered. 100 molecules of sodium. How many molecules of chloride is filtered? For example, 100 molecules of chloride is filtered. How many molecules of glucose is filtered? 100 molecules of glucose filtered. And how much water is filtered? For example, 100 molecules of even water is filtered. 100 ml of water is filtered. For example. So I can say, in one molecule of water, one sodium is there, one chloride is there, one glucose is there. So 1:1:1:1. So it's all 1:1:1:1:1. Okay. Now tell me, in PCT, that's the concentration. In one molecule of water, one sodium is there, one chloride is there, one glucose is there. Okay, 100 molecules में 100 glucose, 100 chloride, 100 sodium. One molecule of water में one sodium is there. That's a normal thing, right? Normal. For example, let's keep it as an example. Okay. Now tell me, in PCT, how much water is reabsorbed? Tell me. 70% water is reabsorbed. Okay, 70% of water is reabsorbed. So how much water is left over here? 30 molecules of water is left over here. 30 molecules of water. How much sodium is reabsorbed? 70% of the sodium is reabsorbed. 70% of the sodium is reabsorbed. So how much sodium is left over here? 30 molecules of sodium is left over. How many molecules of chloride is reabsorbed? 70 molecules of chloride. 70%, you know, 70% of water, 70% of sodium, 70% of chloride are getting reabsorbed. So how many molecules of sodium is left over here? Sorry, chloride is left over here. 30 molecules of chloride. Which means here also look, in every molecule of water, concentration, I am talking about the concentration. In every molecule of water, one sodium is there, one chloride is there. 30 molecules of water में 30 molecules of sodium है and 30 molecules of chloride है. So again, 1:1:1:1. But how many glucose is getting reabsorbed? How many glucose is getting reabsorbed? 100% of the glucose is getting reabsorbed. So there is no glucose left over here. Okay. So in one molecule of water, there is no glucose at all. Okay. So what is the answer? Now tell me, which substance concentration decreases? Which substance concentration decreases? Now tell me. In the PCT. What happened, guys? Zoom, is it working? My Zoom got blank. Yeah, it came back. So, which substance concentration decreases? Is it working? Yeah. Okay, my screen now. Yeah, glucose. Now you are telling. Yeah, now glucose concentration decreases. Now glucose concentration decreases. So that's the answer, sir. So PCT low in PCT may. Okay, in PCT, sodium concentration, glucose concentration is going to be same. Isotonic, isoosmolar, same amount of water, same amount of solutes are getting reabsorbed. So sodium concentration, glucose concentration is same, not changed. But glucose is 100% reabsorbed. So glucose concentration decreases. That's the FMG question. Okay, that's the FMG question. So answer is what? C. Done, sir. Okay. Now, after this, directly come to this slide. Sorry, not now, directly come to this slide. Okay, no, wait. So these images are there in your book. First tell me. 2 MCQs are there. These images are there in your book. I'm asking you. These images are there in your book or not? Those images are there in your book? Okay, they are not there. Okay, draw this. Draw this with me. 2 MCQs, very important. Draw this with me. If you is not there, draw this. This will help you to understand a lot of things in the base in the diabetes mellitus. Okay. Now, draw 3 nephrons. This is glomerular capillary. Glomerular capillary. Now, here is the nephron, Bowman's capsule. Okay. First nephron number 1. Nephron number 1. Second nephron. Here is the second nephron. Okay. This is the first nephron. First, look here. The concept which I am going to teach you. Sir, how much glucose you have in your blood? Can you tell me? That's a plasma glucose concentration. How much glucose is there in your plasma? What is the normal value, an average value? Tell me. 100 milligrams per deciliter. Deciliter means you know it, 100 ml. So can I say something like this? 100 milligrams of glucose is present in 100 ml. 1 deciliter means how much? 100 ml. So I am writing here 100 ml. So 100 ml of blood may 100 milligrams of glucose is there. So can I say something like this? 1 ml may. Okay, in 1 ml, how much glucose is there? 1 milligram glucose is there. 1 ml may 1 milligram glucose is there. Okay. 1 ml may 1 milligram of glucose is there. Okay. So every minute, how much glucose is getting filtered? Every minute. What is the normal GFR? Sir, 125 ml fluid. 125 ml fluid is plasma is getting filtered. So 125 ml may how much glucose is there? Each ml may 1 milligram. Each ml may 1 milligram is there. So 125 ml may how much glucose is there? 125 into 1. So how much glucose is filtered? 125 milligrams of glucose is filtered. Okay. So how much glucose is getting filtered? Every minute 125 milligrams. This is called as filtration load for the glucose. Okay. So what is the filtration load for the glucose? The filtered load for the glucose is 125 milligrams per minute.
Okay, so just wait. Yeah, here this is called as a filtered load. Filtered load. Filtered load means how much glucose is getting filtered. Okay, now look, in the PCT, all glucose, 100% glucose is reabsorbed. Your nephrons are designed in such a way, this 125 is nothing. This 125 is very small. So all the glucose molecules are reabsorbed. So any glucose is coming out in the urine in a healthy individual, no glucose. No glucose is there in the urine. All is reabsorbed. Okay. Now I'm changing it little bit. Okay. Look here. This is a diabetes mellitus patient. Now my patient is diabetes mellitus. He's having diabetes mellitus. So his plasma glucose. Look, plasma glucose concentration. How much? Maybe he is having 200 milligrams of glucose per deciliter. 200 milligrams per deciliter. He is having more glucose. He's a sugar patient. He is having more glucose. Which means, can I write something like this? 200 milligrams of glucose is present in, more glucose is present in 100 ml. So 100 ml में 200 milligrams of glucose is there, which means 1 ml में how much glucose is there? 2 milligrams. 1 ml में 2 milligrams of glucose is there. Now tell me. So what is his GFR? GFR is 125. But each ml में how much glucose is there? 2 milligrams is there. So what is his filtered load? The filtered load of glucose is, here he is keeping more glucose. So 250 milligrams of glucose he is keeping. 250 milligrams of glucose per minute. So how much glucose is getting filtered in the diabetic people? In this diabetic people, in this patient, diabetes mellitus patient, his filtered load increased. Okay. Now I'm telling you, see, sir, all boys are not same. So all nephrons are not same. All nephrons are not same. Okay. So if you, sir, most of the nephron, 99% of the nephrons, 99% of the nephrons, they can reabsorb this much. 250 also can be reabsorbed. But there are certain nephrons, they cannot reabsorb this much glucose. They cannot reabsorb this high levels of glucose. Okay. So for the first time, if your glucose concentration is this much, if you have this much plasma glucose, look, if you have this much plasma glucose, the filtered load also increased due to nephronal heterogeneity, because some nephrons will fail easily. They can't reabsorb. So some nephrons cannot reabsorb the glucose. So for the first time, some glucose molecules will appear in the urine. Okay, some glucose molecules will appear in the urine. Okay, so only some glucose molecules. So when for the first time glucose molecules will start to appear in the urine? When your plasma glucose concentration is 200. Some glucose molecules, for the first time, they will start to appear in the urine. So this 200 value is called as renal threshold for glucose. Renal threshold for glucose means, at the urinary threshold for glucose, how much? 200 milligrams. Okay, 200 milligrams per deciliter. If you have this much amount of glucose in your blood, if you have that much amount of glucose in your blood, now for the first time, glucose will start to appear in the urine. But most of the nephrons will reabsorb. Most of the nephrons, 99% of the nephrons, they will reabsorb the glucose. But some nephrons, they can't reabsorb this heavy load of glucose, so they will start to leak. Okay. So that's the question. Look here, that's the question. Say, if plasma glucose concentration, if it is becoming more than 200 milligrams per deciliter, glucose will start to appear in the urine. This is called as renal threshold for glucose. How much is that value? 200 milligrams per deciliter. Okay. Now the third image that I'm showing you. Okay, draw this third diagram. Draw the third diagram. Now my patient is having severe diabetes mellitus. Okay, look, glomerular capillary. Here is the Bowman's capsule. So based on this, you have to calculate certain things. Look, now he sees severe diabetes mellitus. Okay. Now his plasma glucose concentration, look, his plasma glucose concentration is how much? He's having 300 milligrams of glucose per deciliter. Okay, 300 milligrams of glucose per deciliter. That is 100 ml. Which means in every ml of plasma, how much glucose is there? 3 milligrams of glucose is there. 3 milligrams is present in 1 ml. So what is his GFR? GFR is 125. So in each ml, 3 milligrams of glucose is there. So 125 into 3, how much? 125 into 3, how much? Any idea? 125 3 into 3, how much? 375 milligrams. So what is the filtered load? How much glucose is getting filtered now? 375. See, all the 99% of your nephrons can handle up till this level. Up till this level, they can reabsorb. So God designed the nephrons in such a way. Okay, God designed the nephrons in such a way that up till this 375, most of the nephrons, even if you keep 375 milligrams of glucose per minute here, if you keep this much amount of glucose here, that glucose will be reabsorbed. Okay, so all 100% glucose is getting reabsorbed, almost like 100%, or you can say 99%, because some is getting lost. No, so more, you can say almost every glucose molecule is getting reabsorbed. Okay, almost everything is getting reabsorbed. Okay, so till how much you can reabsorb your nephrons? Most of the nephrons, 99%, okay, you can say 99.9% of the nephrons can reabsorb till this much value. Inta varaku reabsorb cheyagaltai. Okay, okay, inta varaku, like till this value you can reabsorb. But if you keep 376, that extra molecule, one molecule, that will come out in the urine. It cannot be reabsorbed. It cannot be reabsorbed. So what is this 375 value? The 375 value is the maximum your nephrons can reabsorb, the maximum glucose that your nephrons can reabsorb per minute, the maximum glucose that your nephrons can reabsorb per minute. This is called as a transport maximum for glucose. This value is called as what? Transport maximum. Okay, so what is the transport maximum value for glucose? 375 milligrams per minute. 1 minute की, okay, 1 minute को 375 milligram can be reabsorbed in the nephrons. Okay, so look at the explanation. See, if a filtered load of glucose, if it is more than 375 milligrams per minute, further glucose reabsorption will not occur. Okay, further the extra glucose molecules cannot be reabsorbed. So that value, just remember this value, that's enough. Transport maximum value 375. That's it. So based on this, I will, if you say, sir, it's clear. If you say, sir, it's clear, we understand, I will give you a question which was asked in the exam. Clear ante, if you say it's clear, I will give you the question. If you say it's clear, I will give you the question. Okay, even if it's not clear, just try. Look, now there is our patient, diabetic patient. He's a diabetic patient. He's a patient diabetic, diabetes mellitus patient. His plasma glucose concentration is 400 milligrams per deciliter. His GFR, glomerular filtration rate, is 125 ml per minute. Okay, 125 ml per minute. Calculate his filtration load of glucose, filtered load of glucose. Calculate his filtered load of glucose, and also calculate the amount of glucose lost in urine. Amount of glucose lost in urine. Okay, now calculate. The plasma glucose concentration is 400 milligrams per deciliter. GFR is normal, 125 ml per minute. Calculate the filtration load of the glucose and calculate the amount of glucose lost in urine. Glucose lost in urine. So for those students who are not good with the mathematics calculations, let's go one by one. Let's see. So, देखो guys, here is the blood vessel. Here is the nephron. Okay. Now tell me, what is the plasma glucose? Plasma glucose 400 milligrams per deciliter. Okay. In 1 ml में how many milligrams is there? 4 milligrams is there. Okay. What is the GFR? 125. So 125 into 4. So filtered load how much? Filtered load 125 into 4 how much? 500 milligrams per minute. Okay. So this much amount of glucose is getting filtered into the nephrons. This much glucose. So filtered load is how much? 500 milligrams per minute. Let me see who can answer. Okay. So 500. Excellent, excellent, excellent. All guys, yes, you are saying 500. Okay. So in this 500, your nephrons, how much they can reabsorb? Your nephrons is 500, 375 can be reabsorbed. That's the transport maximum. So how much glucose is lost in the urine every minute? 125. If 500 low, in this 500 375 is reabsorbed because your nephrons can do that. So 500 minus 375, how much? 125. So 125 milligrams of glucose is lost in urine. So you understand how the questions will come? So with this topic also completed. This graph is not needed. Just leave this graph. Just know this. How to calculate the amount of glucose lost. The questions will come in your ARISE exams. In your ARISE exam, such kind of questions will come. The other physiology faculty will give you such kind of questions. How to calculate. Such kind of questions will also show up in your exams, FMG exams also. That's why they will give you calculated based questions. GFR calculation, glucose loss. How much glucose loss? Calculations important. Good answer. So with this PCT, all important points completed. Yeah, Vishnu Yadav. Yeah, 125. Yeah. Take deep breath. Just give me 1 second, guys. 1 second. I need to just turn on the AC. Just 1 second. Okay. So PCT, all points about the PCT are completed. Okay. Next, now let's discuss about loop of Henle. Loop of Henle. After PCT, see here it's the PCT. This is PCT. After the PCT, what do you have? Sir, we are having the loop of Henle. This is the descending limb of loop of Henle. Okay. This is the hairpin turn of the loop of Henle. And here it is ascending limb of loop of Henle. Okay, there are three parts. There is a descending limb. Okay. And there is hairpin turn. Okay. And there is ascending limb of loop of Henle. Okay, sir. Now let's go one by one. Okay, let's go one by one. Now, in loop of Henle, draw the diagram with me. Or at least listen. Okay. Now, here, look. This is the cortex. The dotted line, above the dotted line is the cortex. Now, what do we have here? Sir, this is proximal convoluted tubule. Here it is the proximal convoluted tubule. Now, down here, what is this one? Sir, this one is the descending limb of loop of Henle. Okay. Okay. This is the descending limb of loop of Henle. It's coming like this. And this is the ascending limb of loop of Henle. So now tell me, where is the loop of Henle present? Loop of Henle, it is present in the medulla. This is all medulla. This is cortex. Okay, this is PCT. Okay, this is PCT. Now, what is the osmolarity of fluid in the PCT? 300 milliosmoles. The urine osmolarity, 300 urine. It is here, 300 milliosmoles. Okay. Now, God have created our kidneys in such a way. God have created our kidneys in such a way that in the medulla, if you are going deep into the medulla, what happens is, see here, cortex may osmolarity is also 300. But in the medulla, look, what is happening to the osmolarity? 400. 600, 800, 1000, 1200. Okay, so there is more concentration. So here, what is happening, sir? When you go deep into the medulla, osmolarity increases, concentration increases. And osmolarity means what? Here more sodium, here more sodium, here more sodium is there, more sodium is there, more sodium is there, which means more solutes are there. That's causing the concentration. Simple, right? Okay, so the point which I want you to know is, when we go deep into medulla, concentration or osmolarity increases. Okay, there is medullary hyperosmolarity. See, there is high osmolarity. Okay, there is high osmolarity, sir. Okay, done. Now, see what exactly happens. Now, first the urine comes here. Here it is 300, no? Now the 300 urine came here. 300. Now it is 300. Outside how much? 400. Now you tell me, sir, here this is more concentrated, right? Here there is more sodium, more sodium, more sodium. Wherever there is sodium, water goes towards the sodium. So now water is reabsorbed. Look, listen here carefully. Now what is happening? Water is reabsorbing, sir. Now pure water is getting reabsorbed because here more sodium is there. That is causing the water reabsorption. As you are losing the water, see, as you are losing the water, you are removing the water. So your urine will become how much concentrated? Now your urine will become 400. Now your urine is getting concentrated. Only water is reabsorbed, but not the solutes. Solutes are not reabsorbed. Only water is reabsorbed. So, okay, this 400 urine is coming now here. 400 here. Now, outside is 600 means here more osmolarity means more sodium is here. Osmolarity baita ikundi. Here more osmolarity means more sodium. Now, tell me what happens. That sodium will attract the water. Sodium will attract the water. Remember. So, now again further water reabsorption. Water is getting reabsorbed from the urine. Water is getting reabsorbed. So as you are removing the water, again here urine will get concentrated. Urine get concentrated because you are removing the water. Okay, so water is reabsorbed. Okay, now this 600 urine is coming down here. Okay, 600 urine is coming down here. Now outside it is 800. So it will attract the, here more sodium is there. It will attract the water. So further water reabsorption. So water, wherever there is sodium, water goes towards the sodium. So again, the urine is getting equilibrated. It becomes 800. So same thing happens, sir. When the urine is coming down, so urine is getting gradually concentrated. Urine is getting gradually concentrated because water is being reabsorbed. So now tell me, sir, this is a descending limb of loop of Henle. It is permeable to only solvents. It's permeable only to solvents, or you can say it's permeable only to water. Only water is being reabsorbed. Okay, in the descending limb of loop of Henle, only water is being reabsorbed. Okay, only water is being reabsorbed in the descending limb of loop of Henle. So as the water is being reabsorbed, the urine is getting concentrated. So how much urine is getting concentrated? The urine is getting concentrated to 1200 milliosmoles. That's the MCQ. Okay. So
in the descending limb of loop of Henle. Okay, that's why see the urine is concentrated. See, because the water is being reabsorbed. Okay, see the water is being reabsorbed. So gradually the urine is getting concentrated. So in the descending limb of loop of Henle, the urine concentration increases to 1200 milliosmoles. Okay, 1200 milliosmoles. Okay, so urine is getting concentrated, so it's called as a concentrating segment. So it's called as a what? Concentrating segment of the urine. The urine is getting concentrated, no doubt. Urine is getting concentrated. So look, these are the MCQs. So what are the important points about the descending loop of Henle? Only permeable to water. Any ions are getting reabsorbed? No ions are getting reabsorbed. It is impermeable to ions. It is called as concentrating segment of the nephron. Okay, it's a concentrating segment because it's concentrating the urine. Okay, that's it. This is not needed. Aquaporin 1 channel is not needed. Just that's it. Okay, so is that clear? Do you understand how the urine is getting concentrated in the descending limb of loop of Henle? Is that clear? So descending limb of loop of Henle is also completed. Okay, descending limb of loop of Henle is completed. So let me ask you one thing. Some questions you just try to answer them. Okay, sir, in descending limb of loop of Henle, okay, in the descending limb of loop of Henle, water reabsorption. Okay, water reabsorption in the descending limb of loop of Henle occurs via, you tell me, occurs via water is getting reabsorbed. Yes, water is getting reabsorbed via active transport, passive transport, facilitated diffusion, or simple diffusion. Anyone? So water is getting reabsorbed. Water is getting reabsorbed because sodium is there, outside sodium is there, that is dragging the water. Roshni is saying simple diffusion, simple diffusion. Jyoti is saying simple diffusion. Ovais is saying simple diffusion. Susil, simple diffusion. Oh my god. Gases undergo diffusion, not the fluids. Fluids cannot undergo diffusion. The transport is osmosis. The fluid movement is called as osmosis. Okay, water is getting like sodium is attracting the water, that is called as osmosis. Okay, right. You'll find out the answer in the given options. You'll find out the answer, best suitable answer. See, water reabsorption, right? Water reabsorption in descending limb of loop of Henle. Not only descending limb of loop of Henle, also in the PCT. What is that? It is osmosis. It's osmosis, sir. Okay, it's osmosis. Osmosis means water will move towards sodium. That is called as osmosis. Water will move towards sodium. That is called as osmosis. Wherever there is high sodium, water will move towards the sodium. That is called as osmosis. Simply remember that. Okay. So descending limb of loop of Henle. Hope they are, sir. Done. Done. Now after this, I will explain you about ascending limb of loop of Henle. Don't worry, I will explain you the ascending limb of loop of Henle. After that, I will leave you. Okay, after that, I will leave you. I have discussed with the management. Yes, class is also there on Monday. Monday is also there. So we'll go slowly only. I just don't want to give you so much trouble. Like, at a time. I will discuss about the ascending limb of loop of Henle and 2 disorders. I will discuss about 2 disorders. I will leave you. Okay, is that okay? Tell me. Yeah. Yeah. Even examiners play tricks. Your whole FMG exam, especially June attempt. Okay, whenever I think about the June attempt, it's all about tricks. Okay, the examiner will try to trick you. Okay, December attempt, the examiners will be like sages. Okay, December attempt. Okay, let's give the paper easy. June attempt, the examiner will be like psycho. Okay. Okay. Now, let's discuss about ascending limb of loop of Henle. Draw this with me. If you have white paper, draw this. Otherwise, just listen. Descending limb ho gaya, completed. Now look. This is the ascending limb of loop of Henle. Ascending limb of loop of Henle have
one thin part, the base is going to be thin, okay, and one thick part. This is the thick part of ascending limb of loop of Henle. Okay, this is the thick part. Okay, thin part as well as thick part. Now look, so here urine is how much urine? 1200 milliosmoles. This urine is coming like this, 1200 milliosmoles. The urine is going up. Now let me show you one epithelial cell here. Look, here is one epithelial cell. In the ascending limb of loop of Henle, I am talking about the epithelial cells. Now only I am showing one epithelial cell. Okay, this is one epithelial cell. Now on this epithelial cell, there is a transporter present. There is a special transporter present. Let me show it, give it some special color. And this is the question which was asked in the recent FMG exam, in the recent 20 days back. This is the question which was asked. Okay, I will tell you what is that question. Look, here is a transporter. There is a transporter. Now what is the transporter doing? So this transporter from the urine, here is the urine. Okay, it reabsorbs one sodium. Okay, it reabsorbs one potassium. Okay, it reabsorbs two chloride. Okay, okay, so sodium, potassium, two chloride molecules are getting reabsorbed. So what is the name of this transporter? This transporter is called as sodium, potassium, two chloride symporter. The moment you see the word symporter, which kind of transport? Secondary active transport. Don't forget. Okay, don't forget. Okay, co-transporter, symporter, secondary active transport. Now, listen carefully. Listen carefully. See, on the other membrane, this is the basolateral membrane, right? This is the basolateral membrane. This is the base. This is the base of the cell. This is the luminal membrane. This is the luminal membrane. This is the basolateral membrane. Now, look carefully. Sir, there is a transporter here. What it is doing? It is throwing 3 sodium out of the cell. Okay. And bringing 2 potassium into the cell. 2 potassium into the cell. Okay. And on the same cell, there are also, nature have kept here chloride channels. There is a one more channel here through which the chloride is going out. The chloride, see this chloride is going out, no doubt. And the sodium is also going out. So the sodium, it is going out like this. Okay. So sodium is coming into the cell and sodium is going out of the cell, no doubt. It's getting reabsorbed. It's getting reabsorbed. It's going into the interstitium. So sodium ko koi problem nahi hai. And chloride is also coming into the cell. Chloride is going out. Okay, chloride is going out, going into the interstitium. Okay. So who is having the problem? Tell me. So which ions are accumulating inside the cell? Which ions are accumulating inside the cell? So students don't this transporter is sodium, potassium, ATPase. Sodium, potassium, ATPase. Sodium, potassium, ATPase. Now tell me, which ions are accumulating inside the cell? Can you tell me? Which ions are accumulating inside the cell? It is the potassium. See, potassium is coming into the cell. Here also, look, potassium is coming into the cell. In both the sides, from both the sides, potassium is coming into the cell. Okay. So this is the question. So which ion concentration increases? Potassium ion concentration increases. Okay. So in the cells, which ions are going to accumulate? Potassium ions are going to accumulate. Okay. There is an importance I will tell you. So write one by one important points. One by one important points. Sir, what is the name of this transporter? इस transporter का नाम क्या है? Sodium, potassium, 2 chloride symporter. Where it is present? It is present in the ascending limb of loop of Henle. Okay, it's present in the ascending limb of loop of Henle. So now tell me, ascending limb of loop of Henle, this ascending limb of loop of Henle, it is permeable to water or is it permeable to solutes? Who is getting reabsorbed? From your urine, who is getting reabsorbed, sir? Okay. So ascending limb of loop of Henle is only, right, only permeable to solutes. So you are removing the solutes, you are removing the ions. Okay, you are removing the ions, which means when you remove the ions, when you remove the sodium out of the urine, what happened to the urine? The urine is getting diluted. Okay, urine is getting diluted because you are removing the these salts, right? You are removing the salts. So your urine gradually is getting diluted. So ascending limb of loop of Henle is diluting segment for the urine. So your urine is getting diluted, no doubt in that. In the ascending limb of loop of Henle, your urine, it will get dilute. Okay, it will get dilute. Okay, so gradually, see, from 1200 it is getting 1000, 800, 600,000, because what is happening? Continuously sodium is getting reabsorbed, chloride is getting reabsorbed, so sodium reabsorbed, so something like that. So the urine is getting diluted because you are removing salts, you are removing solutes. Okay, is that clear? Is that clear? That's why here I have given the ascending limb of loop of Henle. Look, the ascending limb of loop of Henle. Look here. So sodium is getting reabsorbed, potassium and 2 chloride, they are all getting reabsorbed. But which ions concentration increases? Potassium ions will accumulate. Potassium ions will accumulate. See, the urine is getting diluted. Okay, the urine is gradually it's going to get dilute. So that's why it is called as diluting segment. So done, sir. It's called as what? Diluting segment. Okay. Now, questions. Ascending limb of loop of Henle is permeable too. Ascending limb of loop of Henle is permeable too. It's permeable to only solutes. Only solutes are getting reabsorbed. That is sodium, potassium, 2 chloride. Only solutes are getting reabsorbed. Okay, only permeable to solutes, not to water. Water is not reabsorbed. Ascending limb of loop of Henle is diluting segment because the urine is getting diluted. Okay, everything is good. Now let me tell you the real important point. Okay, the real implication of the potassium. Look, see, now I have explained you. This is the descending limb of loop of Henle, and here is the ascending limb of loop of Henle. This is ascending, no? This is ascending limb of loop of Henle. Now you tell me, what is this? This is the epithelial cell. What is the transporter that is present over here? The transporter is sodium, potassium, 2 chloride. Let me write sodium, potassium, 2 chloride, importer. So now it is reabsorbing. You know, it's sodium, potassium, 2 chloride is getting reabsorbed. Okay, everything is good. But at the end of the day, which ion concentration increases inside the cell? It's the potassium concentration increases the cell. So lots and lots of potassium is getting accumulated. So at the end of the day, what happens is this potassium will again leak back. Okay, look. So the potassium will again leak back into the lumen. So look, the potassium cells are totally loading with potassium. So potassium will leak back. Okay. So who is leaking back? Potassium. Because of the potassium leakage, the potassium is giving the positive charge to the ascending limb of loop of Henle. So due to the potassium leakage, the ascending limb of loop of Henle is having which charge? Positive charge. Okay. So now the ascending limb of loop of Henle is having which luminal potential? Positive luminal potential. Positive charge is there because of potassium leakage. Potassium is accumulating. Potassium cannot go out. Potassium cannot go out. So potassium is again coming back into the ascending limb of loop of Henle continuously 24/7. Every second it is coming out, coming out, coming out. So because of this potassium, here there is positive charge. Okay. So what is the importance of this positive charge? What is the importance of this positive charge? See, divalent cations like calcium, Ca2 plus, and Mg2 plus, magnesium, it's a C2 plus, a lot of positivity. Now this calcium and magnesium are coming like this. Now tell me what happens. Can they go up? Can they go up? See, positive charges repel. Now calcium and magnesium, they cannot go up. So the calcium and magnesium, they are forced to be reabsorbed through the small gaps. So the calcium and magnesium, they cannot escape into the urine because here positive charge is there. Okay, so due to this positive luminal potential, the divalent cations like calcium, magnesium, they are forced to be reabsorbed through the paracellular route. Between the cells, there are small gaps. Through the gaps, the calcium and magnesium are reabsorbed. Now you understand how the calcium and magnesium are reabsorbed? Okay. Now you understand how the calcium and magnesium are reabsorbed? The same thing. Same thing. Here I have written, look here. I have written
ascending limb of loop of Henle, the potassium is getting accumulated. So because of that, which charge is there? Positive charge is there. So ascending limb of loop of Henle, just go through this once. Ascending limb of loop of Henle have positive luminal potential due to potassium secretion, which helps in the absorption of calcium and magnesium via the paracellular route. So calcium and magnesium are getting reabsorbed. Okay. Like, is it clear? How calcium and magnesium are reabsorbed? Now, what was the question which was asked in FMG exam? The recent 20 days back, the question which was asked in FMG exam is, look, see, the question is, look, guys, lifelong you have to know this because every doctor will use this drug. Okay, every doctor will use this drug. Let me tell you what is that. Every doctor will definitely use this drug. Okay, sometime definitely will use this drug. If you are a cardiac, like, you know, if you are a physician who is doing with the heart patients, cardiologist, every day, every minute also you will give this drug to the patients. Let me tell you what is that. Look, guys, can you tell me what is this transporter through which sodium, potassium, and chloride molecules are getting reabsorbed? What is the name of the transporter? You know it. It's a sodium, potassium, 2-chloride symporter. Okay, sodium, potassium, 2-chloride symporter. Where it is present? Present in the ascending limb of loop of Henle. Ascending limb of loop of Henle. Okay. Now, see, I am using some drug. Okay, I am using some drug. If I use the drug, what is the drug doing? The drug will come and block this transporter. Okay, the drug will come and block this transporter. What is the name of this drug? The drug is loop diuretic. Okay, it's called the loop diuretics. They're called the loop diuretics. Example, furosemide, Lasix, furosemide. Okay, furosemide, bumetanide, torsemide, these are all loop diuretics. So what these loop diuretics are going to do? Diuretic means what? Diuretic meaning, hey, it increases the urine volume. It increases the urine volume. How they are going to increase the urine volume? Sir, if you use this a diuretic X drug, the sodium potassium 2-chloride symporter is blocked. So sodium is reabsorbed. No, sodium is not reabsorbed. Chloride is reabsorbed. No, chloride is reabsorbed. So where the sodium is going? Sodium is going into the urine. Okay. So wherever sodium goes, even water follows. See, more sodium is going into the urine, more chloride is going into the urine. So water follows the sodium. Water follows the sodium. So what happened to the urination? More urination. Aha, okay. So if you block the sodium potassium 2-chloride symporter, sodium is not getting reabsorbed. Sodium is not getting reabsorbed. So sodium is going out. Chloride is going out. So wherever sodium goes, water follows. So more water is going into the urine. So what happened to the urine volume? Urine volume increases. So the moment you give furosemide, if you give furosemide, the patient is going to lose more and more water. The patient is going to lose more and more urine because no sodium reabsorption, no chloride reabsorption. Okay, you understood? So what is this drug? This question which was asked, loop diuretics acts on. Tell me, loop diuretics act on ascending limb of loop of Henle. Loop diuretics inhibit. Okay, loop diuretics inhibit sodium, potassium, 2-chloride symporter. If you inhibit the sodium, potassium, 2-chloride symporter, sodium is not reabsorbed, chloride is not reabsorbed. So sodium and chloride are lost in the urine. Wherever sodium goes, water follows. So more urination. That's it. More urination. Done, guys. Second implication. The same thing.
let me teach you in a different way. In a different way, how they can ask you question is, look, what is this transporter? You know, it's sodium potassium 2 chlorides importer here. The sodium potassium 2 chlorides importer, now it is blocked. You blocked it. You blocked it. Okay. Now do you think potassium is going into the cell? Sodium is not going into the cell. Chloride, sorry, just wait. Sodium, potassium, 2 chloride. Are they going into the cell? No. See, potassium from this side, from this side, potassium is not going into the cell. So, do you think intracellular potassium concentration increases? No. So, intracellular potassium concentration decreases. So, when you use a drug called as a loop diuretic, see what is happening. When you use the drug called as a loop diuretic, intracellular potassium concentration decreases because potassium is not getting reabsorbed. Not getting reabsorbed. So intracellular potassium concentration decreases. Now, do you think potassium will leak out? No. So potassium is not leaking out. So do you think here positive charge is there? No positive charge. Positive charge either nahi hai. Now positive charge is not there. Okay. Now if the positive charge is not there, do you think calcium and magnesium are they reabsorbed? No. Calcium and magnesium are not getting reabsorbed. Now calcium and magnesium, as there is no positive charge, this calcium and magnesium will simply escape and it will come out in urine. So in urine, what you will see? You will see calcium and magnesium. So that's the reason why they will tell you in your pharmacology, what they will tell you. If you use the loop diuretics increases calcium loss. Loop diuretics loop out the calcium, they loops out. Calcium means they will remove the calcium out of the body, not only calcium, but also magnesium. So calcium and magnesium will be lost out. Calcium and magnesium is going out. Now you understand? If you use furosemide, the loop diuretic, they will remove the calcium out of the body because that positive charge is lost. That positive charge, potassium positive charge is lost. So that's the side effect. This is side effect of loop diuretics. Side effect of loop diuretics. Okay, side effect of loop diuretics. Okay, calcium is going out. Okay, calcium is going out in the where? Calcium is going out where? Calcium is going out into the urine. Calcium is going out in the urine. So that calcium, now more and more calcium is getting in the urine. So now there is a chance that this calcium will precipitate in the kidneys. The calcium can precipitate in the kidneys or it can precipitate in the ureters, can lead to formation of stones. So more and more calcium is there in the urine. So more calcium is present in the urinary fluids. So that can lead to the stone. So the side effect of loop diuretics is nephrolithiasis, stone formation. Okay, so that's it. So ascending limb of loop of Henle, integrations completed. Ascending limb of loop of Henle, integration completed. Okay. Now you tell me one question. Sir, direct questions. Ascending limb of loop of Henle, is it permeable to? Is it permeable to water or solutes? Please guys, for me, I am like, yes, of course, I know you are also working hard. I'm also working hard. So please satisfy me. Ascending limb of loop of Henle is permeable to water or solutes? Solutes. Okay, good. Ascending limb of loop of Henle, is it diluting the urine or concentrating the urine? Is it dilating the urine or concentrating the urine? It is diluting. Ascending is diluting the urine. Okay, ascending is diluting the urine. Okay, good. Sir, in ascending limb of loop of Henle, which transporter is present on the luminal membrane, luminal side? Which transporter is present? There is one transporter which is reabsorbing 3 ions. What is that? Sodium, potassium, 2 chloride. Rasur is saying sodium, potassium, chloride. No, the number 2 is important because in one exam they have asked. It's not sodium, potassium, chloride. Sodium, potassium, 2 chloride is important. Sodium, potassium, 2 chloride is important. Okay, done. Sodium, potassium, 2 chloride is important. I'm giving you the statement. Sodium, potassium, 2 chloride is important is an example of facilitated diffusion. True or false? Symporters, co-transporters are example of. They're all example of secondary active transport, not facilitated diffusion. They're all example of secondary active transport.
Okay, sir, in the ascending limb of loop of Henle, in the epithelial cells, of ascending limb of loop of Henle, which ion concentration increases? Which ion concentration increases? Normally, potassium concentration increases. Good, good. In ascending limb of loop of Henle, which luminal potential is there? Which charge is there? In the ascending limb of loop of Henle, which charge is there? Which charge is there? Positive charge. Sir, in the ascending limb of loop of Henle, the positive charge is responsible for the reabsorption of. That positive charge is responsible for the reabsorption of calcium and magnesium. Sir, what is that drug? That acts on the ascending limb of loop of Henle and blocks the sodium potassium 2 chloride importer? What is that drug which blocks the sodium potassium 2 chloride importer? Loop diuretics. If I use the loop diuretic, tell me, if I use the loop diuretic, more calcium reabsorption will occur, right? If I take the loop diuretic furosemide, more calcium reabsorption will occur. No, calcium is not going to be reabsorbed. Calcium will be lost in the urine. That can form stones. Okay, calcium is going into the urine in the renal pelvis. It can precipitate, the calcium can precipitate and forms stones. Okay, in the renal pelvis, the calcium can precipitate and form stones in the renal pelvis or the ureters or sometimes in the urinary bladder. The calcium will precipitate in the urine and forms stones. Nephrolithiasis. Okay, yeah, calculus. It can form the calculus in the ureters also. Okay. Now, just tell me, sir, there is a baby. In this baby, this transporter, sodium potassium 2 chloride importer. Okay, this transporter, sodium potassium 2 chloride importer, it is not functioning from the birth. That transporter is not functioning from the birth.
Now, the same thing. Same story, sir. Look here carefully. This is the epithelial cell. Now, this is the transporter, sodium potassium 2 chloride importer transporter. But this transporter is not functioning from the birth. Just like loop diuretic. If you use the loop diuretics, it will not function. This transporter not functional. Mutated by birth. So what is that syndrome called as? That syndrome is called as Bartter syndrome. What is that syndrome called as? Bartter syndrome. That syndrome is called as a Bartter syndrome. So in Bartter syndrome, who is not functional? Sodium, potassium, 2 chloride importer. It is a defective by birth. Defective by birth. It's a autosomal recessive disorder. Okay, autosomal recessive disorder. Bartter syndrome, autosomal recessive disorder. This transporter is not functioning. So now what are the clinical features, guys? Can you tell me what are the clinical features? Same. If this is not functioning, it is looking similar to loop diuretic usage. If you use loop diuretic, same transporter is inhibited. In Bartter syndrome also, same transporter is defective. So I can say something like this. So Bartter syndrome resembles. Means clinical feature resembles loop diuretic overusage. Because in both the conditions, if you use the loop diuretic, same transporter is inhibited. In Bartter syndrome also, same transporter is defective. So this is the question which was asked. Bartter syndrome resembles loop diuretic overusage. Okay, done. Okay. Now, I will ask you one question, you tell me. Sir, imagine there is a baby. Okay, you are in the pediatric ward. Imagine there is a baby with a Bartter syndrome. He is having Bartter syndrome. Now tell me, he will be having more urination or less urination? If a baby is having Bartter syndrome, sodium potassium 2 chloride importer is not functioning. So he will be having more urination or less urination? Bartter syndrome. Tell me. Yes, of course. More urination, Jyoti. He will be having more urination because sodium potassium 2 chloride is not functioning. Sodium loss. Sodium is going out of the body. So
more urine will go. Sodium is going out of the body. Sodium is not getting reabsorbed. Sodium is going out in the urine. More water will go out in the urine. So Bartter syndrome babies will suffer with. Look, come to the slide. You just see in the slide. It was given in your book. Okay. So Bartter syndrome, autosomal recessive disorder. I have told you it resembles what? Loop diuretic overusage. The patient is going to have polyuria because the transporter is not functioning, sir. Okay, the transporter. This transporter, okay, this transporter, that sodium potassium 2 chloride importer, it is not functioning. So sodium not reabsorbed, chloride not reabsorbed, they are going out in the urine. So water also follows the sodium. So more urination will increase. So that's why the baby is going to have polyuria, more urination, that will lead to the dehydration in the baby. So because of the severe dehydration, the baby is going to not grow properly, failure to thrive. The baby is not growing. As the patient is losing the urine, see, as the patient is losing the fluids out of the body, polyuria, urine is going out. So what happened to his BP? Sir, he is losing the fluids out of the body, sir. He is losing the blood volume. Simply, if you are removing the water out of the body, what happened to the blood volume? Blood volume decreases, so BP will decrease. Maybe normal, but most of the times the baby is going to have decreased BP, but never increase. So for your medicine questions, remember, Bartter syndrome is a disorder of hypotension. Hypotension. It's a medicine integrated topic, okay? So Bartter is a hypotensive disorder. It will come in pediatrics also. It's a hypotensive disorder, not hypertensive. Hypotensive disorder means BP is going to be decreased but never increase because the patient is losing the sodium. Sodium is going out. Water is going out. That will lead to dehydration. That will lead to decreased BP. So hypotension. Okay. As the baby is getting dehydrated so much, if you look at the anterior fontanel, the anterior fontanel in the frontal area, in the frontal bone area, now the water is not there in the body. The baby is getting dehydrated. So anterior frontal, the anterior fontanel is also dry. Okay, dehydrated. So there is sunken. Sunken means it's getting dip. Okay, it's going down. So there is sunken anterior fontanel because of the dehydration. Okay. Now I said you, the Bartter syndrome, it resembles what? It resembles loop diuretic overusage. So Bartter babies also lose what? Calcium. They are losing the calcium, increases the calcium levels in the urine. Urine calcium levels are increasing. So that will form kidney stones. Okay, that will form kidney stones. So calcium is going out of the body. When you lose when the baby is losing the calcium, that will cause rickets, renal rickets. Because of the kidney problem, the baby is having rickets, renal rickets. Okay, so that's it. These are the points which I want you to know. Now in Bartter syndrome, one point, the last final point is these babies, the chloride channels in the cochlea, are also defective. So that can cause deafness in the baby. Okay. So one integrated thing with the medicine, Bartter syndrome, autosomal recessive disorder. The baby is going to be having dehydration, failure to thrive, polyuria, kidney, the baby can have stones, the baby can have sensory neural deafness, and Bartter is a hypotensive disorder with a sunken anterior fontanel. Okay, so Bartter is done. Bartter syndrome completed. Okay, Bartter syndrome is completed. So shall we stop for today? Shall I give you a break? Will they survive? Yeah, of course they will survive. If you do intervention, if you give fluids, yeah, definitely they will survive. There is no doubt in that. If you identify and if you give simple, the main problem is what dehydration. Give normal saline. Okay, keep them hydrated. They will survive. Anterior fontanel here it will be there. If the baby is getting dehydrated, from the body you are removing all the water. You removing the water, the baby is getting dehydrated. So you can see the dip here because the fluids are getting less, right? So you are seeing a dip in this area. Okay, because you are removing the fluids, so dehydration. So tomorrow, shall we continue tomorrow? So I'm sharing the PDF. Okay, anyway, on Monday also we are having class, right? On Monday also we are having class. So let's go slowly only. I thought only 4 days class is there. I thought only the class is for 4 days. So I'm going little fast, but if there is class on Monday also, I will go slowly only. Okay. And so much time is there. Okay. Bye bye. See you guys. I'm sharing the PDF right now. You ask the management to share with you. Bye bye. Bye bye, guys. Bye bye. Sahit Kumar. Yeah, we can do that, but yeah, we have to go according to the majority, right? Majority of the students like already tired because today we have done respiratory, the super highly conceptual thing, all those things, and renal. So people are little tired. That's why. Yeah, now I will share renal also. Now I'm sharing. See in front of you. Now just wait a sec. Just wait a sec. This is the renal, right? Renal share, export and send. Guys, don't go through each and every topic. So even renal have a lot of slides. I'm not deleting all those slides. There will be a lot of slides that will be there in the renal. You don't delete them. Okay, don't go through each and everything. Whatever I'm teaching, only go through them. Arise Andy. Da. Okay, sure. Bye bye guys, see you tomorrow. Bye bye.